Alrighty, I think we're going to go ahead and get started. I don't know about all of you guys, I know people are probably a little tired from having some fun last night, hanging out with your colleagues and stimulated by all of the talks. And I just want to thank all of you for being here. It's been really fun to hear that energy in the room. We have a great day planned for you today. So, like I mentioned, I hope you were also able to enjoy the poster presentations and colleagues. So before we get started with our agenda, just a few housekeeping notes. Again, we encourage all of you to visit the exhibitors for supporting this event. They're located where you checked in and grabbed breakfast this morning. This year actually marks the 15th year of the ICOS. Throughout the next today is the last day 3 of 3. And you will see our social media ambassador and photographers capturing this landmark here. And we encourage you to share your post and post your own highlights. And that'll be really awesome. And without any further delay, I think I have the distinct honor to introduce our keynote speaker, Dr. Alex Lyon. And he is well known to the ICOS community and really doesn't need any introduction, but I will try. He's a cardiologist and a clinical lead for the cardio-oncology service at the Royal Brompton Hospital since it was created in 2011. And the service was awarded a Gold Cardio-Oncology Center of Excellence Award by ICOS in 2021. Alex, more than anything, I think personally is a friend and a mentor and a lovely colleague. So he is an executive board member of the ICOS and was a co-chair for the first European Society of Cardio-Oncology Guidelines. He is an immediate past chair of the ESC Council of Cardio-Oncology and the past president of the British Cardio-Oncology Society and is currently the deputy editor of European Heart Journal. Where he leads the cardio-oncology team. He's published over 250 papers and an index of 69. So if that's not impressive, I don't know what else is. But it's without further review. Thank you.
Thank you, Suma and Adam. I think everyone should just have a moment to thank Suma and Adam for what amazing we just expecting. Okay. So when Suma, I think it was, contacted me about 6 months ago, said, Alex would like you to give a talk on checkpoint inhibitors of myocarditis. I said, okay. It's just a common topic. We've spoken about it a lot. We need to make this different. And so what I've decided to do today is not actually just give a standard talk on checkpoint inhibitor myocarditis, because I think you've heard a lot about it already in this meeting. But I'm going to challenge us as a community on some of the concepts that I think we all have taken for granted, and you hear them repeated in articles and in lectures. And just take a step back and think about where we should be going with this field. So I hope this will be interesting and maybe provocative as well. Those are my disclosures. So this, I think, comes from the perspective of the checkpoint inhibitor myocarditis. When you hear about this topic, there's a lot of regular things that are said. But sometimes we need to take a step back and then look at the data in a different way so that we can make new changes. So it's sort of being able to stand out, think about this in a different way. So this is how I'm going to approach this talk. So checkpoint inhibitor related myocarditis is rare, has a high mortality, 25 to 50%. Almost every article on this topic says that in the first sentence or two sentences. Patients with checkpoint inhibitor myocarditis should receive high-dose intravenous prednisolone. Patients with checkpoint inhibitor-related myocarditis and cardiogenic shock should get mechanical cardiac support. Restarting checkpoint inhibitors after an episode of myocarditis is contraindicated. And maybe the most provocative is checkpoint inhibitor myocarditis is the most important checkpoint inhibitor-related adverse cardiac event. So let's start with the first one. And it's morning, you've all got up and come here, so I just wanted to ask you as an audience a question. So how many of you have looked after a patient with checkpoint inhibitor myocarditis in the last year? In the last 12 months, put up your hands and give up. So we're a select, and keep your hand up. So we're a selected audience because we get referred them, but the point is that in this community is rare. Now, if your patient died, keep your hand up. If your patient survived, take it down. So there's a few hands up, but I don't think that's 25 to 50% of the hands that were up a minute ago. So is this really true? So I've gone back and looked at some of the studies, starting with the very first one, Johnson and Mosley, New England Journal, if you remember. And if you look at a number of cases and then the frequency at which this was reported based on the denominator, which is the number of people treated with checkpoint inhibitors. And you start off with very low or rare numbers, and then over time, the percentages start to increase, but they're still relatively low, which is about sort of somewhere between 0.5 and 1.25%. So I think it's still moderately rare. But if you look at the mortality in the reported series, it's completely changed. So in those early series, it was up at this 25 to 50%, which is what was repeated the whole time. But if you look, two of them, the pharmacovigilance database data, they're basically looking at the same data set. And that's a bias by people reporting it into that pharmacovigilance base. Whereas the two most recent studies, one from our centre at the Brompton and one from Andrew Noria in Brigham, shows a much lower mortality, which really was reflected in what I saw here with the number of people reporting that they've had a case that's died. So whilst clearly there is a mortality, I don't think it's 25 or 50% anymore. And we need to recognise that when we're writing articles or giving talks. So I think that's where the mortality is probably going to lie, somewhere, I suspect, in the 5% or 2 to 5% range. And then you could say, well, are these patients rare? Depends what your denominator is, but these are all the current FDA or EMEA in Europe licensed indications for checkpoint inhibitors. And as you know, the number of indications is escalating every year. We get more trials. And this paper, which is actually already 3 to 4 years old, just was looking at the number of patients in North America with cancer who would be eligible for a checkpoint inhibitor. And based on the trial data and the number of patients who are being diagnosed with different cancers, they could create a mathematical model that was about 35 to 40% of all cancer patients in North America would be potentially being treated with a checkpoint inhibitor. And when you then do the maths based on your number of new diagnoses of cancer a year, it works out at about 234,000 people who have lived. That's why some of these pharma companies are doing very well. And of course, that then, depending on what your percentage rate of the checkpoint inhibitor myocarditis would say across the US, you're going to get somewhere between 1,500 and 2,500 cases, which you can then work out per state or per cancer center what that will equate to based on how many patients your center is starting on checkpoint inhibitors every year. So I suspect, depending on how you view this, it might be considered relatively rare, but it's not extremely rare because most centers are going to be getting few cases a year. And I work at the Brompton, which is next door to the Royal Marsden Hospital, a very busy cancer centre with lots of patients being treated with checkpoint inhibitors. And at the moment, we get about sort of 10 to 15 cases a year being referred. So next topic to discuss is, should all patients who get this diagnosis be treated with high-dose intravenous methylprednisolone? So as I think some of you know, I was involved in this ESC guideline, and we spent a long time on each of these different algorithms. There were 32 members of the task force, and every decision has to have at least 75% or more of the task force agreeing before a class of recommendation and its level of evidence is finalized. And we give this management algorithm, which says that if you're diagnosed with a checkpoint inhibitor myocarditis, you should be admitted. If you happen to be an outpatient still, that you should be admitted to a bed where you have continuous ECG monitoring. So that's usually in a cardiology environment rather than oncology. And that you should get treated with IV methylprednisolone, 500 milligrams to 1,000 milligrams per day for the first 3 days. And that's a class 1 recommendation. And that was based a lot on this study, which was a really important observational study where several groups around the world were pooling our data on checkpoint inhibitor myocarditis cases, and we contributed ours, and this was led by Tom Leland. And if you take the conclusion of this study, it's that if you are treated with a low dose of oral prednisolone, which is in the red group, and if your treatment is delayed by more than 72 hours from starting, so you have a low dose oral treatment and it's delayed, then your rate of MACE is about 80 to 90%. And these MACE were cardiac arrest, cardiovascular death, cardiogenic shock, and complete heart block requiring emergency pacing. So these were not mild things, these are severe endpoints. So 90% in the people getting oral steroids at a low dose. Conversely, if you take the solid blue line, those are the patients getting the high dose intravenous methylprednisolone, their MACE rate was 0. So it was very impressive. Now, this, of course, is observational. And when you look at what happens and how those cohorts were managed in their different centers, there was a great heterogeneity. The time from the last dose of the checkpoint inhibitor to being admitted, the time to getting diagnostic tests, that could be MRI, but was not always. About half of the patients had an endomyocardial biopsy. So there's a lot of variability in how these patients were managed. And this, I think, we should always look at as an observational study rather than a randomized controlled trial. So I want to give you a concept which is only recently started to be discussed properly, which is that, like many cardiac diseases, and I take myocardial infarction as a good example, checkpoint inhibitor myocarditis comes in a whole range of flavors or severities. So we all think, oh my goodness, it's cardiogenic shock. This is a really severe illness. We need IV methylprednisolone, like the fire brigade, to douse this down as soon as possible. But equally, clinically, we see very mild cases. And I get cases which are essentially picked up incidentally because a patient presents with another checkpoint inhibitor-related complication, colitis, dermatitis. And the oncologists in the panel of assessment do a troponin. And then the troponin comes back up, and then it opens up a pathway to say, does this patient also have myocarditis as well as the other complications? So with that sort of context, should we be treating everybody the same? And so in the ICOS definitions of cardiovascular complications, checkpoint inhibitor myocarditis, there's definitions of severity. So you can start to sort of define and describe cases as to severe or fulminant when they've got cardiogenic shock, through to the milder cases. And Angina and her group at Brigham have published this paper in JACC Cardio-Oncology. And if you explode the negative cases and say, well, I had 124 cases of myocarditis. 28 of them were severe, so that's approximately a quarter, but that means 3/4 were not severe. And what were their outcomes? And on the bottom left graph, you can see in the red group, the severe cases had a significant rate of major adverse cardiac events, but actually the milder cases, it was much less. And they reported the cardiovascular mortality, and that reflects this. What's interesting, not the topic for me to discuss, is actually the overall mortality ended up being pretty even across the severe and the less severe cases, suggesting there's still the background oncology mortality that is a problem. But what I'm trying to say here is, do we really think that everybody we see with this diagnosis should be hit with the high dose of Iakobishvili? So if you're in a debate, you'd say, well, we've done this at the Brompton, we've had 33 cases and nobody died, 0% mortality. And we've got this observational study to report, to support this approach. But against it is these mild cases. Now, what's a mild case? Maybe these ones with relatively low troponin elevation, because that's a marker of injury, clinically not complicated, so they don't have heart failure, arrhythmias. And as I say, what are all being picked up either asymptomatically or incidentally when they're presenting with another complication. And then we've got to take into account that there is a morbidity of having steroids, because if you start these high doses, normally the tapering takes about 2 to 3 months. So for survivors, there's going to be a legacy on their bone health and on their metabolic health. But maybe more concerningly, there are some emerging data that patients who have checkpoint inhibitor complications, not just myocarditis, anything which requires steroids, that those patients have a worse oncology outcome. Because in essence, you're switching off the treatment. So if the treatment has already had all its beneficial effects, that's not a problem. But if you are actually switching off a treatment that could still be providing ongoing clinical benefit, and our neighbours at the Master have actually got some data that they presented at conferences, it's not published yet, showing worse outcomes in their melanoma patients who've got high-dose steroids. So this isn't just a benign sort of treatment option. So my proposal is that what we need is a randomized control trial of the standard guideline approach versus a lower dose steroid option for the milder cases. And obviously you need to have a patient that's got a confirmed diagnosis. We've got to define what is mild, but I think it's hopefully relatively obvious clinically. And then they could be randomized to intravenous methylprednisolone, the standard treatment, versus an oral low dose with a rapid tapering, and then look at outcomes. And obviously we'd look at cardiac outcomes, but I think we'd also want to look at progression-free cancer survival outcomes to see what the overall benefit is for our patients. So what about the next topic? So should patients who do present the most severe ones all receive mechanical cardiac support? So again, if we go back to the algorithm in the guidelines and come over to the right-hand panel, in patients presenting with severe and fulminant myocarditis from checkpoint inhibitor therapy, obviously they should be admitted to an ICU and have optimal cardiovascular treatment, including mechanical cardiac support. So how does this conversation go in reality, which is, oncologist phones cardiologist. I've got a patient with checkpoint inhibitors, their troponin is 3,000, they're really unwell, can you admit them? Cardiologist phones intensive care colleague, there's a patient with metastatic cancer next door at the cancer centre in cardiogenic shock from checkpoint inhibitors, and we admit them to the intensive care unit. And of course, the intensive care consultant's going, patient's got cancer. What are you doing? So you've got to have the conversation. But I think what's most important here is the context in the oncology. And there's cardiologists in the world of cardio-oncology, and I teach my fellows this, you've got to read the oncology trials. Get a feel of how important the impact of the treatment you're looking at, so that when you see the complications, you've got a context. So I'm going to do an experiment, which I've done with my team before on this, which is I want you to think that you've got a 50-year-old lady who is presented to you with checkpoint inhibitor, myocarditis, cardiogenic shock, low cardiac output state, and is very unwell after her second cycle of checkpoint inhibitor therapy. 50-year-old woman, married, 3 kids. She's got metastatic melanoma. So she's got a 52% chance of being alive in 5 years. And I think that would be pretty reasonable to take this lady to the intensive care unit, because the odds that she's been cured is very high in reality from a previously lethal disease. She's got metastatic non-small cell lung cancer. So her survival is 30%, 3 years. So if you've got the 3 of them, 2 are dead, 1's going to survive. In fact, the curves start to look like they're coming together at the end as well. So it's not that it's curing, it's just helping some delay progression. I think, she's 50, got kids. Would you put her on mechanical support? I think that's a real difficult one. What about metastatic triple-negative breast cancer? She's 50, but she's only got a 19% chance that she's going to be alive in 4 years. And again, looking at the curves, very minimal separations. There is some benefit, but absolute benefit is pretty low. Maybe that lady wouldn't be speaking to the intensive care units to put her on mechanical support. But if she had early invasive triple-negative breast cancer, she's got a 90% survival. So it's all the context, isn't it, when you're speaking to the ITU team and speaking to the oncologists. Next topic, which was touched on yesterday, should we consider that a checkpoint inhibitor myocarditis is an absolute no-no to re-challenge or restarting treatment? And I think actually, in my clinical practice, this is one of the hardest incisions that we face. It's difficult managing the patients, but it's even harder when the oncologist says, look, cancer's progressing, you might restart. So I thought I'd give you some of the ideas from my experience on this. So I went back and looked, and we've done it 3 times at the Bronson, and 2 of the patients are still alive, and 1 died of aggressive metastatic melanoma. I think the key again and again is the conversation between cardiology and oncology, and an MDT decision. You should never have one individual shouldering this decision, because it's clearly got quite a few risks. Again, think about the oncology trial data. What is the context of what we're trying to achieve? Is it going to be take someone with a metastatic disease and actually curing them where the benefit is greatest versus just potentially prolonging life by a few months, which, while very valuable, may not be worth this potential risk? And obviously, what other treatments are available for the patient if they were not having any checkpoint inhibitors? I think I feel comfortable if it's a mild case, whereas someone who's presented with pulmonary cardiogenic shock, I think no one would be considering it. You need to have a new baseline to ensure that there's no active inflammation. Currently, you have only treated the first episode. You want to be absolutely certain the inflammation is extinguished. And then you've got to educate and consent the patient, both in terms of the risks of recurrence. We don't know the answer to this. We take data from re-challenging other checkpoint inhibitor-related adverse events that it's somewhere between 30 and 50% odds of recurrence. It's not 100%. And these are generally mild cases, so therefore they may not be familiar with the symptoms. You've got to really brief them on their symptoms and recognize. If they've had dual checkpoint inhibitors, you never give 2 again. It's always 1, and ideally a different one from the combination or single drug they've had before. And some form of monitoring, although you can't keep them in hospital for every day for the first 3 or 4 weeks. So in reality, it's using sensible monitoring when they come in. And I think this is a topic where we need an ICOS registry, because these are rare cases, even in the biggest centers. So the only way we're going to learn is by pulling the data together and having a registry that can share the experience, what were the indications, what were the decisions, what were the outcomes, so that we can get this right. But I think my take home is so that we can re-challenge patients. It's not an absolute indication. And finally, maybe the most sort of controversial part of this is we've all focused on myocarditis. It's because it's really extreme in many cases. It's really complex. It's really fascinating. But is it actually the most important checkpoint inhibitor-related cardiovascular adverse event? And is that heresy? Does that mean, saying that, it sort of breaks with the philosophy in this field? And I think the first comment is, well, is it all about myocarditis, or are there other things going on? And actually, we wrote this back in 2018 about a range of different cardiovascular complications of checkpoint inhibitors. Myocarditis, it's clearly important. Pericarditis, vasculitis. There was post-aortitis and other vascular complications. Then there's the complete heart block in the absence of myocarditis, Takotsubo syndrome, and then this other phenomenon called non-inflammatory heart failure. And when you sort of looked at this and reported this in the paper that Sol Andres wrote and published in Cardio-Oncology, you could see that there's a range of different complications. But this is all happening during the treatment, and compare the myocarditis with the non-inflammatory heart failure. They're clearly different things. The myocarditis tends to occur early in the first 4 cycles of treatment, whereas it's the patients who are staying on treatment longer, 6 months, a year, 2 years, where this later non-inflammatory heart failure can occur. But I don't think that's the most important. It's interesting. But it's this story now about late effects. And the cardiologists all know that the biology of atherosclerosis and ultimately valve rupture involves inflammation, involves lymphocytes and macrophages, and that in essence, the checkpoint inhibitors are a little bit like petrol on the fire of this disease for people who've already got it. And so we should be thinking more about the late effects of checkpoint inhibitors, and that concept that we've considered in other cancer therapies like radiotherapy and anthracycline chemotherapy. And many of you might have seen this paper from Tom Nealon's group, looking at the CTs of the oncology patients, looking at the amount of aortic atheroma and calcification, and showing that it accelerates in the patients exposed to checkpoint inhibitors. And it's the worst form of the atheroma. It's the non-calcified soft plaque. And that this potentially means to increase clinical events. You can see here the curves of a cohort before in blue and after in red, their checkpoint inhibitor therapy, and how there's an increased range of cardiovascular events. And a lot of these patients are older. Speak of lung cancer patients, there's one cohort that are all going to have some vascular disease already, and we're accelerating. And then particularly the vascular complications such as MI. So we go back to the scale of things. Who's getting the treatments? These are large numbers of people. There's just a lovely slide of all the trials coming down the pipeline. So there's an enormous number of people going to get checkpoint inhibitor therapy. And the myocarditis is really important, and obviously some cases are very severe. But I think the big issue for this drug treatment is going to be the legacy of accelerating vascular disease and probably heart failure survivors. So I think that's the most important complication. It really is a community to think about. So I'm just going to finish by highlighting a paper that Gabriella Chetty led from the Heart Failure Association Cardio-Oncology Study Group together with us, which was published in the last couple of weeks. So if you want to read more on this topic, that's a sort of latest state-of-the-art review. Also wanted to highlight that next year we've got 2 really important cardio-oncology meetings, one hosted by the ESC in Florence in June, and one hosted by Trishun and colleagues in Cape Town at the end of October. And hopefully you can all come to these meetings, because next year is obviously going to be a really big year for cardio-oncology. And so with that, I want to thank you, and I hope you find that raised a few questions to
For questions that Alex, thank you. That was wonderful. And I couldn't disagree on any of those issues. We definitely really re-examine. I think in cardio-oncology, we're so well set up. Often we go where the man or woman has gone before. And so this is a great setup. One of the other things that I think is controversial and in the checkpoint myocarditis is the surveillance issue with troponins. And I would love to hear your comments on that. I know you only have so much time.
Yeah, it's really difficult. And I'll sort of give you some thoughts without probably having an answer. So the first problem is that most cases occur after dose 1 or 2 or 3. So therefore, you've got to have this sort of concept that if you're trying to capture these cases, you've got to do something in this early phase. And yet, we, in reality, suggest that people come and have things when they're going to come up to the hospital anyway. So it's just sort of opportunistic rather than, right, we need to do it in 48 hours or 72 hours. Nobody's got that data to say when it's the perfect time. And I think the solution to that in the correct patients, but I'll come to that as the second part of my answer, is these technologies that are now going to be doing continuous biomarker monitoring. So we're familiar with diabetics having their Libra or other device subcutaneously giving them a readout on their glucose. And these are now going to be available in the, I think, pretty near future for troponin and that's retropeptides, as well as other things. You can almost look into your panel and get it on a chip. So if we have those, then those might be interesting to explore their clinical benefit. But the other thing is it moves up risk. And it's not what we learn in cardiology. It's not the diabetics, hypertensives, the smokers. It's given water, immune dysregulation of thymoma patients. And so the risk factor profile is very different. And the final thing, and it comes back to the issue of the steroids, we can do harm of stopping the checkpoint inhibitor or over-treating patients for mild incidental cases being linked up. So the answer is I don't know, but I think it's better monitoring, but then working out where the absolute clinical benefit is, because what we want to do is pick up the really severe cases early, but that's difficult.
Thank you for the understanding too. My name is Zaza from Washington. So the question that I have is a little bit similar to what Gabe asked. Let's say you had this patient, you're saying in clinic, they had 2 cycles, the troponin was checked, the troponin 60 or 70, maybe 80, asymptomatic. You get the target, all right, there's not specific changes, maybe some NGE. There's some data that also shows that these patients could have NGE, before start therapy. So what is your approach to these patients? Would you admit them? Would you do workup? Would you just let them out?
It's a great question and a common issue, isn't it? So the first clinical thing is, what's the cause of the troponin bias? So if your MRI is a good quality MRI and there's no activity with the base, then you don't have a diagnosis yet. So then it's a case of all the other causes of troponin elevation, and if you sort of strike them all off and you still don't have an answer, and you've got an oncologist saying, I give them all checkpoint inhibitor, and we've got this troponin, and it's created anxiety, then I think you've got to decide what the next step is. And is that endomyocardial biopsy, which I think is reasonable if you have uncertainty. There's a bit of a debate about nuclear imaging. FDG PET in some people's hands seems to be good, in other people's hands it's not. But another form of imaging of your myocardial inflammation, if your cardiac MRI is either a grey zone or quality, but if you've exploded it, then I would do an endomyocardial biopsy, because then you can either say, yes, there is inflammation, and then have an MDT to discuss the treatment strategy, versus, no, you've exploded it, patients get troponin rises for all sorts of things. And when it's in that sort of range below 100, it's very non-specific. If it was 600, or 6,000, I think you would already be thinking in a higher level of suspicion, isn't it? But it's these low levels of troponin without a clinical syndrome that are complex. But if you've got high quality MRI and it's absolutely normal, that is, I think, very reassuring.
Brilliant talk. To take just said a little bit further, where do you stand on the routine use of endomyocardial biopsy for two reasons? One is you mentioned, and it would be a full query of other etiologies, and a lot of them are on two cardiotoxic medication. It could be an atracycline with an ICI, with 5-FU and an ICI, and also incidental findings of finding TTR and some of these, and that could explain other cases. And the second be to give us a leg to stand up for the pre-challenge cases and the ones who have negative biopsies or lower rate inflammation should make the MBs be part of the algorithm.
So they're definitely all part of the algorithm, but I reserve them for grey zone cases. So modern cardiac MRI and good quality sensors is pretty good at either detection or exclusion in my experience. It's when you've got uncertainty. The MRI is either poor quality, they can't have one for other reasons, or that you've got a sort of a grey zone report. You know, as a clinician, I like my radiologist, cardiac MRI, cardiac CT to go, something's there, yes or no. None of this intermediates or possibly. The possibly doesn't help us, does it? You want black or white. But if you get this grey zone result, and you review it and there is uncertainty, then I think that's where the myocardial biopsy becomes relevant. So we don't routinely do it on everyone. In fact, we do it in a very restricted way because, of course, even in very high sort of quality, skilled hands, there are complications of that procedure. So it's not a benign procedure. And I also think a little bit like sarcoid, that you can get patchy changes. So what is the sensitivity and specificity of EMB in checkpoint inhibitor myocarditis? I don't think we've had that study. How many samples need to be taken? And where do you go? Is it LV? Is it RV senator? Both. So there's lots of interesting questions about that. But in reality today, I use it in the grey zone cases.
Thank you, Dr. Milan. So the very broad of thoughts can reference to the acceleration of atherosclerotic cardiovascular disease when we need that finding inhibitors. But since they don't all target the same ECOS, is there at this point an understanding, are some classes of ICIs more likely to accelerate ASCVD versus others? And then as a secondary question, now there's some thoughts about what can we be doing to mitigate that acceleration, knowing very well that our go-to vascular anti-inflammatory agent are statins, which also create ICOS.
Yeah, so it's a great question. So as part of the first one, we don't have a sort of knowledge yet that one particular class is worse or better than others. I think there's a comment on combination therapies, because there's maybe more. Taking and extrapolating the myocarditis, certainly if you have a CTLA-4 antibody, so ipilimumab, that seems to be particularly sort of pro-inflammatory for the myocarditis phenotype. And it may be that we'll look at things like high sensitivity CRP. In terms of what we should do with preventing it, I think, again, it's the context of the cancer patient. So if they're in a curable algorithm, either because it's neoadjuvant, adjuvant, or they're in the metastatic melanoma, they've already had a great response after 4 cycles, then you'd be wanting to do some risk assessment and optimize their risk factors really early in the piece. If they're in a metastatic case where it's more uncertain, you'll sort of want to get the survivors and wait 2 years or 3 years out to then think about their long-term survival. We're starting a study looking at CT coronary angiography in patients 10 years after checkpoint inhibitors from the early master data, and then going back to 5 years. I'm just doing a sort of cross-sectional observation to say how many of them actually have atherosclerosis, because I suspect, anyone who's a cancer survivor, once they've reached a certain age group, we're probably getting this anyway, just for appropriate screening for vascular disease. And then, of course, what we do need is that the more prospective baseline CTCA and carotid Dopplers pre-checkpoint inhibitors, and then following them serially. That will need obviously go to follow-up.
Just one question. Thank you for that great talk. So as an oncologist, I worry a lot about us withholding immunotherapy. You gave the example of curing breast cancer. I'm curious also, and I think likewise worry about long-term potential cardiovascular risk. Are you aware of any data looking at any of these patients also get endocrinopathies? That's where you're using some of novel agents like adrenal insufficiency and some of the work causes the type 70%, let alone the thyroid dysfunction, how that may impact that atherosclerotic disease.
So we don't know. I expect the type 1 diabetes is also going to be a big one for patients who get acute it's sort of beta islet failure. In terms of things like the hypoadrenalism, I actually practically think of it in a different way, which is if I've got patients with heart failure, then I wanted to use lots of drugs that lower blood pressure. And the hardest patients are always the ones who've got low blood pressure. So I would routinely check 9 a.m. cortisols and then consider suractin tests in the survivors of running low blood pressures, but also have got some elevation impairment. But I think we need studies to actually see which of the endocrinopathies could then lead to increasing cardio issues. But probably it's the diabetes, and whether the hypothesitis could as well. Great question.
Thank you very much for very actually to the point on the presentation. My question is about a patient who is admitted to the hospital on ICI, diagnosed with the myocarditis, all the things that they do. Any of these patients may have some hypoxemia as well, with the patient at non-invasive positive pressure ventilation still at the borderline, and as all and of that we're checking CPK is elevated as well. So before starting high dose methylprednisolone for these patients, what is your threshold to get involved, for example, neurology to myasthenia? I'm asking because I had 2 patients like this in 6 months.
Yeah, so it's a sort of question of, is it just myocarditis, or is it looking a bit like a triple ended syndrome with myositis and then myasthenia? Because, of course, our neurology colleagues teach us that the steroids will make myasthenia gravis worse, and so they obviously avoid them normally. So I think it's a difficult situation. In the cases I've looked after, we've all agreed the heart trumps the myositis and myasthenia because they're going to die of the heart complication if you don't treat it properly. So once you've sort of got your baseline assessments with the muscle CK, is that high and making you suspicious of myositis, after having an MRI of their heart, can you get an MRI of their leg muscle? Were they too sick? You can't go down that route. That take them to the cath lab to check their coronaries, their troponins 5,000, and they're very unwell, and then considering an endomyocardial biopsy at that stage. But I think you've got to get in early. So my advice is don't hold back on the steroids. You need to give the steroids, but you also need the neurologist to already have a plan for the myasthenia. In our experience, plasma exchange has been the most effective therapy for that complication. But it tends to be dealt with once you've got them through their cardiogenic shock. So with mechanical support, that's priority, and try to minimize the inotropic faults. Sort of bugbear of flying your patients. It's getting lots of catecholamine-based inotropes and cardiac shock, but particularly when it's myocarditis, because they're so proarrhythmic as well. So we would have them on VAX steroids, and then think about when you get into plasma exchange, as there's clearly in neurology and myasthenic components. But they're difficult, aren't they? So,
thank you, Alex. That was very engaging. Next, move on to our next session on the multimodality imaging and cardiology.
Okay, so again, good morning. My name is Daniel Addison. I'm at the Ohio State University Oncology there. I'm excited to be joined by my co-chair.
So I'm Suma Konety. I've introduced myself many times. Thank you all for being here, and we have a great lineup of speakers today. And we'll start with Anthony Yu from Memorial Sloan Kettering. We'll talk to us about surveillance with echocardiograms. How much is too much?
Great. Good morning, everyone. It's really a pleasure to be here. Thanks very much to Suma and the organizing committee for the invitation. I'm really excited to speak to you about this topic, cardiac surveillance, echocardiograms, how much is too much, a topic that's very near and dear to my heart. And these are my disclosures. So I thought I would begin by just showing this figure, which I think nicely summarizes the role of multimodality imaging cardio-oncology. If you look at the left column, you'll see that the primary tools in our toolbox are echocardiography, which I'll focus on this morning, and then our subsequent speakers will focus on cardiac MR as well as cardiac CT. And I think we all hopefully would consider echocardiography as the workhorse, the first line, the tool to use in our toolkit. Perhaps because they're widely accessible, the expertise is widely accessible, and get a great deal of information regarding cardiac structure and function that's so important for assessing these patients throughout their cancer treatment continuum. So at baseline, we want to know their LA and RP function. We want to know their candidacy for beginning cardiotoxic cancer therapies. In follow-up, these patients often undergo regular repeated echocardiograms to monitor for clinical or subclinical signs of cardiotoxicity. This is really important to ensure safety, and it also provides all of us in the room an opportunity to intervene when necessary. And in the post-treatment era, after treatment during survivorship, once again, follow-up echocardiograms serve an important role for monitoring the effects of cancer therapy. Now, when we think about if we're doing too much, I think it's instructive for us to go back to the historical context of why we do so many surveillance echoes. And I think one of the major drivers has been the treatment of patients with targeted therapies. The panel on the left shows the cardiac event rates from two important landmark trials in which women with breast cancer were treated with anthracycline chemotherapy, sequentially followed by trastuzumab. And you can see in the table that patients developed, the rate of heart failure was on the order of 2 to 4%. Perhaps equally concerning or more concerning was the rate of asymptomatic EF decline, which was on the order of 15 to 20%. We know these events are concentrated predominantly in the first year of therapy. And so it's really a consequence of these findings that cardiac safety rules were created and translated to our guidelines, whereby baseline EF assessments are recommended pre-treatment, follow-up assessments every 3 months are recommended during treatment. And the goals are several-fold. We want to detect subclinical cardiotoxicity before patients develop clinical heart failure. We want to intervene with cardioprotective strategies when possible. And we also want to partner with our oncologists and to help make the appropriate clinical decision-making for our patients. So a few years ago at MSK, we really wanted to understand and dive a little bit deeper into the role of surveillance echoes amongst patients. We identified patients who developed severe phenotype of clinical heart failure. During the course of breast cancer treatment, we identified heart failure-free controls, and we looked to really understand the frequency and the information that was yielded from surveillance echocardiograms. And we made two major observations. The first is that adherence to echo surveillance is really great early on during therapy, and then it wanes over time. And so perhaps a takeaway from this could be that in higher risk patients, patients who are going to develop heart failure, we need to do a better job making sure that we're doing the appropriate level of monitoring. The second observation was that amongst patients who develop heart failure, 50% of the time, there was an abnormal ejection fraction detected prior to the clinical presentation of the heart failure. So once again, I would interpret this as follows. Surveillance echocardiograms utilizing 2DES do provide us information, do provide us a time window to intervene and help modify the natural history of cardiac access in these patients. On the flip side, we know that 50% of patients will not have an abnormal ES. 50% of patients will go on to have regular surveillance echoes. And so we rely on 2D ES alone. That will not be sufficient. Thankfully, we have a more advanced imaging marker, global longitudinal strain. Jennifer gave a really nice overview yesterday of the utility and the data behind this. This is a really nice systematic review and meta-analysis that generally summarizes the fact that GLS is more robust than ES for assessing LV systolic function and has prognostic value for the development of subsequent CTRTD. A primary question, though, with this data is, can GLS impact clinical outcomes? So, of course, as we've seen a few times already during the symposium, we have recent data from SECORE MRI. This data shows in a really nice and rigorous way that amongst patients who are high risk based upon abnormal GLS, intervening with cardioprotective therapies was effective for mitigating ES decline relative to usual care. And while we're still quite far away from implementing this in clinical practice, I think this is very promising data that helps support the use of GLS during routine monitoring. Now, we just heard a really fantastic talk on myocarditis. So I'm glad I included this slide. Echo still is an important tool in evaluating patients with immune checkpoint inhibitor myocarditis. We know based upon the figure on the left that about 50% of patients will present with some degree of LV dysfunction. It's perhaps for that reason that the consensus diagnostic criteria do include abnormal LV function with or without regional function abnormalities as the minor criteria. And the figure on the right from Tom Nealon's group further added to this literature to demonstrate that global longitudinal strain is prognostic. So regardless of the level of ES impairment, patients who had abnormal GLS fared worse from a MACE outcome. So hopefully I've convinced you that surveillance echocardiograms are helpful. There's a role to perform them. These are what the ESC guidelines tell us. On the left are recommendations for anthracycline-treated patients. Echocardiograms are recommended at baseline. Those are the class 1 recommendations, those are green dots. They're also recommended pretty uniformly while after treatment. And only in high-risk patients are more regular, frequent echocardiograms recommended. On the right are recommendations for patients receiving HER2-targeted therapy. You can see many more green dots. So irrespective of level of risk, which is noted on the left-hand side, patients there's a level 1 recommendation for baseline follow-up echo every 3 months for the first year and 1 year's follow-up echo thereafter. So I guess I would challenge the room here. Despite giving you all of this data that surveillance echocardiograms are important, it's really necessary for us to understand the treatment landscape in which we're operating. And I think this figure really nicely shows that the landscape has changed pretty significantly. You can see that amongst the Medicare population and a general private payer population, anthracycline use is on the decline. And in place of anthracyclines are more taxane-based therapies, what I call non-anthracycline-based regimens. And if you look at all of the data in these tables, whether it's in the adjuvant, neoadjuvant, or metastatic settings, we see that the cardiac safety is markedly improved relative to this first slide. The rate of symptomatic heart failure is less than 1%. The rate of asymptomatic EF decline is 2 to 4 or 5%. Now, It's also important for us to remember that we've gone beyond Herceptin and Perjeta. There are novel compounds called antibody-drug conjugates in the HER2 space. Those include TDF1 and trastuzumab deruxtecan, or TDXD. But similarly, the cardiac safety profile looks the same as the prior slide, with a severe heart failure rate of less than 1% and a mean decline rate in the single digits. So if we transition into a new era of safer cancer treatment in this setting, is it appropriate for us to be following all of these guidelines? And I've highlighted here from multiple professional societies what are recommended. So pretty much across the board, they all recommend echocardiograms every 4 cycles or every 3 months for patients. And I would propose that this has created Dinesh and his group have coined risk imaging mismatch. I love that term. He utilized it to apply to baseline echocardiograms, but I think that this extends to follow-up surveillance echocardiograms. We know that there's a spectrum of risk from low to high. There's also a spectrum of severity. So ideally, we would like to focus our resources on those dark circles on the bottom right, the high-risk patients at risk for high severity of disease, and perhaps de-escalate those lighter circles on the top left. But unfortunately, we are following this one-size-fits-all approach. And hopefully, you'll agree with me that one size does not fit all in this setting. And some may ask, what's the big deal? An echocardiogram is pretty harmless. And I would push back a little bit to say that there are some intrinsic potential harms of over-testing. I think we've all seen images like this on the top right. Perhaps a patient who have recently had a mastectomy or has tissue expanders, and so you have suboptimal image quality. And we probably would get 20 different answers in terms of what the ejection fraction is in this figure. And not all labs are going to have the ability to administer echo contrast. This can lead to significant variability, leading to higher false positive rates. And of course, that can snowball into downstream delay of treatment initiation or treatment discontinuation. And we know from work that Robert Kopler-Heltman did with us when he was at MSK that treatment interruption is something to be avoided because it adversely impacts cancer outcome. And we also can't ignore the rise in healthcare resource utilization and patient time and cost. So with that in mind, we had this idea a few years ago to generate what we thought was necessary data to update guidelines. We wanted to demonstrate cardiac safety of fewer, more reduced echo surveillance and patients receiving non-anthracycline-based treatment. So we enrolled what we considered low-risk patients who were receiving non-anthracycline regimens, patients who had no overt cardiovascular disease. We enrolled them in a strategy of reducing surveillance, which included a baseline echo, a 6 and 12-month echo. And our primary outcome was symptomatic heart failure. We aimed to be non-inferior to the heart failure rate in historical controls. We had several secondary outcomes, including changes in ES, treatment interruption, and CGRTD, as well as fakeability. And in this study, not surprisingly, we encountered no patients who developed symptomatic heart failure. There was a mild but not unexpected decline in the ejection fraction that was very modest. The rate of asymptomatic CGRTD was 0.5%, and it was only that one patient who had a transient interruption for HER2 targeted therapy. Almost 75% of patients and providers were deemed to follow this strategy, which I think is also an important point. So hopefully this data will help us to update the usage strategy, this recommendation. So what we might aim to do is identify some of these time points in which surveillance echoes probably are very little, if any, utility, and take them out. Perhaps easing the burden from a healthcare resource perspective, the reducing time and effort for patients, and still delivering excellent, safe care to our patients. Now, it's important to understand that in order to achieve this, we really have to understand who's high risk and who's low risk. So there are several strategies that are available. Here I presented the ICOS pro forma, which has clinical factors listed on the left. You count them up, you add up the score in terms of high, very high, or medium, and that within these patients is low, medium, or high risk. At MSK, we wanted to take advantage of our wealth of data, so we also developed a risk stratification tool called the risk nomogram, which utilized data from a large retrospective cohort that we had. We identified the clinical variables, demographics, cardiovascular disease risks. Those were put together in a risk nomogram, which is on the top right. Each variable was assigned a value, a point score. You add up those points to translate to a 1-year probability of cardiotoxicity. And when we looked at this group in terms of quartile of total point, you can see that the lowest quartile developed a low rate of CTRCD, whereas patients with the highest quartile of risk score developed nearly 25% rate of CTRCD. So we look forward to validating this externally. So we're thankful for Dr. Deswell and her team at MD Anderson, who's graciously agreed to work with us. And it is our hope that this can be a useful tool to not only inform clinical decision making, but perhaps identify appropriate risk patients from a research perspective. So I'm going to leave you just with this one slide. Hopefully it's a word of encouragement. I know that from a medical perspective, it's easy to add more patients, easy to order more tests. It's challenging to do less. It's challenging to offer patients fewer tests. Patients like them, providers, I think, like them. But here's a case study, if you will, in the pediatric group, in which there were established schedules for routine surveillance every 1 to 2 years, depending on radiation or anthracycline dose. But several studies, including this, which was performed by Andrew Noria and her team at the Brigham, performed a cost effectiveness analysis to understand how varying frequencies of echo could impact outcomes. And what they found was that less screening was cost effective, reduced patient burden, but provided similar benefits at half the cost. So here we have the most recent guidelines, which have incorporated many of those findings and now translated to fewer surveillance echocardiograms and describers of young childhood and young adult cancer. So hopefully we can make this happen in the adult space. So a few take-home points. Echocardiograms are critical. In order for us to move the needle forward, we need accurate risk assessment, and less frequent surveillance than currently recommended may be appropriate for some patients. So I would propose that a revision to current guidelines is warranted. Thank you.
Thank you, Doctor. Thank you, Doctor. I think that was a wonderful talk. And again, we'll take questions later. But at this point, we'll go ahead and invite our next speaker, Dr. Charlotte Manisty from the UK, for one talk.
Great, perfect. It's a great pleasure to be here. Hopefully I'll be able to convince you, partly helped by Alex and this talk from our previous talk about hypnotherapy, but hopefully through the evidence that I'm going to show you today about the value of MRI in oncology patients, and I'll talk to you about the future developments that are on the horizon as my disclosures. So we've already seen that imaging as a whole has significant value throughout cancer patients' journey, both the baseline risk stratification and then throughout cardiotoxicity monitoring and assessment during and after therapy. And again, as we've previously heard, it's important that we have a whole armory of multimodality tools with which to be able to assess the range of pathology that we see. But when we look at MRI per se, we can see that there are some specific areas where it has added value, and these are really nicely highlighted in very good work from Daniel and also from Laura Manisty from the AHA and ECC. And I'll encourage you to read those papers, which are really very valuable. But I'll run through this a little today. So when we're thinking about surveillance and CTRCD, obviously the aim of the game is to try and identify a risk which develops heart failure.
But I'll remind you that it's a high-risk game in the sense that if you underdiagnose cardiotoxicity, we know some works with Daniela Fardale is getting cardiography. The later you diagnose it, the less the chance there is of cardiography. But similarly, as we've seen already, if you overdiagnose cardiothoxicity, there's likely to be worse cancer outcomes due to unnecessary interruptions to cancer treatment. So you've got potential to do harm both ways, so we need to get our surveillance right. We know from the guidelines that the threshold of change in ejection fractions in CGRCD is 10%. And we've seen already that the minimal detectable difference using 2D echocardiography 9.9%. So we're using a tool that may not be sufficient to be able to diagnose this. MRI has superior accuracy at 5.9%. But AI also adds incremental benefit in terms of measurement precision of MRI. We know from data in our institution that reproducibility is 40% better using AI analysis to manual analysis. And we now have AI tools to be able to measure 1, 2, analytical dimensions, orbits, etc., all automatically within a single scan and a single analysis software. And this is an example. This is a patient who was being monitored for septum gonitoxicity. She had 2 scans done within 3 months. You may not be able to see on the imaging, but essentially the difference between the quantitative values is so small because of the improved measurement precision using AI. But of course, echocardiography has moved to a large extent as to considering strain as an important parameter. And MRI can also measure strain using standard cine imaging and feature tracking software. And we know that this works well and it tracks ejection fraction change during during chemotherapy. But what's the actual incremental value over the very precise measurements of ejection fraction that we'd have with cardiac MRI? And this is nice data from the Dinesh Havidaran's group, where we see that the incremental value in terms of prognosticability from strains and feature tracking CMR is not significantly better as compared to the precise measurements you get ejection fraction measurements. And their conclusion is that when ejection fraction can be measured precisely using CMR, feature tracking strain may additionally add confirmation, but this is in contrast to echo, where actually it's the old prognostic measure. We've seen already in this meeting the ability of myospray to measure the percentage of normal myocardium and to be able to detect subclinical and clinical cardiotoxicity and its prognostic power in assessing. And this is a commercial solution doing rapid scanning and clinical scanners. But of course, with MRI, one of the main advantages of MRI is the ability to do tissue characterization. So not only late-gap linear enhancement, but also quantitative parameters that you can track over time. Like T1 ECP mapping, which alongside late-gap linear enhancement imaging, you can rely on like a fibrosis or injury, and T2 mapping, which allows you to quantify myocardial edema. And so how are these in terms of detecting CPLCD? Well, we know that in cancer survivors, T1 and ECP values are higher. What about during treatment? Does it help us during treatment? And again, this is nice data from Dinesh's group, where they tracked T1, T2, and ECP values throughout treatment in 136 patients with therapy. And what they found is that there were changes in T1, ECP, and T2, but these were small, they were often within the normal range, and probably most importantly, they didn't associate with subsequent electric rejection fraction strain dependent values. So their value and incremental value of rejection fraction static may be relatively limited. The other criticism, of course, that we've had with MRI is access, the feasibility and cost. But the whole CMR community and moving towards doing less complex scans, reducing scan time, and doing non-monitorized scans about that. So in our institution, we now do non-monitorized scans and surveillance. We can fit 2 patients into a standard CMR slot. Certainly, my country's group is doing very abbreviated scans, 2-minute scans, and using the community assay, which have high sensitivity, although the specimens do 71%. So who should we be doing this on? And I think it was really nicely illustrated in Addison's previous talk that there are patients where it's going to be of value. Not only the patients who don't have very good echocardiogram windows, but also those patients who are already at highest risk. Perhaps they had in previous cardiothoxicity, or they have no cardiovascular disease, in those patients where I really want to have a good track of what's going on, it's important to do the CMR. But of course, CMR can understand and tell us a lot about many other pathologies going on, and that's because of the range of sequences we have available. So we can look at perfusion, scar, edema, and all of these different pathological processes. If your patient develops a ventricular systolic dysfunction during treatment, you can interrogate it and understand what the underlying etiology is, so you get mesothelioma in these patients. And similarly, in patients who have got late effects, for example, a single scan will allow you to do a comprehensive cardiovascular assessment. This is a patient who had metal-field radiotherapy and presented with mild chest pain when they were being assessed for neoadjuvant chemotherapy and breast cancer. And what you can see in this study is the patient had mild elderly impairments. They had severe aortic stenosis seen on the flow imaging. They had evidence of maybe having an enhancement of a small infarct. And then when we did quantitative diffusion mapping, you could see that they had globally 4 level known. Subsequent coronary angiogram showed that they had cancer disease. So this patient had tissue AVR and coverage before they went on and had to go out of their chemotherapy. But of course, myocarditis we've already heard about. We know that the diagnostic criteria for myocarditis in terms of non-invasive imaging rely quite heavily on CMR. We have the modified Lyon criteria, which look for myocardial injury and myocardial edema using parametric mapping techniques. We know that there's a class 1 indication for CMR in myocarditis, and it forms part of the major criteria for diagnosis of myocarditis, Forensic setting. But what does it actually look like in the real-world setting? How useful is it? And I think perhaps it's a bit overpromised. The actual real-world data is not quite as convincing as perhaps we'd have hoped for. So this was nice work. Lyon's group, 28 centres, 103 patients who over a month at the Konety. What we can see is that a large proportion of patients had normal ejection fraction, but also that 42% of patients had either late gap in enhancement nor abnormal DT start. So their tissue characterization is essentially normal. And perhaps more concerningly, neither late gap nor stir with prognostic intent of major adverse cardiovascular events. But of course, as we've heard earlier, it's important that you get a good quality CMR. Parametric mapping is key here. And this is work from the Nations group where they looked using patients who had parametric mapping done as part of their CMR. And what they showed, 95% of patients had either abnormal T1, T2, or late gap advancements, and T1 was the best prognostic marker in terms of major adverse cardiovascular events. And no patient with a major adverse cardiovascular event had a normal T1 value. So this led them to conclude, as Alex suggested earlier, that if you get a grey zone patient, you may need to go on and do more invasive testing, such as endomyocardial biopsy. But in a patient with completely normal tissue characterization, you can be fairly confident that patient has got myocarditis. Whereas if the pathology is diagnostic in terms of CMR appearances, then you may be able to avoid invasive biopsy completely. But we also know, as I suggested earlier, that CMR is slightly more challenging in this setting than it is with myocarditis. It's nice and well trials where they took patients with myocarditis, checked when it was myocarditis, and patients with similar malignancies before they started in checkpoints. What they showed is that there were higher ECV, T1 and T2 values and slightly more late gap in patients who had myocarditis than those who didn't have myocarditis, as you would expect. But perhaps importantly, compared to patients with viable myocarditis, with much less T2 elevation, much less late gap in enhancement. So it's not such straightforward at all as it would be in viable myocarditis setting. So the other area, as we've been aware, where CMR is particularly important is with amyloidosis, both the diagnosis, where as a child one indication in the NC guidelines, but also the prognosis. T1 and ECV are quantitative parameters, and we can see that those are associated with mortality in the amyloid population. And we can also use the parametric maps to be able to track the response. So the patients on the left had regression of their amyloidosis in the heart during treatment, and you can see that their T1 and ECV values have reduced. The patient on the right that had a regression, those values increase. That's been shown to be track organ response very nicely in AL amyloidosis. We use CMR for diagnosis of tumors, not just the location, the relationship with adjacent cardiac structures, but perhaps most importantly to help with tissue characterization. But more recently, we have evidence that it's actually useful for prognosis. This is work from Shinoy, where they took 903 patients and then diagnosed patients by having malignant, benign, thrombus, or pseudomasses according to specific criteria. And what they showed was that the CMR was not only accurate, was an excellent predictor of increased mortality, with benign tumors found to have similar mortality as patients without tumors at all. And finally, in research, we've heard a lot about clinical trials, particularly in cardiac detection, which use CMR as clinical endpoints. That's because of that improved precision, meaning that essentially they were going to be able to reduce your sample size, double your trial. And we see no really better example of that super MRI, where they were able to show the benefits of strain-based cardioprotective strategy when MRI was used to adjudicate endpoints compared to cardiology. And finally, MRI was seeking us mechanistic insights into the underlying physiology of cardiac toxicity. This is work from Vlad Zaha in Texas, looking at abnormal metabolism using hyperpolarized spectroscopy. And this is work in Glasgow from Lyon, looking at VEGF inhibitors and showing that there is a microvascular ischemia which can be quantified on with diffusion mapping in patients taking VEGF inhibitors. So, in conclusion, CMR is an essential tool as part of the multimodality imaging armory. We do need improved precision when we're doing our surveillance, and tissue characterization and parametric mapping is needed, particularly for immune checkpoint inhibitors, myocarditis, and amyloidosis. If you're doing a clinical trial, CMR may help you out, it may be your friends to help you reduce your sample size, but we need more outcome evidence to show that this actually changes outcomes. So thank you.
For the next journal review. Continuing with our multimodality theme in cardio-oncology, I call Maros to give us an overview on cardiac CT imaging and cardio-oncology.
Thank you very much for the introduction. Thank you for the invite to this great meeting. Thank you, organizers, for the whole meeting, the social events. Really great to be here. These are my disclosures. So, over the last 3 days, you've probably heard a lot of this background, the interface between cardiac disease and cancer, and you can look, these are some old data. Cardiovascular disease, the first, people argue is first to second, but it doesn't matter. These are, if you are here in this room, sooner or later you will die of one of these. That's basically what it is. And when you look at it, there's really a lot of cardiovascular and cancer risk factors that they go for traditional, what we call in cardiology, traditional cardiovascular risk factors such as age, sex, smoking, diabetes, obesity, hypertension, and then there's more modern what it takes like environmental factor, setting their lifestyle, and chronic inflammation, and then more about genetics like chronic diseases and telomere lengths and so forth. And then really Sunday was amazing. Right? And I'm not going to go to this slide because Sunday we learned so much about these basic biologic and then you saw the overlay between cardiovascular disease and cancer. And there's so much to learn about it. But what it just does too for the cardiac CT tool and with strength in atherosclerosis imaging is these data from MESA study, and I have to explain it. This slide basically the MESA, for those who know MESA, they did follow-up scans, for 6,000 subject study, and they looked at patients who during the follow-up developed cancer. And what on this slide you see is if you developed cancer between the baseline and follow-up CT scan in MESA study, you were more likely to develop the calcium. It shows you that, the cardiovascular disease, atherosclerotic disease, and cancer development develops within the same time of your lifetime. Very important. And it works, of course, the other way around. We talked about the reverse cardio-oncology also over the course of the last 2 days, and this is a huge database, 750,000 patients. And what you see here, in patients that have prior atherosclerotic cardiovascular disease, those of the right-hand side, for the entire population, they're more likely to develop cancer. And it's any type of cancer. It's men and women. It's in different races. And of course, on the left, the bottom side, you can see that the more likely or more typical cancer there are associated with this is increased risk when you have atherosclerotic cardiovascular disease, breast cancer, head and neck cancer, and genitourinary cancers. So very nice analysis. And why it all matters is, I think, this slide, which tells us that if you survive the cancer and you have cardiovascular disease, you are far worse in terms of your survival. So there is a huge opportunity, because everything that we do in cardiology is this relative reduction of 10%, 20% in different drugs, different interventions. So you have something that is a very high impact in terms of morbidity and mortality. Your relative risk will transform into large absolute risk, which will really matter at the population level. What I'm going to review in this presentation will be what we, together with Juan Mate, many people in this room actually worked on and prepared a consensus statement which summarizes how to use cardiovascular CT in cardio-oncology. So if you are interested in more to learn about it, this is really a good document that summarizes the current status of things. There again, prepared this very nice slide, which shows again the summary of where we went when we're sort of conceptually thinking about it. You have the cancers, you have the cardiovascular risk factors, you have the effect of the treatment medicine, and you end up with atherosclerotic disease, valvular disease, or cardiac disease, and other things that are very important and that can be detected and managed with cardiovascular CT. So the first concept that we put into this consensus document was really the fact of the shared risk factors and how the core cardiovascular CT can help in the risk stratification of patients during their journey, pre-cancer treatment, during cancer treatment, and in survivorship. What we summarize on the left-hand side is the sort of clinical assessment. So your physical exam, your basic evaluation, including the biomarkers in EKG, and then emphasizing the opportunity to detect coronary calcium as a measure of subclinical amyloidosis. Because the majority of the cancer patients have chest CT scan, and the detection of calcium on any of the CT scanning is really reliable with the modern CT scanners. And this provides a real opportunity to use the framework that we know from standard DHA and ACC guidelines, which is on the right-hand side. We have the basic ASCVD risk assessment based on cardiovascular risk factors, like lipidemia, diabetes, age, sex, and so forth. And then using the calcium, the amount of calcium, to sort of refine how much interventions in terms of medical preventive therapies you can do. And you can do a very sort of general evaluation because we have a lot of data. You can also see slide that even just very simple semi-quantitative assessment of plaque burden of coronary calcium predicts future cardiovascular events. At the bottom line of the left-hand side, we have very many heart disease data that were getting reproduced also in the MESA study on the left-hand side, showing that number of segments, no segments, 1 to 2 segments, 3, 4 segments, or more than 5 segments are associated with a 2-fold or 8-fold increased risk of cardiovascular events. So very simple framework that gives you an evaluate what the risk of patient is. And when there is a moderate or severe calcification, the guidelines would recommend treatment with statin and aspirin, because we know from general population that leads to lower cardiovascular events. Now, we also in this document, we provided this sort of simplified pathway for people who would not necessarily familiar with the cardiovascular guidelines, or don't feel comfortable to manage aspirin and statin in terms of the general practice, to have that experience with it. You look at the basic CT scans, and now I would say that with the modern reporting in radiology, more and more often, we see it really implemented in reports. There is really a lot of reports these days that have evaluation about calcium, and you can also get very comfortable in an oncology room. I'm sure you are reviewing your CT scan. It's really very easy. they've been assessed how much coronary calcium or vascular calcium there is in the scan. Another area that we covered, of course, is role of cardiac CT in cancer treatment related to cardiac dysfunction, CTRCD. The CT has very limited value in LV systolic dysfunction. CT actually can do it. It can do it very reliably, but it's in cost of high radiation. It's not really what we do in standard. Our real role for CT is in those who have LV dysfunction from various causes to exclude coronary disease as the cause of the lower of LV dysfunction. Because when you look at the general population, the most common reason for LV dysfunction is obstructive coronary disease, especially if you treat patients in their 60s or 70s or 80s. Then we, of course, they have a group of patients present with clinical symptoms, whether it's acute presentation. We talk about ICI myocarditis, and anthracyclines, and the elevation of troponin, the levels of elevation troponins. The CT is a very quick and easy test to exclude obstructive coronary disease as the cause for the elevated troponin. And of course, stable coronary disease evaluation, where the CT has a class 1 indication for the evaluation of patients with no prior history of coronary disease. Now, we have some exciting stuff that I'm happy you have got a chance to talk about. We can do extracellular volume evaluation, sort of fibrosis imaging with CT. We can calculate strain. And of course, I will talk now about what is important, and that's the atherosclerosis progression and imaging. I didn't mean to sort of show you this again. You go to the document for each of the cardiotoxic treatments, such as anthracyclines or 5-FU. We provide some of the recommendation when and how to use coronary CTA. So you can again go and reference this document if you need to use it in clinical practice. We already talked about immune checkpoint inhibitors and their possible effect on the progression or start of coronary atherosclerosis. On the left-hand side, again, Valvula's data showing increased cardiovascular events after you treated with ICIs. And then the right-hand side, sort of mechanistic explanation why it happens. To change the amount of plaque, in this case, actually aortic plaque, and the type of plaque, the higher risk type of plaque that is more non-calcified plaque. What's exciting in the coronary CTA world is that this is becoming now basically commercially and clinically feasible. There are at least 3 companies. There's now actually reimbursement code for quantitative assessment of plaque. And I really think in the next 2 or 3 years, this is going to be probably commercially available and reimbursable when you do it. So you'll be able, coronary CT, to quantify your plaque. And why it's important is that from general population, we know that the total plaque volume, these are data from Munich study for over 10 years follow-up, showing the gradual increase of risk as you have higher amount of plaque, or actually more detailed analysis of plaque types, where the non-calcified plaque mass Scott Hart study showing 5-fold increase in cardiovascular events. So having amount of plaque and type of plaque that's at worst of prognosis can refine your risk stratification. Dr. Chaswell yesterday talked about the monoaminometaphysis. There we have on the left-hand side their original data showing the increased risk of calcium. On the right-hand side, you have some of our preliminary data in our small cohort of 68 sort of matched patients, where now in the small data set, we are showing similarly that there is more atherosclerosis, more non-calcified plaque, although when corrected for risk factors, we were sort of losing some of the power. So probably in the larger data sets, we would be able to replicate these data in quantitative plaque analysis. CT has a role in the evaluation of patients with after radiation therapy in pre-treatment using the framework that I put in the few first slides about the stress stratification of calcium and potentially role of statin. We discussed it yesterday in the radiation session that perhaps the patients that have no coronary atherosclerosis CT scan could be prevented if treated with statin. And then very important post-treatment evaluation of radiation toxicity, whether it's radiation-related coronary atherosclerosis, coronary disease, valvular assessment, and pericardial disease. And where really is the critical role of CT in a modern era is that crucial role of cardiovascular CT in pre- and post-procedural imaging for TAVR, TME, where CT is basically in the irreplaceable. Again, if you want to learn a little bit more about it, Josh Mitchell, here led the excellent work of ICOS summary statement on the cardiovascular manifestation of therapeutic radiation, where we do summarize the role of CT, especially for assessment of valvular and CAD. So the final role, again, that's in the document is the evaluation of cardiac masses. There, CT has a limited role as a sort of standalone test. Really, we use CT typically after the cardiac MRI, echocardiography. But what CT is really strong about is when you need that additional information. Roll out coronary before you go to OR for the surgery. Really, you can avoid the catheterization. The localization invasion, this really high spatial resolution of all the techniques, allows the exact location of the tumor. What is also very important is the sort of using the CT scan that we have and learn about what you have again on the right side. It's small, it's not meant for you to read, but all the information, how the different types of tumors are reflected in CT scans, and how they can be reflected in non-cardiac CT scans, which is what the oncologist probably covers. So in summary, we talk about the shared risk factors and this mechanism between cancer and CVD, which are critical with the detection of subclinical atherosclerosis for cardiovascular risk stratification and prevention. We talk about the preventive treatments based on the quantification of coronary calcium. We talk about CTRCD and its central role for the CAD assessment with obstructive, non-obstructive, radiation, heart disease, and again, detection of coronary disease, role for the evaluation of valve disease, and a sort of supplementary role in the context of multimodality imaging for cardiac masses. So with that, I would like to thank you for your attention. Thank you for the invitation. Thank you, guys.
I think we'll open up the stage for some questions. And if you have heard the multimodality case.
Maybe we could also call him Dr. Yu and Dr. Manisty staying here.
Okay, excellent session. My question is for Charlotte. So as we have discussed in the setting of this for CMR, they use ECHO to identify the patients at risk, and they end up randomizing patients that have had a change in strain, i.e. adjudication of CTRCD by demonstrating 12% reduction in GLS, but no adjudication by EF. So GLS positive, EF negative. So my question is, if we can use MRI, would you have found a similar cohort where you could demonstrate changes in GLS, but not in ejection fraction? Then two more parts. The second part is, if that is the case from MRI, and if you were to use that tool, for surveillance, is it about the strain by CMR, or is it about ejection fraction? You mentioned two different strategies. One, the minus unit one, and then a short evaluation of ejection fraction by a CMR. And last question is, if you're going to use CMR, and if you have been able to adjudicate LV dysfunction, won't you trust the ischemia sequences to rule out CAP, or do you need to use a modality that will give radiation to the patient like a PET or CT?
There's great questions. Thank you very much. So I think in terms of the first two questions, would they have found the same results using CMR strain analysis? I mean, I'm sure that they would be able to do that analysis. I'm sure Janesh is in the room here. But obviously they were doing the primary endpoint assessment. Do I think that we should be thinking of the two as very distinct entities? I think that we ideally at the moment, if we have the ability to be able to just measure ejection fraction, requiring their additional corrective processing, etc., using AI, then we could just pursue that as a strategy. But using strain has additional benefits We know there's a lot of validation data for echocardiograms. We don't have the same validation data in terms of CMR strain. Our cutoffs are not so clearly defined. Our impact on prognosis is not so clearly defined. So we tend to use ejection fraction based at the moment for patients where we have CMR surveillance, but that's obviously going to be a relatively select group of patients anyway. And the final question about perfusion mapping. So perfusion mapping has been extremely well validated now in very large scale studies. So I would say that you definitely can trust that. You would not need additional imaging using PET, etc. It's available inline on the scanner, so that you would immediately get results on the scanner, which gives you the quantitative perfusion mapping of the MPR, stress myocardial blood flow, rest myocardial blood flow per segment, and you can differentiate between subendocardial and transmural perfusion. It's been well validated, and I would say that you can trust that now again.
Thank you. First of all, what a great session. I really enjoyed that. And my questions to Anthony, and I really like your talk. So you should have been on the task force guideline. We proposed the concept of lowering the frequency of echo imaging in low risk patients receiving trastuzumab. And so then I could tell you the reason we did not do that was actually more the North American colleagues of the guidelines said, but the FDA says we have to do it. So what are my questions to you? And there's sort of two questions which come together. How many low risk patients should we do the study to have the certainty of what's absolutely low, so that you can then go to the FDA? And how do you go to the FDA and get this changed? Because for low-risk patients, I agree, I'm an advocate and would support that, but it's how we actually make it happen.
Yep. So thanks, great, excellent questions. To first address your question regarding the FDA, I think there's, it depends on what our goal is. Is our goal to change the FDA label? And if our goal is to change the FDA label, that will require a large number of patients in a 2-arm randomized controlled trial, or level of evidence to that degree. Alternatively, I do think that I'm speaking for the providers at my institution, with education of all of the oncology providers, with presentation of the abundance of historical data showing cardiac safety, that providers are ready to make a change. And so I think from a practical standpoint, they are two different things. I acknowledge that 100%. I don't have a good answer for you. That's just, well, that should require an FDA change label-wise to implement clinical practice. But I do think that if you show this, a lot of these types of studies, they can influence practice sort of from the ground up, from a professional society standpoint.
So either way, maybe you can do a quick show of hands, particularly in this North American audience. How many North American doctors here are happy to practice outside the FDA label if they get the green from their census? It's not bad. How many of you are worried about lawyers? Then how about you? So I think there will be a change in culture, that low risk need less, whereas the higher risk patients are where we want to target the results. I think there'll be more on the debate on this.
Thank you so much for the session. It's awesome. Actually, follow up on a similar point to Alex. So, first off, I'd say from the legal standpoint, it's much more about standard of care, which isn't necessarily based on the label. And this is where there is an opportunity as a society like guidelines to make this point clear. And my question for you is, with the data you've shown, as well as the data from the clinical trials where there's not anthracycline treated HER2 positive patients showing such a low rate of clinically relevant cardiotoxicity, why not go a step further? Why are you still including those monitoring echoes alone or low and moderate risk patients, as opposed to saying we're going to get a baseline echo, and if it's normal, we're not going to do anything?
Yeah. So I guess my response to that is somewhat of a practical response. This was NIH funded. I actually did propose. I did propose that, and in order to satisfy grant reviewers to get it funded, I upped the surveillance game. Which is not a great answer. Those questions worst. No, but I mean, would you now advocate based on your data and what we know from the trials? Would you advocate not for your study, but for practice, eliminating them in low or moderate risk patients with normal baseline genetics? Yeah, most of me wants to say yes. However, I see enough of these patients where I am very surprised that by the absence of risk factors, looking at my risk nomogram or the ICOS pro forma, they should be low risk, but they rarely come to my clinic with real significant LP dysfunction. So those are just giving me loss. And I think that the best path forward is for us to just continue working refining our approach to risk stratification so that we can hopefully get to a point where we identify somebody who's truly low risk. We do a baseline echo, or perhaps we do an AI ACG. And if it's normal, then we offer clinical symptoms. I'm not sure we're there yet.
Certainly, I'll be out of the zone of good stuff. What last one?
Thank you. My name is Robert Zaza from the University of Tokushima in Japan. I'd like to thank all three speakers. It was really worth listening to flying in from Japan, especially Anthony. I'm an echocardiologist running on the side oncocardiology clinic at my hospital. I was asking, we really struggle with following GLS, especially in breast cancer patients after surgery. So, what do you think of the feasibility of following other things other than say diastolic function? Because it's really hard to after EF decline, it's really too late to intervene. So I think other things need to be monitored more closely.
Yeah, I acknowledge and I empathize with the challenge for many post-operative breast cancer patients. So yes. I have struggled myself in a research perspective trying to quantify GLS in those patients, and it is so difficult. So it's never or not, it's a big concern. Certainly for diastolic dysfunction, it should be more easily obtainable in a routine surveillance study. But again, I'm not sure that diastolic dysfunction is necessarily the primary parameter that we're eager to follow. So, I think it's a matter of having really, really excellent sonographers, and despite the challenges at our institution, our sonographers pretty much always can get good quality images for an accurate 2D assessment, sometimes with echo enhancing agents. But unfortunately, it is a challenge, and I think
That's
another quick question for long-term survey data for metastatic patients with hereditary. If these patients no CT or CT after 1 year, what is your actually recommendation for survey data for low-risk patients? For non-low-risk patients, is there any difference?
Yeah, so I believe the ESC guidelines recommend every 6, if I'm not mistaken, every 6 months after the first year for patients on maintenance therapy. I can't recall it was every 6 or 12. I think in patients who are low risk, our practice at my institution is really to give the oncologist the option. I think it has to calibrate, patient-specific risk. And, the patients with metastatic breast cancer tend to be older and have more cardiovascular morbidities. So I can say that I'm uncomfortable not imaging that at all. I think that a far reduced schedule of monitoring, whether that's annually or sooner based upon symptoms, or if it has multiple risk factors, or perhaps 6-month interval, if there wasn't, or if there has been any indication of structural change during that first year, perhaps that would have prompted you to do, a sooner 6-month follow-up rather than 1 year. I think you'd have to take all of those things into account. It's difficult to make it across the board generalization.
Good, thank you all.
Well, that was a great session. Let's continue like this. And I'm glad it was worth flying in from Japan. And I hope others feel the same, even if they're closer. And there's a reason why it's in Minnesota, because people wonder why we do this in Minnesota. There's nothing to distract. So you think, and not exactly talking. But I wanted to give kudos and thanks and congratulations to Dr. Blaes and Dr. Konety for putting up such a great conference. And we're going to hand it over to Dr. Singh, who's going to do an equally, if not more, superb conference in South Africa. And with this, I hand over to introduce our speakers. So,
thank you. It's a pleasure to be at this conference. Thank you very much for inviting us. I just wanted to say that, if you don't understand it, my co-chair, if you don't understand his English, he's quite happy to speak in Portuguese.
Oh.
Which he did once. So our first speaker, I think, is going to be virtual. Is that correct? Because unfortunately, he could not attend in person. He's from Tel Aviv. But I will introduce Zaza Iakobishvili, who you all know very well. And Zaza is from Tel Aviv. He is director of the Community Cardiology Department of Tel Aviv. He has established the first dedicated cardio-oncology clinic in Israel in 2013. And I must say, having visited his unit in 2017, if ever one of you have the privilege to attend, it's got the most beautiful museum of paintings in his basement of the hospital, which you will never see in any other hospital in the world. So, Zaza, I hand over to you, and you are going to speak on the management of coronary artery disease during and after cancer therapy. Zaza, over to you.
Thank you for the wonderful introduction, Dr. Singh. I want to congratulate Blaes and Dr. Konety for the last meeting and telling me even allowed me to participate virtually at the initial great conference. For the current situation in Israel, they not allow participant person. So without further delay, go further and slides. Well, these are my disclosures. And my task is to discuss the management of coronary artery disease management during and after cancer treatment. There is significant overlap between ischemic heart disease and cancer. And according to this with the conservative estimate, approximately 10% of patients with acute MI also have cancer, and up to 9% have a history of cancer. It leaves us with 100,000 cases each year around the globe. Observation by the increased risk of coronary artery disease because of sheer factors, cardiovascular toxicity of cancer therapy, and anti-inflammatory and thrombotic states. some of the examples you see from the guidelines of oncology, you can see, like accelerated personal and vouching can happen in androgen deprivation therapy, which generate Japanese. Even the checkpoint inhibitor therapy with developing melatonin probation therapy, VEGF inhibitors, versus one which can mean with Lyon Singapore therapy director of big or treating patients. And convert thrombosis with base and you can see here, right? A little marks, molecular antibodies, again, developing platinum chemotherapy, and so on and so forth. So there are lots of cancer-related treatment that are exposed to acute problems anyways. We're interested in this issue, and our first study, which we published back in 2018, on the basis of environment stimuli with water industry, we found that about 5% of acute coronary syndrome patients had the cancer, and 35% of them had active malignancy. In hospital complications of this patient, they had respiratory function and pericarditis for the first 30 days to follow, but more acute heart failure, more cardiogenic shock, more acute kidney injury, and more deoxidant fibrillation. While at 1 year, the patient with cancer had reduced survival on cause therapy. So much that a London observation study was published based on US database, which demonstrated that about 3% of acute myocardial infarction patients had cardiac cancer, and the number of cancer survivors increased all the time in this database, and reaching 80% in 2014. At least 50% of them were liquid cancer, you see here. Only about 40% of them are doing coronary angiography. And most of them are doing coronary angiography, and they were treated by PCR, and on the small minority were the Vlad challenge. Here you see the outcomes of this specific role. The patient with colon cancer and treated by the single mortality is twofold higher, at 11%, compared to no cancer. Means if 13%, bleeding is prohibitively high, 18%, and stroke is high, this is 0.4%. Another single center study from my company, which was published recently, showed that about almost 5,000 patients on HCS, only a small portion of patients had acute cancer. But you see that up to 1 year reaching hazard ratio of 5 very steady, and for non-stable patient like in coronary syndrome, hazard ratio was 2 for 1 year mortality. After Professor Singh mentioned, in active cancer patients, there were no differences in hospitalization during the days and family days, but they show higher shock and often mortality expected just for other comorbidities. So carrying cancer of direct acute coronary syndrome is not the same, especially for mix of other characters. The protein group led by Dr. Maros and Dr. Gafal published recently at the TFC Congress a few weeks ago in London, the data from migrant registry was published in Boston. And the evidence showed that the lone cohort of more than 300,000 patients, 2.2% had active cancer. And the cancer group underwent less coronary angio, were treated by dual antiplatelet therapy only in 85% of cases versus 95% cases of non-cancer group. And they had almost twice increased risk of bleeding at 1 year at a similar reduction rate. Higher bleeding rates was seen in colon and prostate cancer patients, and higher risk increase was observed in hematological malignancies. The consensus document was published for the evaluation and management of cancer patients with acute cardiovascular disease by ESC Cardiovascular Care Association and the ESC Council of Oncology. Was published back in 2021. This document stated that The same diagnostic evaluation in women for ACS and cancer or small cancer patients. They advise for echocardiography to see that to extend complications. They clearly call for invasive strategy in patients stemming in the high risk, non-sterile elevation active pulmonary syndrome, but advocating a conservative approach in stable domestic ACS with poor conceptual knowledge and for high negative risk. These concepts were further developed in the field that 2022 ESA Oncology guidelines and in the advice for temporary interruption of cancer therapy if the cancer therapy was suspected and consequent cause. And short duration of drug-related therapy was should be considered in patients with very high bleeding risks. Including class 3 to not use recommendations advocated, and they are as follows. Don't use aspirated if platelet count is less than 10,000, and the same application if the platelet count is less than 30,000, and use transfusion because of pocket combined and converting only if you have a patient with platelet more than 50,000 and they have low bleeding but excessive convoluted waste. Recent data reviewed meta-analysis from European Heart Journal this year by Marian calls the recommended to use this algorithm for chronic artery overlapping resistant cancer patients. First, they find the first overbility of chronic artery syndrome. If intermediate or high, you can go for coronary CDRTO plasma protein death, which is justified in the first step, followed by coronary angiography for high-risk grading, and then you have to evaluate the veterans with multidisciplinary team to decide if the patient is advised to be maybe conservatively, or you can offer invasive coronary reduction. Important to note that in the most recent real-life registry, these patients are undertreated by blockers, AC or ARBs and statins, prognostically significant agents. Radiotherapy coronary medicine remain particularly challenging for PCI and carriage, with the extensive mediastinal fibrosis and a severe underclassification, which may include the memory-active convoy for vital surgery. On this slide, you see the incident from the same variable, incident rate ratio, all-cause death, and cardiovascular death. As I can see that for all-cause death, we have relative risk of death in cancer patients in 2.2, while there is no difference in terms of cardiovascular death. So PCI, according to the patterns, is very beneficial indicating to prevent cardiovascular death even in the chronic coroners and right patients. But there are no free lunches. No, we have a very high bleeding risk in cancer patients and accepted bleeding source out of the for cancer patients. With this in mind, the same group of Dr. Zaza and Maros imagining the published recently in European Heart Journal updated measuring the cancer risk score when they include binary cancer score. As you can see, additional binary cancer score allowed to reclassify more patients high risk group, but the model statistic was quite unsatisfactory, 0.64. In summary, a sizable portion of CND patients have acute cancer or cancer history. Their short-term ischemic outcomes in HCS are better now after patients, but long-term all-cause mortality is at least twofold higher for non-stemming and maybe up to fivefold more for stemming. Acute cancer itself should not be a reason to inform coronary hospitalization. Multidisciplinary discussion is key, especially chronic innovations. For antithrombotic therapy, use a shortened possible duration. A topical-based regimen probe is preferable. Cancer history addition for blending with prediction tools, like precise blood cancer, may include patient safety and outcomes, no better recognition of their diabetes profile. Aggressive coronary structural modification may involve the cardiovascular outcomes of HCS coronary column assist patients with cancer. Thank you for your kind attention and for having made this wonderful video. Thank you.
Thank you, Joe. I think in terms of trying kind of speaking your panel of questions, right? So I really think I have privilege to introduce the second speaker. That's Vlad Zaza. He is an associate professor in the Department of Internal Medicine at Southwestern Medical Center, and is a member of its cardiology division. He's one of these clever people that got his doctoral degree cum laude, and he's going to speak to us on valvular heart disease in cancer survivors. Vlad, I'll hand over to you.
Much for such a kind introduction, and thank you, the hosts, for inviting me. This is a wonderful meeting that coming here in following the imaging diagnosis focuses on the valves. So let's see if this works for me. Yes, I have no conflicts of features. And in the next about 10 minutes, I will provide a high-level overview of what is the impact of valvular dysfunction in cancer survivors, the diagnostic modalities, and some of the current therapeutic options, and thinking about where the future goes. So first of all, who are cancer survivors? Maybe just to reiterate what Dr. Konety was mentioning yesterday, and to bring up these 2 points from the American Cancer Society and NIH, they are saying pretty much the same thing, that anyone who has been diagnosed with cancer, no matter where they are in the course of their disease, are cancer survivors. So that means time point 0 is the diagnosis. And any individual is considered a cancer survivor from the time of diagnosis through the rest of life. So this brings us to time point 0. And as it has been reviewed here, we have to also know about the valves. So who are the patients at risk for having valvular disease? When to assess the valves? How to detect and evaluate valvular heart disease severity? When to intervene? What are the intervention options? With the nuances that are specific for cancer survivors. So then we go back to the guidelines, to the ESC 2022. And the main imaging modalities are how we would approach this. But what we find is a small paragraph that tells us that we need to go back to the general guidelines and look at the valvular heart disease, because it becomes quite specialized and quite complex. And this is what is happening on the 2 sides of the Atlantic. So we have guidelines both in Europe and US, and looking at each individual valve dysfunction, there are agreements and disagreements. So the key part is to keep in mind the agreements regarding the aortic stenosis, which is one of the primary concerns, aortic regurgitation, and then going to, so on the left side of the heart, look at the mitral stenosis, mitral regurgitation, again, focus on the consensus, and not forgetting the right side of the heart. So what I will do, I will take a couple of examples here on the right side, on the left side, and try to provide some outline of how the workup works. Thinking about the valve disease, in patients diagnosed with cancer, radiation-induced heart valve disease is probably the primary one. Carcinoid valvular disease, it's secondary, especially for the right-sided valves. Not the least, but probably the least investigated for now is chemotherapy-induced valve disease. So there is some evidence from Lyon that chemotherapy can also result in valve disease. If we focus on radiation-induced valvular heart disease, so remember it comes in the context of radiation-induced heart disease that was reviewed in detail yesterday. But then going specifically to the heart, the valves are again one component of the entire heart structure. They are all in the same plane, and they can be exposed to radiation. The most significant changes are, though, in the aortic valve. I'll bring in a case here just to illustrate how complex a patient might get. So 55-year-old woman with a history of Hodgkin's lymphoma, 1987, status post ABVD, so including chemotherapy, doxorubicin, and mental radiation for to Grace, presenting with a heart arrhythmia. Looking at the vital signs, nothing really remarkable. NT-proBNP is elevated, and a range indicating heart failure, and an all troponin with a metabolic profile with the lipids showing an LDL at 95.8 with high dose of rosuvastatin. And looking at the imaging studies, there is severe MR, there is moderate aortic stenosis, and moderate aortic regurgitation. So going back to the guidelines, what is the management for moderate aortic stenosis and regurgitation? It comes in the range of it's similar to aortic stenosis and what indicates valve placement. Now, if we go back now to think a little bit about what means mediastinal radiation and some of the evidence, but this series of patients are relatively small, retrospective. This is an example from 2017, 172 patients out in Cleveland Clinic, where 95 patients, so 28% of the patients in the series died within the 5.7 years of follow-up. But interestingly, the mediastinal radiation resulted in a hazard ratio of 8.5 in that specific group, while patients with severe aortic stenosis without mediastinal radiation had an STS score with the elevated STS score has a hazard ratio of 1.1. Now, what do we do with the patients? So in the era of TAVR, right, that has ramped up amazingly in the last couple decades, compared to the surgical aortic valve replacement following mediastinal radiation therapy. So this is a small proof of concept study from Mayo Clinic where evaluating the outcomes of patients post-TAVR and TAVR. Once the baseline characteristics are adjusted, there is a significantly increased risk in the patients who have surgical valve replacement. So this was followed by several other retrospective studies that have looked at what is the outcome of patients following valve replacement or using surgical or interventional approach. And it summarizes the current evidence regarding evaluation of patient risk, evaluation of vascular disease, and the importance of the communication between the different components of patient care, of the patient care team. So here are some of the data that are highlighting that TAVR has that in-hospital mortality is lower following TAVR procedures compared to TAVR procedures. There is a 40% reduction in all-cause mortality in one series with patients with TAVR. And there is increased hypertensive mortality in the patients with TAVR, and there is overall worse midterm outcome. So the decision follows a tree, then depending on what is the severity. So in patients with severe aortic stenosis, depending on what is their surgical risk and what is the overall risk of the patient, what are other interventions that are required, patient would be undergoing TAVR or TAVR. So this is a complex decision that involves discussion both with the surgeons, with the interventional valve team, and with the oncologists. So what TAVR becomes today, it was what primary BCI is for STEMI. So it is a recommended procedure both for patients newly diagnosed with metastatic cancer on first line of treatment
or even on second line of treatment, depending on what is the genetic makeup of the tumor, what is their state of, especially the state of frailty or functional status, and what is their expected survival. But shifting gears a little bit to the right side of the heart, an example of the constitutive heart disease, which is it's a disease caused by a neuroendocrine malignancy, most commonly originating from enterocarotene cells in the gastrointestinal tract. With the relatively low incidence, only 1 in 100,000 people, but these patients may be concentrated in your cardio-oncology centers. The tumors grow slowly over years. Patients have no symptoms, but when they present with symptoms, they have a carcinoid syndrome. And 70% of those patients will have cardiac involvement. So another example here, this time, I think this might be an old slide. See it, this was going through it. So here's the example. So the clinical case of a 42-year-old man with a history of malignant neuroendocrine tumor, liver metastases, presented again with a heart failure. So in this case, his BMI was decreased at 20, with relatively low blood pressure, with a heart rate of 95, with 3+ lower extremity edema, with elevated NT-proBNP, with an echocardiogram showing severe tricuspid regurgitation and moderate pulmonary insufficiency. So what was performed in this patient was combination of an interventional therapy due to his limited functional state. So initially, he was not able to undergo surgery. Fortunately, benefited from the FDA approval of the Harmony Transcatheter pulmonary valve system, which allowed to implant a valve in the aorta. And secondly, he was able also to benefit from a novel procedure, mini thoracotomy, where instead of the sternotomy, there's a right lateral peristomal incision, which allowed him to implant a bioprosthetic tricuspid valve and discharged from hospital in about 3 days. So the patient completed following this treatment peptide receptor radionuclide therapy for his liver metastasis, and he was able to regain his BMI to 23 and was back to baseline physical activity in a few months. So this is an example where technology is today. So we have implantable valves on both for the left and the right. We have complex procedures that can be performed in such patients. And just to close back here on the patients that are presented with the aortic valve, just go back here. So what happened with the first patient, looking at the left side of the heart, what she received was a surgical procedure, a complex surgical procedure. She was quite a coronary artery disease and had a mechanical mitral valve, a mechanical aortic valve. Our medical therapy was expanded to include SGLT2 inhibitor, warfarin due to the valves, PCSK9 inhibitor, and then circumventricular valve sultane. And what her history followed was at the time when I met her a couple of years later, she required percutaneous closure of the mitral paravalvular Blaes due to the underlying radiation toxicity of the myocardium. And then with all this, having her valves, the valve disease addressed, 4 years later, when she was diagnosed with new breast cancer, she was able to undergo surgery. So with these couple pieces, I want to shoot now for a couple slides to what does the future hold. And that is quite exciting in 2 ways. On one side is the access to data. So patients are already wearing devices for monitoring of their heart rate, and some of them can have a stethoscope and a crunch stethoscope that can transmit the data. This may be followed by a point of care ultrasound that can be
brought to the patient, and then the diagnosis can be integrated into an AI system. So these are already efforts that are happening, and then the patient arrives then in the hospital with a different degree of disease that was caught at an early stage. And I would say not the least, there are also efforts into creating regeneration of valve in situ. So there are new studies that are looking at implanting temporary valves that are bioresorbable, and they're replaced gradually by the growth of endogenous valves. So with this in mind, the take-home points for today are that valve disease can be a result of cancer treatment, but it can increase the risk of cancer therapy related to cardiac disease. The early diagnosis of valve disease in cancer survivors is critical, and the optimization of hemodynamic parameters is important for maintaining the valves on the long term. And the timely interventional or surgical treatment requires multidisciplinary communication with multiple teams. So thank you.
Thank you, Vlad. Our third speaker for this session is Zaza. He's an interventional cardiologist interested in vascular biology in cancer patients. He's professor in the Department of Cardiology at the University of Texas, MD Addison Cancer Institute. Over to you.
Thank you, Dr. Singh and Dr. Hardiman, for the kind invitation. Going to go ahead and get started. Really nothing to disclose. And actually, I'm going to start with a question. Talking about the challenges. I'm going to ask that question for the audience. How many of you are cardiologists in the audience? How many of you are only cancer patients? So beautiful. And I think that's why, from your perspective, most of the data presented, you can see, it's actually part of the left side of the slide, is general population, where 10% of the patients do have cancer. How does the world look like from the perspective of those of us, which is just cancer patients, where just 10% of the complications are cardiovascular complications? The second one is, we do not do a lot of things because we're seeing things as having high risk. The question is, if I were telling you I'm an oncologist and have 90% of doing a therapy to have a patient alive in 5 years, it would be like a successful cancer story. But if I tell you the 10% cardiovascular complication, we call it high risk and we don't do those procedures. So it's very, very interesting. I'm going to really challenge you all to think a little bit outside the box. And some of us have been there around the globe where we did procedures where the risk of survivorship was really 10%. We did those procedures and we moved the field forward. You're going to see the story with pericardiocentesis and how we move that from something that's really contraindicated or really sometimes suggested not to be done to where we do it on the standard basis, and our fellows, all our fellows do those procedures. The bottom is this: we're talking about pericardial effusion, we're talking about myocarditis, and I'm going to just focus in the setting of immunotherapy. Really the field is too broad, and then of course I'm going to talk about direct involvement from the tumor or from the metastatic disease. And where we started, So for those of you, so I'm considering myself like, I'm not going to say anything. I'm going to stop because I was thinking about age considerations, but okay, I'm somewhere in the middle, okay? So the bottom is I trained with a harpoon. So we did pericardiocentesis with a harpoon, okay? For those that do not know, it's a big needle this size, and the tip of that needle cuts like the scalpel. So when you're doing it, it's fine, but when you train someone to go with a scalpel towards the pericardium, it's really challenging, as a mentor and a trainer. And on top of that, you add pericardiocentesis and patient low maintenance. You don't really realize now why that procedure is impossible, okay? So we had to evolve to where we do it on a seldom basis and really on exceptional ways to where it became standard. And our initial experience after 5 years, you see the numbers, we did it over 5 years and basically had zero mortality. And then how did we do it? How did we end having zero mortality? And this is our cardiac cath lab setting, and you can see that we use basically triple guidance, like really need precision. Oncologists to talk about precision in everything we do. And sometimes we talk about this very broad, large data, and very non-specific. It's very hard to come on precision when looking from the airplane. So that's why we move very, very close to the patient. We do all this procedure in the cath lab. We see oral. You can see the second error, which is towards the ultrasound, the sauna side, and the third one is the echo check. So we all looking at all those elements to make sure you're able to accomplish this procedure in all the patients. And what's interesting is you can see that we did 200 patients initially. We're always successful. Like we missed one or two, and those procedures we've learned actually the micropunch needle did not reach. So it's a 12 centimeter needle, and it did not reach. So we tried not to bleed the micropunch excess. You can see the bleeding was not related to the thrombocytopenia. So the bleeding was respect for the platelet cannot, to learn from this initial experience, keeping the drain 3 to 5 days is actually decreases the recurrence rate to 10%. So we came up from this initial study that we can do it irrespective of the platelet counts, and we can keep the drain at least 3 days in this patients with pericardial infusions. Going further, we can also, there was something unique to the patient again malignant pericardial infusion. You did not need any studies to know those patients not going to do that well, And of course, the platelet counts are less than 20,000. That's a prognostic of severity of disease in cancer patients. So the lower the platelets, the lower the cancer disease is. So they're not going to live that long from disease, not from what we do. Of course, lung cancer is not, an initial experience. The lung cancer patient was not very well. But what we learned from that initial experience is actually not all malignant pericardial infusions are the same. And actually, breast cancer patients live as long with and without malignant pericardial infusions. So that was good news for our patients with the breast cancer, and also good news for the lung cancer patients. Of course, all the drive of this mortality in patients with positive malignant infusions were from the lung cancer patients, actually. Now, that being said, we evolved. So after the initial experience where we did all these patients, we said, how about moving our boundaries? How about the thrombocytopenia? A good amount of our patients in the hospital, a third of them actually had hematological malignancies. So there were a third of patients were basically non-treated. So what we've learned from this initial experience, of course, thrombocytopenia is relative contraindication, but nobody was doing platelet counts 99,000. What else we knew about it? If you look at our patient population, 2/3 of them had platelet counts less than 50,000. So really severe thrombocytopenia, and you're going to see why we're coming with a 50,000 cutoff. And it's another interesting concept that everybody talks about, you have low platelets, transfusing platelets. For those that have not done, a pericarditis in a patient with tampon at the low platelets, the story is this. The patient comes in tampon at the platelets 10. The lowest actually we've done was 4, actually. So the patient comes platelets 4, so you waited blood platelet transfusion. By the time the platelets come, you have to recheck the platelets to make sure they have a good response to that one. And surprisingly, the platelet count goes from 5,000 to 10,000. Does it modify the risk with the procedure? And the answer is no. It's still high risk. The way is the patient was stable initially at 10 o'clock in the morning, and now we're talking about 6 o'clock in the afternoon. Patient is a birth time on a cannula flat, so it's almost vertical, and then you have to do the pericarditis, and then you should have done, 9 o'clock, 10 o'clock in the morning with those platelet counts. So that's why I have to introduce this concept of platelet refractoriness, and really we do not wait for the transfusion. So if we have it, we put it on course. We try to get as much as we can, but the bottom is if we don't have it, we don't do it. And what we've learned actually in this initial group, 59 patients with severe thrombocytopenia, majority with hematological malignancies, is a platelet increase was 5,000. So basically, you move from 9 to 14,000. It's still high risk, it's still complicated, and a lot of them have refractoriness to platelet transfusion. Bottom is another thing that when we look backwards was, we talked about valvular disease that improved survivorship and TAVR improved survivorship about 23%. It was a revolution, but you never heard about the revolution that pericarditis did in cancer patients with low platelets. Because if you look really at the other end of the spectrum, if you look at it, the bottom is, its true survivorship is 20% at 1 year. The patient platelet counts less than 20%, but it's a 20% survival. Those people are alive at 1 year. Otherwise, we would have no one alive at 1 year. All these patients, if they're really over tamponade, if they're really sick, they would not make it tomorrow. So that's the problem we have. So the discussion is everything we're doing in this patient is improve survivorship. And then, but if you look at the 50,000 platelet cutoff, of course, survivorship is 50%. In average, it's 27% survivorship at 1 year. All these patients with low platelets and pericardial infusion that underwent pericarditis and tissues. We were privileged to write this, how we do it. And really, it's in JAG where we go through all the steps. And sometimes, I'm too didactic in this discussion because we keep on teaching our elders how to do this procedure and how to do it safe. But the bottom is we ask them to scan. You scan with your own hand. You feel the angles. You scan some side for it. You scan atypically. You see how you can get access. The second one, we measure the distance from the probe to the space. And there are two types of micropunctures. One is short and stable. The other is 12. And you pick the micropuncture based on the length and the space you have to get to the paycal space. And you have to be comfortable in both approaches, either lateral or subside. And you can see on the screen, the first one is lateral because patients are low. You try to go to that space. If you have a bleeding complication, at least in the thorax, and you can put a chest tube in. But if you bleed and the liver bleeds, everything is going to be in the Douglas pouch, and you cannot stop. Once you touch the liver starts bleeding. It's unstoppable bleeding. That's the only way you can lose a patient. So again, high threshold really to go subside of patient population. And again, you're going to see like this patient, we had no way around. The apex was all adhesions around the tumor and the mass, so you have no way around it. And we do those procedures. But again, obviously it's the full on option on the initial approach. That being said, is how we came up with the cutoff 50,000. When we look back at patients with acute coronary syndrome, and we did this thromboelastogram, and this is an example of the thromboelastogram. I'm not going to go into details of how we do it, but the bottom is 50,000 and above, the thromboelastograms are the same as above 100,000. So we call now thrombocytopenia if you go 50,000 and below. 50,000 and above, we treat all these patients standard of care. Doesn't matter, really. If it's ACS or thrombocytopenia or everything else, it's really standard of care, no hesitation. But if the platelet count is less than 50,000, we usually check as an element of reassurance. If the check, that being said, is in acute setting, you don't have factor check. In that situation, you have to replace all the three elements. And there's a lesson for today, is if you really have to do something, the patient is bleeding, you do not replace only platelets in thrombocytopenic patients. You have to replace plasma because the R is prolonged. You have to replace with prior precipitate because the angle is modified and the maximum amplitude is the one that's driven by the low platelets, and then replace the platelet. Again, all three of them should be considered when you do the replacement. Again, when you go in the paycal space, it's always a surprise. Of course, and you're lucky if it's serious, we secure this page with a wire actually. We do not inject bowels in that one because we have the floor, we can see the wire in the paycal space. If it's in pleural space, we direct. If it's in an abdomen, we direct. But we don't want to lose the opportunity to do one sneak and to get in the paycal space with one sneak and no losing the space to do the bowels. So if it's serious, we secure the space. If it's bloody, then we have to inject the bubbles. If it's like this, you have to call the surgeon. And of course, we have some other colors as well. And that's not the topic of today. It's usually the topic of an M&M. But anyway, anything can happen. This is the typical patient. It's always challenging. This is like the skin access. And again, we had just a dot of skin, plain skin, and that's the way we got the access in the paycal space. This is a patient that can see where we're actually confirmed with the bubbles, the paycal space, but the wire goes all the way to the thyroid because the patient had a sinus mass, and of course, when you open the space and the communication that got closed from progression of disease, you can have these patients are sick patients, they have abdominal distension, and this is the colon distension that really made it challenging. Any access both subsided and apical. Of course, these are local apical diffusion. The first time is easy, but how about these patients that come the second time and the third time, and they're still not surgical candidates? So you have to have the fluoroscopy to get access and to advance the catheter. And of course, sometimes it goes to the tumor, you're going to see that. So we really need to make sure the catheter lands in the paycal space. This is, of course, it's a big procedure. It's very worrying for our fellows. They really feel good. They finally learn the skills to get out and to save a life. But the bottom line, sometimes they're doing good gastric. They show like a trophy. This is how much we got out for the patient. Again, when you lift it back above the heart level, all the air we had in the tubing, you can see now myocardium. So that's why a lesson is, always keep the bag behind, below the heart level. So again, it's a trophy true, but do not go into the patient immediately to disconnect it. Then you can show it. The last one I'm going to say 2 words about the predictors of recurrence. And what we've learned is really the predictors of recurrence is, first of all, the younger they are, the more aggressive the tumor is, it's very likely it's not going to come back. The second one is we use NSAIDs early. We learn the lesson when we leave the drain in, we try not to use NSAIDs or the colchicine acute space, so we let the catheter score. We send the patient home on colchicine on NSAIDs, so we give the initial phase, allow some inflammation of the drain in the paycal space to do it. Of course, acute ones or immunotherapy very unlikely going to recur. The second story, of course, we use, I'm going to go fast through these. We use colchicine again. We have data from Korea. Actually, I think it's a good drug, and the anti-inflammatory properties of it will reduce, as well as steroid in some specific situations. Immunotherapy is associated with pericardial effusion and pericarditis. What we've learned in our beautiful study that Nick Velasquez did for us is not all immunotherapies cause the same pericardial effusion, and you have options. You can see needle and pepper where the most likely associated with the pericardial effusion, but not EP, so you can trade one for the other one if you want to, you worry about the pericardial effusion recurrence of it from an oncological perspective. And a nice algorithm, but of course, DOACs, we use it all the time, but DOACs can be associated with hemorrhagic effusions. So always be considerate and think about it. You have a patient with atrial fibrillation, you put them on DOAC, they come really miserable, short operating few days. That's DOAC related and keep it in line. Pericardial sarcoma, and probably this is one of the most impressive one. You can see this circumferential mediastinal mass, and patient in the month get back in time on up here, but there's a drain through all that mass, all the tumor. It's not easy, it's not surgical, it's just palliative. And again, we have this palliative cardio-oncology component to our service that's as important as all the palliative services as well. Now that the Halloween is coming, I wish you all happy Halloween parties and have fun. We had fun as well. This is the super low-plane pericardial effusion. You can see, we could not see it by echo because guess what? The bubbles were in one loculation. So until they traveled to the last loculation, it was really challenging. So because we were the cath labs, we were the wire through all these loculations, so we broke them. And again, we had, since we published this paper, probably another 3 or 4. So it's a situation where, again, fluoroscopy is extremely helpful in my cath lab situation. And to conclude my talk again, pericarditis, again, we get close to 600 of that, out of which 200 solid were done in patients with extreme prothrombopenia. Knock on wood, it's not lost a patient, but again, you saw that with guidance. The magnitude of what we do is compared to TAVR. And again, it's at the other pole, at the other spectrum. You know, we have survivorship like 80 to 90% now on the TAVR side. On the pericardial effusion, we have, 20 to 40 on the other end of the spectrum, but they're still survivors. They're still doing it, and this procedure, and it's life-saving. We find useful to keep the drain a little longer. Focus is helpful, again, after 5 days usually. And the key to success is all of the team that we have behind. And I have to thank you, a lot of people. And of course, to do these crazy cases, you need someone to have your back. So I thank Lenita for being here and having my back, so when I'm going to get in trouble.
Thank you very much, Zaza, and other two speakers, Zaza and Vlad, for an excellent session. I'm now going to hand over to Iakobishvili to handle the questions.
Yeah, so I think, first of all, I would say fantastic talks, and I think it's true what's on the web for Dr. Liesco. It's that patients say, you literally saved my life, okay, when you get the sense. But there have also been introductions where they say you're a fighter pilot in interventional cardiology, flying over the war zone with 1930 cardiovascular disease. And so one question before, I would welcome them, is that obviously comes up, and then I hand it over, is which patients can you monitor? Where do you need to get the needle out of the pericardial effusion, and which patients, based on your experience, can you wait that actually go to that?
Thank you, Org. Actually, it's a very challenging question for many reasons. It's these patients' effusions do progress, and we have the option of doing it daytime, the triple control, and the cat versus emergency at the bedside. So we've evolved, and again, Anita's here. So we have trained all our young faculty are comfortable doing these crazy cases. They usually call me and say, it's easier, I have complicated cases, hold my hand. And I'm kind of feeling bad right now because nobody's calling. So they're so good about doing it, so they learned all these steps and they're all doing it. So it's not that complicated once you cluster. Again, Jack is a great resource. It shows really all the steps you go. When we do not vary from those, we like CTs, to see exactly, because the patient lays on the back, it's almost guided pericarditis. And we do it daytime. So we now almost even moderate to large, would rather favor doing it and having control and doing it in the morning when all the teams are available. If you need extra hand, you have that rather in the night at bedside. And you've seen that it's dramatic. the anatomy is complicated, they're long related. It's not easy to do that at bedside. So to do that really is triple guidance, like it's a must.
Right.
Thank you for the excellent talks. When do you call the surgeon for a pericardial window?
So this is a very good question. So in our experience over the last 15 years, we probably done by, in a measure of what we're doing. Again, I know it's outside what you've heard before and everything, but the belief is that windows to close as well as our drapes. And the belief is the patient goes through a surgical procedure, is going to have another redo and everything. That being said, is of course, we have the bats of the procedure, video assisted, so you go on the other side where the tumor is not, and you do the window on that side. And of course, that can happen. But these are patients with lung cancer. They do not, they'd rather, they'd rather have us do it. So we've got twice, 3 yards. We have people who've done 4 or 5 times back, and we should do those exterior sacraments. That's a good idea. Or show experience, but they very, very seldom do it. The only situation where we've seen them evacuating the space when we use the micropuncture and the fluid is so gelatinous that cannot be evacuated with the micropuncture needle. And we're not comfortable to go with a large needle, and then we get upset for having to do it. It's the only situation where we were not able to go to the procedure.
Yes. Oh, again, wonderful talks. Just 2 quick questions. So you gave me wonderful slides, and at the end you pointed out that just is there a varies the duration of colchicine use in this population based on capacity and enemy average? So the second question is really focused more on therapies like IL-1 blockers. And what is the experience or use thereof this population?
So I heard the first question, again, the data dropped from 3 to 2 months, and again, that's the option, so even go for 2 or 3 months, I'm not sure what you all do, but that's where we are. So we've never looked as far as they looked at the patient's colchicine and how they use it. So we use their data and their reference for how we use it and how we use it. And I didn't hear the second question.
Really, IL-1 blockers.
Yes, so CPIC and Nick is working on this one, and we have a interest in that aspect as well. And we believe it's a role for those, but how impactful that is. But it's a go-to log should be fail with the head and with colchicine. That's the off we go, and it's running this clinical, recurrent and probably fusion and recurrent pericarditis with dialysis.
Thank you.
One more pericardial use question for you. So a issue that we run into commonly are effusions that continue to drain beyond 3, 4, 5 days. So what is your approach to those cases? Do you use sclerosing agents? If you do, what has your experience been with that?
Again, probably I agree with you. We have water chill in 100 where we have this issue where we keep them beyond that. We started antibiotic therapy to cover for possible secondary infections, keeping the drain longer than 7 days. So that's the biggest issue we thought we faced. Of course, now it's a situation where the surgical should be involved, should be taken care of. We've done sclerosing agents initially. We probably did it like 13, 14 years ago. It was a nightmare. We were not able to distribute that. We probably didn't do it right. And I think the experience is from Italy where they did a superb job and they were so happy with them. We tried to replicate what they did and we just got ovulation and then we got more pockets and we got so more challenging pericarditis tissues to do after that one, where it was almost impossible to do them in uncontrolled pace. So I'm not sure how they were able to distribute the Depa or whatever they do with the brain pulse space that are homogeneous because we're never able to do it. And neither of the practices, to be honest, for so many hours at the bedside to try to make it happen with some optimal results where we get the better.
Great. I think in the interest of time, we have to move on. Next year, we're going to do a live case, maybe.
Actually, fixing to come to you, is it?
Okay, everybody.
now for something slightly different. So one of the highlights of this year's meeting, which is the grand debate. Now, those of you who looked at the program will see that Dr. Ron has been given a year off. So, but that's not a problem because we've got two fantastic speakers. In the blue corner, representing cardiology, is Dinesh from Toronto, and in the red corner, representing oncology, is Anna. So, and they're going to take on a topic which I know is very complex for lots of people, which is about how does the ESC guideline get implemented? Did we get it right? Dinesh was on the task force and so has insights into what we went through to produce it. And is a consumer of the guideline as an oncologist and what did her sort of real world experience. And I have the pleasure of co-chairing this with Jörg. Jörg was a bit cheekier and to suggest that Minneapolis didn't have much going on. We've had a great time, those of us visiting here, including the American football and the Vikings. And that's coming from some NATO clinic. So anyway, we'll pass on to you just to say a few comments and then start the debate.
Yeah, I really can come down one because you brought them colors, so this is not a political debate. I feel it's such a thing that they're probably next year. But I think we'll go ahead. I think Dinesh is first, and then we'll hand it over to Ned. So we'll have to see. I mean, we have a proponent for the guidelines. Right? So there's going to be Dinesh elaborating on it. Hear from him what she might question about the guidelines.
They'll have a chance for a little rebuttal, and then if possible, hopefully some time to open it to the audience for questions. And so over to you, Dinesh.
Hey, thank you very much. You guys really filled it up. So it's going to be okay. So the debate we're having is the ESC ICOS cardio-oncology guidelines. Are they ready for implementation? I've been given the task of debating that. We are absolutely ready for implementation. So let's just go through these guidelines. So the only disclosure I have is that I'm here to argue the position I'm giving today. I have no intention of offending anyone personally. I apologize. And so I did a bit of searching large organizations like the WHO, and then I asked the question, what are guidelines? So this is what I put together based on what I've read. So the guideline gives recommendations, interpretations, administrative instructions, best practice guidance for frameworks in which to operate. Guidelines are informational, not mandatory, and definitely not gospel or law. So the development of guidelines is important to any field, even the field of cardio-oncology. However, the key is the transparent nature of these recommendations. How do we achieve this? We make these recommendations transparent by providing classes of recommendations and the level of evidence for the recommendations that are made. So let's look at the ESC guidelines. ESC guidelines were published in August of 2022, presented at the ESC meeting that year. There are 272 recommendations in those guidelines. Who were participating in these guidelines? Well, this was written along with the European Hematology Association, European Society of Therapeutic Radiology and Oncology, and the International Cardio-Oncology Society. Arguing, people who have a vested interest in the care of these patients, who are stakeholders in the care of these patients, were involved in the development of these guidelines. So not a bunch of cardiologists who have an interest in imaging, but people who really take care of patients. So what are in these guidelines? Let me break it down for you. Let me go back to the prior slide. So in the guidelines, there were grade 1 recommendations that were, again, about 57% of the recommendations. So there's general agreement that this should be done. A smaller proportion grade 2A that should be considered, and then a smaller proportion grade 2B, which is maybe considered, and a smaller proportion grade 3. I also want to bring attention to the levels of evidence, and this is broken down into 3 categories. Level of evidence A is really multiple randomized control trials of meta-analysis, and we all understand that that's limited in the space of cardio-oncology, hence this accounted for only 3% of the recommendations. Level of evidence B, moderate level of evidence, that's also limited in about 21% of the recommendations were level of evidence B, and 76% of the recommendations were level of evidence C, which means that this was really the consensus opinion of the experts from the
panel. So let's look at that a little bit more. Let's delve into that. So how were the ESC ICOS cardio-oncology guidelines created? First, there were 30 experts that were practicing clinically, so involved in the care of these patients, who came together to put these guidelines together. There was a strict policy of conflict of interest as to who could participate in these guidelines. We had multiple whole-day committee meetings over 2 years during the pandemic period, virtually sitting in board sometimes, trying to come up with these guidelines. We had a committee that was focused on formal literature reviews. When we had any questions, we had a group of individuals who would do the literature review to provide us the data that's out there to help support these recommendations. That's your formal already. You needed to have 75% agreement between the experts on the panel for a recommendation to put forward. If it was 74% and was 72%, we painfully went back through those recommendations, modified it, changed it, made everybody happy. We went back and voted for it again, and it had to pass the 75% bar before the recommendations were included in the guidelines. But the most important underlying theme throughout the 2-year period was that these guidelines were developed with the intention of improving outcomes in our patient in a field where the evidence is still emerging. So what are unique about these guidelines? I want to highlight a few things. First of all, this is a comprehensive capture of cardio-oncology. I repeat, this is a comprehensive capture of cardio-oncology and hence 133 pages. What do we cover in these guidelines? Well, we cover the entire spectrum, entire patient's cancer journey, from the time of diagnosis, during treatment, the first year after completion of the therapy, and in long-term follow-up. For the first time, although we all have been talking about this, the ESC guidelines recommends that we should not be thinking of all patients the same. We need to risk stratify these patients. We need to think of patients at low risk, moderate risk, high, and very high. And not only did we say that, we provided some guidance, again, based on expert consensus, of pro formas that we can use for 7 very commonly used drugs that are cardiotoxic to help us risk stratify patients. And the guidelines really focused on titrating our care based on the risk of these patients. For those of you who complain about 133 pages, there's the pocket guideline. You can download it. You can use it before you go in and see your patients. You can easily look at some of the pro formas and some of the recommendations in this handout I put in this out. We have tried really hard to make nice infographics like this for those people who are providing treatments and cause hypertension, or when you have myocarditis, you can use these nice infographics to help with the care of these patients. So on the left-hand side is management of hypertension, where the cancer therapy outcomes are on the top, the blood pressure is up on the y-axis, and there is the evidence or the data as to what should be done in the middle. On the right-hand side, you've seen this before with Myocarditis. There's an algorithmic approach to help you. So despite this being a long set of guidelines, there are really key figures like this that you can take out as an oncologist to put it up on your wall, or as a cardio-oncologist practicing and taking care of these patients. We're able to really have this guide us in our care of our patients. So how do the guidelines care? The first is that the guidelines have to try to standardize the care of these patients. So what does this mean? In an attempt to standardize the care of these patients, we are essentially asking individuals to practice similarly around the globe. We understand that it's not all possible, that there are limitations, there are resource limitations, and you have to adapt the guidelines to the institution which you're practicing. But the strength here is by trying to standardize how we care for the patients, we can go back a few years later, collect all of this data in a standardized manner, analyze the data, and help improve these guidelines and help improve the care of our patients. Now, we've done that with the best evidence available. It's not that the guidelines committee did not want to look at the evidence out there, but this is the best evidence available. But you and I know that tomorrow we have to go and take care of a patient who's referred to our program with cardiotoxicity. We need sound guidance. So in the absence of perhaps evidence in some areas, we have come up with a curated expert opinion. This is an alternative, no evidence and no opinion. So this expert opinion of problem. So I took a bit of time to go through our guidelines that we follow in our routine cardiology practice. One is the ACC/AHA valvular registration guidelines. For heaven's sake, we've been treating patients with valvular heart disease as far as I can remember. There has been so much work done in this space. But in the ACC/AHA valvular registration guidelines, 20 to 25% of the recommendations are just based on expert opinion.
We also have a document that we can take to payers, that take to the institution and say, the recommendations here are that this should be done. And we have a document to use to support our arguments. It's also important, this has a tremendous impact on the research. It is a document that has curated the most important aspects of patient care and has provided a level of evidence. So somebody coming into the field can pick up this document and say, these are the important questions. These are the levels need evidence. Let's work on this as a topic, as a research focus. That means that we are doing the research that's going to generate data that's going to change it from the practice. So this is a tremendous source to promote research in this space. So of course, the million-dollar question comes up over and over again. I'm sure I'm going to hear about this from Dr. Blaes and many others. Have we gone too far? Are we overspeeding? And I can't address the entire guidelines, but I'm going to focus on something that Dr. Blaes is familiar with, which is pluripotent breast cancer. So let's look at the recommendation for biomarkers. So biomarkers, at the beginning, the recommendation said, if you are going to follow patients, that's your decision. If you're going to follow patients with troponin and DNA, you should have baseline measurements. And I can argue that is helpful. There are many times I've got somebody that's referred to with ICOS therapy, be coughing and somebody into troponin. The troponin was 50, and I'm stuck saying, is it new troponin or not? So I think it's valuable to have a baseline if you're going to use troponin or DNA and follow patients. In the low and moderate risk patients on the top and high and very high risk patients, there's suggestions for consideration of biomarker, whether it's appropriate or not, we can debate. I just want to point out who are these high and very high risk patients at the bottom. So these are patients who have cardiomyopathy or heart failure, cardiac disease, active cardiac disease, patients who have multiple cardiovascular risk factors, so older patients about the age of 80. So I'll let you decide whether it's appropriate to follow those patients carefully. Let's shift to imaging. So in the low and moderate risk patients, the guidelines you've heard from Dr. Anthony is to follow patients with echocardiography every 3 months, at the same in high risk patients. But at the completion of therapy, the recommendations in the high risk patients to repeat another imaging to pick up early cardiac dysfunction, and then at 12 months to repeat imaging. Although this looks like we are over-screening low and moderate risk patients, I'm arguing that we actually are suggesting we reduce imaging compared to what's been in the FDA guidelines. Whether you follow it or not is a relevant issue. Let's look at what FDA said in 28. FDA, you need to get a first patient receiving Herceptin. We need an echocardiogram every 3 months, right? You consistent with the guidelines. And they say you should repeat an echocardiogram every 6 months, but 2 years. So if you add the total number of echoes that need to be done, our recommendations in low and moderate risk patients, in fact, shows that we can reduce the number of imaging because the FDA does not differentiate low from moderate from high risk patients. So you'd imagine that after the FDA published this, that you look at data like this, which says our cardiology committee is not following this, that 50% of our patients are not having repeated imaging, you would say, they will change this. Oh, no, they didn't. This is 2 months ago. This is what FDA has published, the exact same recommendations to follow patients with imaging as frequently as it was recommended in 2012. Now, forget FDA, forget what the ESC guidelines say. Let's look at the meta-cardiology, which is JACC cardiology, and let's look at experts like Dr. Addison, we have a lot of respect for. Let's see what she said in 2020. So she says in 2020, and she was way ahead of us. And what did she tell us? She tells us, let's think about the risk of patients. So way ahead of what they were thinking, way before ESC guidelines, she's asking us to think about the risk of the patient. She's asking us to think about the cardiac and cardiac risk as well as oncology. So she's way ahead of ESC guidelines. But let's look at the low risk patients, which is on your left. So she suggests in low risk patients, let me read carefully. We need a 3 monthly echocardiograms, she says. And then she says we need to repeat echocardiograms at 6 to 12 months after low risk patients. Okay. Metastatic population, she suggested that we do it every 3 months, and it's not after we don't complete treatment in many of these patients. So now there's a little sign there, so I don't want to ignore that. She does say that in low risk patients, we can consider reducing the frequency of imaging. But an expert like Dr. Blaes, who was ahead of the guidelines, also suggested that we follow patients with echocardiograms. So what should we do? Should we ignore the guidelines? Should we adapt the guidelines? I think the Chinese paper really did a fantastic job. They said in China, we hope to adapt the guidelines of our region with consideration of our unique demographics, susceptibility to cancer and treatment responses, adapting these guidelines. So let me leave you with this. Remember, with the ESC ICOS cardio-oncology guidelines, we have gone from a field with limited data and lack of standardization to
to a field of standardization, at least expert opinion in places where we do not have data yet, and we still need to care for our patients tomorrow. And I believe this is the direction forward. And those of you who have been following the Olympics, the 2024 Olympics, and especially, have been engaged in watching the dance team, I think I would like to leave you with the analogy. So on the left-hand side is cardio-oncology care before ESCI plus cardiology guidelines. And the right-hand side is after the guidelines. We are much more coordinated. And in the competition of caring for our patients and improving outcomes, we are more likely to win with these guidelines than if we work with them. Thank you. Yeah.
I suddenly feel like it is a little bit of like political thing. And can I go back on what I said a couple of years ago? I'm not. Thanks for giving me this opportunity. And as you guys already heard, I was asked to comment, are we ready for implementation from the perspective of, so I don't have any relevant disclosures other than to say I'm an oncologist. And so clearly I'm going to look at this a little bit differently than Dinesh. And according to the internet, this is what I look like, bringing science to patient care and raising being a voice or a champion for our patients. But I like to think of myself as an oncologist, really thinking about patients from prevention and screening all the way through the trajectory of their care, bringing in the science as well as relevant guidelines. We don't need an introduction to the guidelines themselves. We've heard about that. And I like to think about it as an oncologist really in emphasizing the strength of the risk stratification within it. I think this is probably one of the things, besides the beautiful figures in it, that I think about is extremely strong. Not only is it a group of international experts, but really they've taken time to look at the evidence as we've heard previously, but taking into consideration from the beginning how to risk stratify patients, looking at their age, prior cardiovascular disease, the types of treatments that they're getting, and lifestyle risk factors, really categorizing patients into low, medium, and high risk. And then in some situations of thinking of them as being at very high risk for cardiovascular complications. But I wanted to provide some specific examples. And as I was listening to Dr. Yu earlier today, I thought, man, I think he just gave part of my talk. So we'll kind of go through this from the oncologist perspective. So let's take the perceptive guidelines. We've heard about this a few times this morning. And as I look at these, even though Dinesh just told me it's optional, so I want to include these biomarkers as imaging, I actually, when looking at a class level 1 evidence, really suggests that patients should be getting echocardiograms as well as blood biomarkers throughout the course of their treatment. Nowhere in here does it stratify patients by whether or not they're being treated with curative intent treatment or not. And I'll show a few highlights of how metastatic disease is approached. But from an oncologist, I can't help but ask, are we over-screening? Let's take a 40-year-old woman who has an early stage 1 breast cancer that's HER2 positive, treated with a lumpectomy and radiation. According to the guidelines, she should be getting at least 6 echocardiograms within 2 years based on class 1 evidence, and 6 sets of biomarkers based on class 2B evidence. We saw this figure earlier today. What's the rationale for thinking about echocardiograms in this particular situation? Most of these recommendations are for older data. They would be built upon by the BCIR G006 as well as the NAZBP V31 trial, where there were asymptomatic declines in ejection fractions 14 to 18%. We can see in the figure in the middle that the long-term cardiac safety in patients following them for 5 years went from 1.5% to 4% in patients who received trastuzumab. Now recognize that these patients all received anthracyclines, followed by trastuzumab in conjunction with paclitaxel. Based on this, as we've heard earlier today, this really set the stage for the guidelines suggesting that echoes need to be performed at regular intervals with the goal of detecting subclinical cardiotoxicity, intervening where there are cardioprotective therapies, and informing clinical decision-making for cancer treatment. But I would argue that we have a declining use of anthracyclines. We heard this in our very original keynote yesterday by my colleague, Dr. Becky, as well as by evidence earlier today. On top of that, if you look at long-term Medicare and Texas registry data by Dr. Chavez McGregor, adherence to echo surveillance actually declines after 3 to 6 months, where when we look at elderly patients receiving trastuzumab-based therapy, only 30-60% of them are actually getting the recommended surveillance imaging. So coming back to our patients, this patient would typically be treated in the clinical setting based on the EDT trial by Sarah Delaney using Taxol with trastuzumab, followed by trastuzumab alone. We know these patients have excellent outcomes with 7-year recurrence-free intervals of 97% and disease-free survivals of over 93%. And in these clinical trials that did not use any anthracyclines in a healthy patient population, such as the patients I've mentioned, the cardiac incidence is actually extremely low. 2 patients in this trial developed grade 3 LV systolic dysfunction, with an additional 13 patients having asymptomatic declines. We saw this figure earlier. If you look actually at all of the data, combining some of our clinical trials, the overall incidence of in non-anthracycline treatment regimens remains anywhere from 0 to 1%. This is seen in the Neosphere and Trifina trials where patients receive taxanes with Herceptin and a doublet with Perjeta. It was also seen in the metastatic setting with similar regimens and with some of the antibody drug conjugates. So what happens actually if we institute cardiac screening? As an oncologist, my worry is that you pull to trastuzumab and that this worsens cancer outcomes. We've seen, this is one particular study demonstrating that evidence. So this was produced as a single site institution from Ohio State, looking at patients on adjuvant trastuzumab. You can see in the figures that both the disease-free survival and the overall survival was worsened in those who discontinued trastuzumab with an adjusted hazard ratio of 4.76. This has actually been studied as well. If we shorten trastuzumab treatments, we wrote this editorial a couple of years ago, really suggesting looking at 6 versus 12 months of adjuvant trastuzumab. One of these clinical trials used an even shorter regimen of 9 weeks, and the disease-free survival was worse in patients who received 6 months compared to 12 months, really suggesting that overall survival was also reduced. This is why trastuzumab in the standard of care remains 12 months. On top of that, what if my patient's EF does worsen while they're on trastuzumab? Well, we know, as we've heard during the meeting, we now know from Safeheart and Scholar that patients, we can give trastuzumab safely in patients with an left ventricular ejection fraction of 40 to 50%. We've seen this both in Safeheart and Scholar. Now, I might get some argument from Dinesh that these patients were all followed by cardio-oncology, and so they were risk stratified. But I would argue that if a patient did have a subtle decline, is that really going to impact their outcome? And what if the patient has a metastatic HER2-positive breast cancer? So based on the guidelines themselves, we actually, by class 1 evidence, surveillance can be reduced every 6 months during future treatment if they've been stable. So I'll tell you, a patient of mine that I've been taking care of her since 2017, she's had over 27 echocardiograms. She's never had a decline in her left ventricular ejection fraction, and staying on trastuzumab-based therapy has frankly allowed her to live the last 7 years. So what if I decrease their surveillance? Well, the standard of care today for HER2-positive metastatic breast cancer, now you may not be able to see all of this in the back, but what I want to highlight for you is nowhere on this figure are anthracyclines. So today, and this is rapidly changing, we have taxanes and trastuzumab doublets, such as trastuzumab. We have antibody drug conjugates with trastuzumab deruxtecan, likely moving into the frontline setting soon, as well as tyrosine kinase inhibitors against the HER2 molecule. Anthracyclines are not a part of metastatic HER2-positive breast cancer treatment. So for a patient coming in who has, there may still be some patients who received it in the adjuvant setting, but for patients with de novo metastatic disease, they do not have prior anthracyclines. And we, as already demonstrated, have very low risk cardiac toxicity from the Japanese regimen. What about the new antibody-drug conjugates and TKIs? This was from the FIGI database that looked at over 40,000 patients. And the antibody-drug conjugates highlighted in the yellow bars here have a significantly less risk of cardiotoxicity compared to trastuzumab alone. This is similarly seen in the TKIs, both the green and the pink lines. So we heard about this earlier. One size does not fit all. And I would argue that for patients with metastatic disease, we really need to think about how to risk stratify, and then are we over screening? We know that for non-anthracycline regimens, as well as with some of our newer antibody drug conjugates, that the risk of cardiac toxicity is much less than in older literature. And some of these patients really have low cardiovascular risk. So can we de-escalate surveillance imaging? Well, we're all waiting for Anthony's trial to be published. And I think we're looking forward to this as prospective data to really say, can we de-escalate imaging? As you already heard, this is a clinical trial taking patients such as I described who have no prior cardiac disease and looking at every 6 months imaging compared to every 3 months. So what about the role of biomarkers? In the cardiac care, a study that was just published recently last year, they actually looked at patients with breast cancer and non-Hodgkin lymphoma receiving anthracycline chemotherapy. They underwent serial high sensitivity cardiac troponin testing at CMR before and in 6 months. And patients at high risk of cardiotoxicity were randomized to standard care plus cardioprotection. First of all, the incidence of cardiac events was very low in this patient population. And using biomarkers as a stratification and then going on to be aggressively managed did not impact their outcomes. We've also seen in this recent publication in JACC Cardio-Oncology, going back and looking at the cumulative incidence of prevalence of CTRCD in the product patients, also was suggestive that with biomarker screening, we pick up a lot of perhaps concerted findings, although these don't actually translate into effective patient outcomes. Finally, I wanted to mention, what about immune checkpoint inhibitors and the surveillance protocols? So based on the guidelines themselves, they recommend baseline imaging as well as EKG, echocardiogram, and blood biomarkers with varying degrees of evidence. But we know in triple-negative breast cancer, based on the Keynote 522 clinical trial, that using immunotherapy in these patients actually improves the response rates, and that achieving a pathologic complete response results in a very high, over 90% event-free survival. So with patients receiving this treatment and not having delays in their immunotherapy is really essential. As an aside, in the Keynote trial, as well as in PASSION 031 and the Gavard Nuevo, no cardiac events have been seen in this patient population, really suggesting that inhibiting or postponing treatment may affect clinical outcomes as opposed to, or may affect clinical outcomes. And in the survivorship period, I think we've heard a little bit over the course of the meeting that we really do need to look at cost effectiveness of echocardiograms. In the guidelines themselves, on the press, and really speak very highly of the risk stratification. But some of the recommendations around screening at 1, 2, and 5 years may be over surveillance. I want to just draw attention that in JACC Cardio-Oncology coming out this month and over the course of the next 2 to 3 months, we were privileged to be a part of the team that looked at the guidelines and where there are gaps in needs. Our manuscript specifically looks at cancer survivors, although many people here at the room have been involved in looking at where there are gaps in evidence both before, during, and after treatment. And really want to say that I think, as we've heard throughout the meeting, it's going to be really important to think about how do we develop optimal follow-up programs for screening, to look at the right modalities and strategies for screening long-term in the survivorship population. And then I think really thinking about our AI technologies and the use of large databases to make sure that our data actually includes a broad patient population from diverse backgrounds. So in summary, I would say that ESC ICOS guidelines really provide a framework for screening and risk stratification, and this is essential, though not all risks are taken into consideration with things such as aging and disparities. There is a tendency to overscreen and draw too many blood biomarkers, and delaying cancer care and really impair overall cancer outcomes.
What you want to say to that? Left to out the argument.
I just have slides back. It's hard to respond to that. Like I did write a few things on anatomy, but we didn't have a notebook. So I think the first thing I'd say it's really hard to debate, and because I enjoyed working with them, have the privilege of working on the last recommendations with Jeopardy and Oncology. So just a few things I want to point out. The first is that I want to reiterate that, and this is sort of in the words of Dr. Charlie Porter, who I had a pleasure of chatting with a few days ago, and I think he said it the best. It depends on how you think of these guidelines, whether you think of it as the floor or the ceiling. I like to rephrase that and say, you think of it as the foundation or the ceiling. Foundation on which we can build, which is how I consider these guidelines to be, or the ceiling above which you cannot grow. And I think this truly is the foundation. But the second is, I think, with respect to the process of evidence, and I think you mentioned that, when it's class 2B that you recommend doing them. I mean, look, class 2B level of evidence C to me means that this is something that there is some leeway to decide what you want to do with these patients. Now, I want to address this issue that has come up over and over again today. And the issue that has come up is that if you don't use anthracyclines, you are perfectly fine. There's no need to screen. And it's always trial-based data. But keep in mind, we don't practice under trial conditions. We practice in real life. And if I have a doubt, where do I go? I go and look at Dr. Bonnie-Key's work. So this is publication by Dr. Bonnie-Key. And she looked at patients she has followed in her program who have received anthracyclines, who have received trastuzumab with and without anthracyclines. And I've highlighted what she has published as the incidence of cardiotoxicity defined as a fall in left ventricular ejection fraction to less than 50%. I can read from up here. Okay. I think she's saying that the risk is 17%, which is very different from what we have heard so far. So, I think in real life, the risk of developing cardiac dysfunction in patients who are receiving non-anthracycline-based therapy remains high. Why is this? If you talk to our group, our breast oncology group, and whether it's correct or not, I don't know. I listen to what my oncologists say. And what they tell me is that when they choose non-anthracycline-based therapy, often they're considering many other factors other than the efficacy data. And one of the factors that's considered is pre-existing cardiovascular disease. So when patients have pre-existing cardiovascular disease or cardiovascular risk factors, they're choosing non-anthracycline-based therapy more. So if you have a high-risk patient to start off with very little clinical practice, and one would expect that you will see more cardiovascular events, so which is different from what patients who are recruited in clinical trials. I think that Dr. Blaes brought up the SCHOLAR trial. Remember, the entire SCHOLAR data is based on 40 patients, so I'll leave it to you to make that decision. But, I think Dr. Darrell Lyon this running a fantastic study asking this question in a randomized fashion. So hopefully we'll have some answer to the concept of permissive cardiotoxicity. And I completely agree with that. I think other drug-targeted therapies and toxicity is probably nowhere compared to what we see with Herceptin, and probably something we have to consider the next iteration of our guidelines. And then finally, I think the ICI protocols that you suggested, I think you showed the protocol about ICI treatment and perhaps the contentious issues about biomarkers in these patients. And I completely agree that we do not want to interrupt therapy, but there's work. So the work is not consistent. Work that's being published by Dr. Tipti Gupta from MSKCC, which suggests that perhaps there's no value to routine screening, but work by Dr. Han Zhu, which essentially suggests that screening can't be helpful. Now, keep in mind,
there was a huge change to their practice when they started screening with essentially 24/7 console service available to identify troponin elevation. And I've seen some of our recent paper in MedRDX, especially in a larger cohort of patients, suggesting there's perhaps some value to screening in these patients. So the way to work our work to be published to understand the role of screening. And of course, there's also a randomized control study that's run out of MD Addison, which is really looking at whether there's value to screening patients with troponin. So we'll have the data as well. So I'll stop there, but happy to answer any questions.
Anything else to say, Addison?
I think I have a couple more things to say. No, really wanted to, I appreciate that. I think when was an hour given this job, like, oh my, this is going to be interesting. I do have a couple of other slides that I think they're going to bring up. And mostly because I think it's important to also think about us from a global perspective. I think all of us here would really applaud the group that worked on these guidelines. It's a heroic feat. They are international guidelines, and I think thinking about it from the Chinese approach of saying, how do we adopt these is actually going to be really important. So I wanted to show you a couple of the things I think about, which is really as this is applying to institutions. Most of us here are really from institutions and countries that have a lot of money. This is not the case all around the globe. And in this particular study that looked actually at echocardiograph practices across 5 continents, they did a survey, and I think you'll see from the data, there's a lot of variability in how even echoes are done on an international level. I think that, so when we're thinking about how to apply the guidelines and the international piece of it, I think that's important. Accessibility, the same thing, the figure of the US there. This is looking at MRI centers for a million people. So first of all, Minnesota is green. We have one of the highest concentrations of MRI. So you're getting something, right? Same thing with Konety. But this is very different with a lot of your facility. And we've alluded a little bit that we have to be doing cost-effective analyses within our screening protocols. We want patients to do very well. We also know, though, that there are cost implications. And finally, I wanted to just bring in the patient perspective. A colleague of mine by the name of Dr. Arjun Gupta really coined the term of time toxicity, thinking about time cost of pursuing and receiving a treatment and the follow-up tests of rehabilitation. So taking into account the patient perspective, if you look at cancer survivors that are more than 5 years from diagnosis, they spend over 28 days in a calendar year coming to the doctor. These are typically done for one service. If you look at patients who are with GI malignancies, with active cancer, they're coming in for appointments 1 in 4 days. And while we might say, oh, it's an imaging test or it's a blood test, that's not what the patients will say. This qualitative work really will say that these short visits turn into all-day affairs. And this affects patients and care partners. And on the quantitative perspective, we actually have these NIST badges in our clinic that track time where our patients are where we're at. And for a patient coming in just for a lab test or just for an imaging test, this is typically 120 minutes. If they're seeing a provider with that, that's 360 to 400 minutes on top of an infusion. So I really think as we think about the applicability of the guidelines across the patient perspective is going to be really important. And for those of you from other areas of the world where there aren't as many resources, I would also say we need to be thinking about how to align our resources. So truly, congratulations. The guidelines are an immense heroic feat. And we've talked about the fact that it's a well thought out framework and guideline. There are a tremendous number of strengths. I've highlighted a little bit some of the limitations that these are best consensus, and really thinking about what changes in practice, thinking about how we modify these. And really, the whole goal is to not impact cancer or impair cancer treatment. That'll worsen outcomes. So close collaboration is really essential. So thank you.
So that was a great debate. And so nice to hear the Canadian debate in Minnesota. In New York, this would look totally different, I think. But would like to invite the audience to come up to the microphone and ask their questions about the guidelines. Yes.
Awesome. Thank you very much for this debate. As a consumer and someone who's trying to incorporate the guidelines in many of my talks, I still struggle trying to figure out how do I define the low risk and the high risk zone. Number two, very extensive, very comprehensive, 230 some recommendations, with mindful of the class 1 indications. So how do we make this a little bit more concise so we don't lose the readers? And then, sorry, and I have a couple more things. You can't always, like, as you said, Alex, in your talk, screening has to be taken into context what the oncological scenario is. So in someone who comes in for Herceptin indefinitely for palliative care is different than someone who's going for curative care. So despite my recommendations to our oncologists, not QAs, it's hard for them to adapt to those changes and look forward to more data in this field.
Yeah, just one brief comment on when we go into these guidelines, sometimes the terminology is different too. I don't know if they use the same terminology. Class 1 level of evidence, C or B, if carries oncology, that means it. And so but then it's been looked at, right? And when we look at the immunology guidelines, American or European, less than 10 to 15% are actually level of evidence A, if you look across the board. So that's a general problem with the guidelines. And the Addison, right? It's the guidelines. When it's not law, it's not you don't trespass anything. So I think those are very important aspects. Now, how to implement those guidelines or what to do with them, right? I mean, there's the art of medicine. I mean, for us in cardiology, we're often on the receiving end. But I think what's also coming out is that, where it actually starts is in oncology. I mean, those should be the first line readers, the first line responders, and the first line readers.
I was just saying quickly, I do think some of that comes down to the oncologist, like how do we build this into our EHR, some of these high risk and low risk. And even on a very simple level, Catherine Weaver from Wake Forest has implemented any core one of the community oncology groups, just trying to raise awareness about cardiovascular risk factors for patients actually in the clinic. So they have to get to cardiology, and I think some of that is on us as oncologists to figure out tools. And I know this afternoon we're going to talk about how we use AI and other things that I think will help us with the risk stratification. And then just the app is essential.
I think just to answer your question directly, so I agree with the length and the number of recommendations. I do want to point out the ACCHA Valvular Registration Guidelines, 156 pages. But that's only one aspect of cardiology. This is the entire breadth of cardio-oncology. How do I deal with it? Control F is my friend. So when I'm taking care of patients, control F is very commonly used to find what I want. The other thing to keep in mind is that we're never dealing with the entire guidelines, we're dealing with the section of the guidelines, right? So when I'm going in to see a patient, it's a patient who has referred to me with osimertinib-induced cardiomyopathy or anthracycline-induced left ventricular dysfunction. So it's still a very small segment. And I think there are enough infographics there that are quite helpful in the practice. And then finally, the app is quite helpful as well. And the second point I completely agree with, I think we really need to take into consideration the context from a cancer perspective. Very important with any strategies that we are proposing.
So yeah, I know we're running behind. So one quick comment that was, I think, there are a number of oncologists in this room, but not many. And one of the issues is that there are still very few oncologists that are even aware out of the cardio-oncology guidelines. And in reality, the oncologists are the gatekeepers, aren't they? Because you can't have access to those patients, at least at an early stage, unless they're referred. And importantly, I think what's come up is we've talked a lot about risk stratification and can we reduce the amount of imaging based on risk.
but we really do have to get to the oncologist to encourage them to at least think about risk. Whether you use the the previous forma or other ways of identifying risk. So I think we still have a great deal to do, because if we don't start at least at that basic point, then it's hard to implement the other kind of time.
Final question.
And I think first from Japan, very nice to be. Thank you very much. And then the first of all, I'd like to congratulate Alex and you for creating a very good guideline athlete. And we have been using it as a basis for the marketing discipline. That's a great guideline. And I also enjoyed the debate between the dimension and to understand how to make the guideline actionable in the real world. So my question is actually, as I have written in my comment to the Alex guideline in the chat oncology field, that how to make the guideline sustainable. In other words, the oncology field is rapidly evolving and cardiology field as well. So how to make the guidelines sustainable? There are ASCO guidelines at 2017, ESCO guideline 2020, and obviously guideline 2022. So how to really consolidate all those different guidelines and make guidelines sustainable? That's my question.
So that's a great question. And just for context, we had to submit the guideline in May 2022 to go through the final process before it was then presented in August. And in July 2022, one of the statin trials in cardiac protection came out. We were asked in August, why didn't we include it? So this is the problem with all these types of documents, which is the world keeps moving on. So the way the ESC approach this is that they will have cycles, and at some point there will be either new whole guideline or probably more realistically in our field, an update. And the update will integrate everything that's happened at that time window, the new cancer drugs, any new diseases that we think are relevant that we didn't include. And then where there's new evidence, I can talk to the biomarker piece that we kicked around a lot, the concept of do we put some cutoffs on numeric threshold. And on that task force, overall, the consensus was no. But I think cardiac care, PROACT, Daniela Cardenema's previous data means we are going to have to think about an actual level of certain cardiac biomarkers and not just say positive or elevated as one example. And maybe if Anthony Yu's patent trial is done, that we'll see how we can reduce. And it's really about focusing the resources we have on the people who need them. So whichever healthcare system you work in, it's trying to get away from a one-size-fits-all to personalizing and using the resources you have to the people who need them most. And I think the clinical trials are always lower risk populations, aren't they? And then when you move into the real world, the high-risk patients have rates of heart failure of 30%. And I think we'd all try and prevent that, because otherwise the heart failure stops the cancer treatment and then you get the worst outcomes. Trying to prevent that. But sustainability is going to be about renewed renewals of the guidelines. And I suppose I have a comment to the plea to our whole community, which is A, to promote them because they're there. Secondly, that if people go to new guidelines, how it maps to what we've done and what's their methods. And then finally, contributing to research, because what we need is the research to then be that evidence, to move that 75% level of evidence C down over the years to get to a strength. And maybe a final comment as the co-chair, thanking everybody who was involved, because as well as people at the task force, there are 106 reviewers, so I expect a lot of reviewers as well, and we have 3 rounds of reviews. And we're generally here experts. We can come to the ICOS meeting because we're interested in cardio-oncology, but actually the audience for this guideline are general cardiologists and general oncologists, hematologists who aren't experts, who don't know all the data and the trials that we're familiar with. So you've got to put yourself in their shoes and think, what do they want to know? And that's how we wrote these guidelines. The spirit of that is it's actually for the generalist, because that's where all the patients are actually, not in the super specialist center. I think with that, I might bring it to a close. So thank you, Ganesha.
Okay, so this last session meets for standing between you and Black. So we will try and make this fairly time efficient. But I do know before we start this next session, I just want to say that after our session and before lunch, we'd ask that people in the room come to the front and we're going to take a picture. Is that right, Dan? Yeah, I think so. Anyways, we're going to take a picture after this session. So come forward before you head out of the room to the lunch. So maybe I could ask for slides, please. So just to remind everyone who I am, I'm Susan Dent, Medical Oncology at the University of Rochester, current president of the International Cardiology Society. We're very fortunate in this program. We're allowed to take just a few minutes to talk to you a little bit about some of the accomplishments of the International Cardiology Society. What you may not know is that we have a number of committees as well as working groups. In fact, we have upwards of 200 volunteers within our organization that work on different aspects of cardiac oncology. So you're going to hear a little bit today about some of those accomplishments. And you're also going to hear a little bit about our centers of excellence, who they are, because I think this is very important to distinguish feature. But before that, I'm going to take a few minutes to highlight our fellows. So fellows of ICOS are really members that have been identified and worked hard to become experts in the area, but also have shown their commitment to cardiac oncology in this organization. All the fellows, and I'm going to show you what current fellows are, ICOS, are members of the organization. They've all passed the certification exam, which I can tell you as an oncologist is challenging. They must have published in the field of cardiac oncology. They must have at least 3 years of experience of practice, again, as a board certified oncologist or cardiologist. And of course, they must show their CV and show how active they are. So becoming a fellow of this organization is challenging, but it really does speak to sort of the commitment of our membership. So what I'm going to do is I'm going to just highlight and call out some of the names of our current fellows. There are 21 in our organization. We currently have, I think, about 1,300 members within the International Cardiology Society. And of course, if you are interested in becoming a fellow, these are the criteria. And certainly, we're always happy to consider and recognize those people who are committed to this field. So as I call out these names, we're going to ask these individuals who are attending this meeting to stand up. And I think it would be so nice at the end after I call them and recognize them for their efforts. So we're going to start off by Dr. Anita Arnold. I believe she is still here or was here from Florida. Rochelle Blue. I think is also attending this meeting. Dr. Joe Carver. He was here just a minute ago. Maybe he's getting ready for the next session. There is Dr. Danielle Singh, who is not here today. Myself, Dr. Michael Bradley, who I know is attended this meeting today. Dr. Arjun Ghosh is here on stage, and we'll be talking to you later about some of our work in the committees. Dr. Aki Luha, also at the meeting today. Dr. Karamita, I was believing is attending as well. Dr. Carlurum, Dr. Daniel Lenihan, Dr. Teresa Lopez Fernandez, Dr. Joshua Mitchell, who I saw around earlier today, Dr. Nazir, Dr. Porter, who has kindly been taking a lot of pictures. And Charlie, you're also our official photographer, I think, at ICOS. So thank you for all the photos over the years. Dr. Vijay Rao, Dr. Rosen, Dr. Shani, Dr. Sebastian Smith, we all know very well, Dr. Tran and Dr. Zane. So I just want to take a moment to really recognize and congratulate all those members of the Fellowship of ICOS. So thank you very much for your commitment. And thank you so much. The next one I'm going to do is ask Stephen Casale to come up and spend a few minutes and talk to you about our centers of excellence. So Stephen Casale, most of you know, really our executive director of our organization, also has worked tirelessly to bring us together as an organization. And I can really say has catapulted us in terms of our membership and involvement with organizations around the world. So Stephen, if you could come up and give a few words.
Thank you, Stephen. I think I know most of you by email, but it's good to put names to faces. So the ICOS Center of Excellence Award recognizes those institutions which have demonstrated superior expertise in the care and treatment of patients within the cardio-oncology sphere. This certification provides a quality metrics framework that supports the development and growth of the clinical impact of each of these cardio-oncology programs. I especially want to thank Dr. Vijay Rao. It's some Vijay advocate, see you to the right, but Dr. Rao is the chairman of the Center of Excellence Committee, and he has done a fantastic job of organizing this effort. We're proud to recognize 84 centers all over the globe, as you'll see, who have obtained this certification. And today, since the first time we've recognized these groups, I just want to highlight where they are around the world very quickly, and then recognize our 2024 award winners. So I won't read all the names, but you can see all across North America, both in the United States and Canada, we have a number of centers represented. In South America, primarily in Brazil, Asia, the Middle East, we have centers in Turkey, Israel, Singapore have been recognized. On the African continent, just South Africa, and they will, as you know, be our host for the meeting next year. So we'll be excited to be able to actually visit their site personally next year. Throughout Europe, a number of countries have been recognized. In Australia, we have 4 gold centers of excellence. And in 2024, we have 16 new centers that have been awarded the Center of Excellence Award. 14 of them are gold, 2 silver, and 1 that is moving from silver to gold this year. So as programs mature and develop, they can move from silver to gold. So if there's members of these institutions here, I want to do the same thing. If you could stand and be recognized, but Advent Health in Orlando, Florida, Allegheny General Hospital, Pittsburgh, Pennsylvania, the Sudan Ashdod University in Israel, Central Sydney Cardiology, one of our silver award winners, CHI Memorial in Chattanooga, Tennessee, Connecticut Children's, Hartford, Dell Children's Medical Center in Austin, Texas, Froedtert Hospital in Milwaukee, Wisconsin, Liverpool Heart Chest Hospital in Lyon, Moscow City Hospital in Russia, Northwestern University in Chicago, Newark, Lyon, New York City, Rush University Medical Center in Chicago, Taipei Medical University in Taiwan, Tri Health in Cincinnati, another one of our silver award winners, University of Tennessee Medical Center in Knoxville, Tennessee, and then Scarborough, also in Canada, was one from the silver and gold. So congratulations to all of you for 2024. And I just want to conclude by encouraging all of you to apply if your country is not representing specialty, but please apply for this award. It's a wonderful way to set your institution apart from others. Pardon?
Thank you very much, Steve. Thank you very much, Susan. So, my name is Iakobishvili. I'm a pathologist at Oncology Heart Centre and the University College London Hospital, where I run the platform public service. It's very nice to hear so far the talks we've had on the guidelines and how we need to really be trying to move the field forward and all the research, but probably we also need to try and inspire the next generation of trainees coming through. And hence, I'll be talking a little bit about the cardiology education and training survey that we undertook as part of ICOS. I appreciate we're just before lunch and we are running a little bit behind, so I'll try and get through things as quick as I can. So why did this survey come about? And this was something that Darren and Joe Carver and colleagues produced a number of years ago when they really started to lay the groundwork for why we need some specific education and training in cardio-oncology. Sajid Banatra then produced this piece called Janak, and I was involved in this work from in the cardio-oncology group and talking about training for fellows. A lot more work then from the Jack Council perspective from Jose Alvarez and Bartona. And then we also had a BESC curriculum that recently came out. So some common themes really emerged from all of this. When should you train in cardio-oncology? Should this be during the beginning of your cardiology training, or should it be during your later cardiology training? What does this training actually involve? And how long is this training? How do we deliver this training? And where can you get this? Does this happen in your hospital, in a specialist hospital? Is it didactic? Is it practical? And we need to have a fellowship component to cardio-oncology. Is this essential? And what about research in cardio-oncology? Should we be encouraging this from all the trainees? And finally, probably for a trainee, and I know that there are a number of trainees here in the audience, the most important question, will there be a shining job at the end of it all? That's, of course, the aim. So this is really, I think this slide, I think highlights the great role that ICOS has in bringing the world together. And as you can see, the majority, actually nearly 30% of the respondents were from Mexico, Central and South America. So I really want to thank my colleagues there who really pushed the survey. We've had wide representation also from Europe, from North America, Chile, Canada, as well as from Australia and New Zealand. So really a global picture of cardiology, the trainees of cardio-oncology training. So as you may expect, this is very common in terms of the year of training. So evenly split between early cardiology training and late cardiology training. Then we also asked whether they had specific training in cardio-oncology. And as you may not be surprised to see, that the majority said that they hadn't received specific cardiology training. The main place of the work, did they have cardio-oncology? And again, it may not surprise you to say that the majority actually did have some cardio-oncology service there, which is, of course, a good step forward. And in terms of what did they, what kind of exposure did they have to cardiology and cardio-oncology training? This is really a mix of consults, and this is inpatient consults, also outpatient consults. And for the minority, they had a mixture of both inpatient work and outpatient work. And this is also an interesting question. We did ask how much training did you have in cardio-oncology? And now we exclude the 0 out those who haven't been trained. But if you see, there's quite a mix. There's the majority, 36%, who had less than 10 hours. And the next largest is the 21% who had more than 50 hours. So you either have some groups who have some very limited training and some groups who have a lot of training, and then there's something in between. So really we should be aiming, of course, to try and standardize this in some way. But the aim, of course, of cardio-oncology training is to allow the trainees to be comfortable in managing patients with cardio-oncology problems. And it seems that 63% are comfortable, whereas 37%, large number, are not comfortable. So we need to do better. And this is a very good slide for anyone who is interested in cardio-oncology training. And I dare say it's very important for all of us here in this audience to see that cardiology trainings say that, yes, they do want specific cardio-oncology training. So this, of course, is encouraging. And in terms of further fellowship in cardio-oncology, 60% said yes. When it comes to research, the majority haven't had research in cardiology or taken part in research, and the rest of cardiology research at a variety of times during their training. And the other important point is, of course, they do want a job in cardiology. So 64% are looking for cardiology as a career. And what do they want to combine that with? As you can see, the majority want to combine that with general cardiology. and start with the imaging and heart failure. And I was really happy to see, and I'm sure that Cesar Iliescu and other colleagues would be happy to see that intervention, 20% of the cardiology trainees do actually want to do cardiology and intervention, which for me personally, I think this is fantastic. So what are the take-homes from our survey? We really need to try and formalize cardio-oncology training and incorporate it into core and specialized cardiology training. We need to increase the number of trained cardio-oncologists. So Susan has just talked about fellows with ICOS, and this may be a way to demonstrate that you are capable of being an excellent trainer in cardio-oncology. Maybe something for trainees to look for when they try to seek a mentor or somebody to teach them about cardio-oncology. And of course, we do need to have some appropriate certification at the end of this. And this may be a local board certification, or maybe something for ICOS to say that the individual is now trained in cardio-oncology as per the local requirements. I'd just like to very quickly acknowledge Reese Gray, one of our fellows, who really has been instrumental in getting the survey of background, and the ICOS Education Committee chairs, Rose and Sebastian, for their help, and of course, importantly, all the ICOS members who really helped very much to disseminate the survey in a very global way, as you saw, and of course, participants. Very quickly, just moving on now to the working groups. And again, I will not keep you before lunch very much, but really this is to highlight the amazing work that all the committees and ICOS do. As Susan talked about, there are a number of different committees, and hopefully I'll be able to just highlight the breadth of the work that ICOS is doing. And I'll also be talking about, you could see with each of the committees, the emails are there for the chairs. Please do contact them by email. Of course, you can come and talk to them during the conference if you see them, or talk to Susan and Steve for more details. First is the scientific committee, which is chaired by Lyon and George Nel, who's obviously been on stage a few times. They've produced a lot of work in terms of producing this document with the Interventional Society, as well as 2 documents on checkpoint inhibitors. We have the Education Committee, which is led by Sebastian Smith and Jose Andres Cardona, and they've been great actually developing doc phrases for EPIC and Suma, involved in the exam certification, as well as producing the survival passport for survivors of cancer and algorithms for management in a one-page format. The nursing working group, some of you would have attended that nursing part of the conference on the first day, which was extremely well attended. That's led by Sita Federal and Perry Skirko, who are both here in the audience. They have been extremely active in producing a number of webinars on pediatric imaging, on risk assessment, as well as very importantly, developing a certification exam for nurses to really try and, again, take the field forward, similar to the certification exam we have to the medical staff. They've also produced a training course for nurses and developed patient indication materials as well, and produced manuscripts in this regard. We have the pharmacy working group, which is headed by Ezra Moore and Craig Beavers. Beavers was here on the stage yesterday. They've produced a number of papers relating to drug shortages, as well as cardio-oncology and global pharmacy-related concepts, and developing a database on pericarditis. The advocacy working group is led by Josh Mitchell and by Raul Almodovar, and they've produced a number of papers on this in press. They've developed a webinar on this, and they're all working on the patient survey to better understand the needs of patients in this space. The pediatric working group is led by Casey Villa as well as Nia Bansal, and they have produced again a whole half-day seminar for ICOS on pediatric cardio-oncology. They've also had a couple of webinars to look at imaging in cardio-oncology in the later phase setting, and then currently working on the manuscript for their survey about pediatric cardio-oncology across the globe. The Centers of Excellence program, you've already heard about this from Steve, but this program is run by Vijay Rao and Richard Chen. I'm sure you all know Vijay is in the audience. And they've really worked very hard on publishing this quality metric paper. And I just heard from Vijay yesterday that hopefully the final set of amendments and corrections have been made, and hopefully we are ready for publication there. They have developed criteria of the Centers of Excellence to move from bronze to silver to gold, and hosted a webinar to try and explain it to anyone who's interested in becoming a Center of Excellence how this can be achieved. And as mentioned, they are also offering help to try and get programs from bronze to silver to gold. The exercise working group is chaired by Aaron Howden and Fernando Rivera Cyril, and they're currently working on a publication on rehabilitation in terms of the evidence and research in the field and priorities. And they also had a webinar looking at cardio rehab in amyloid patients. The survivorship group is chaired by Dr. Walker as well as Trishun Parashar, and they have worked on the survivor passport similar to the previous education group. They've carried out a global audit of cardio-oncology services from the late effect setting. They have also produced a paper on pregnancy and like it is taking effects into diabetes, cancer, the role of pharmacy in supporting cardio-oncology care in the late effect setting, as well as a consensus statement. So a lot of different activities from this group. We have the amyloidosis working group, which is run by Dan Lenihan. He's Stockholm Goldstein, and a number of achievements, as you can see, number of different webinars, number of amyloidosis updates. They have also collaborated with the International Society for Amyloidosis, and have also been successful in grants from the France Foundation, as well as currently putting in a grant for regional learning collaboration. And that's it really. So please do contact the different members of the working groups, really just highlighting the amazing amount of work going on all the different committees. I'd just like to thank the committee members, and then I think we are now heading for lunch. So bon appetit.
Okay, thank you very much. So we tried to make that very quick and informative. I'd like to invite everyone up to the screen for a picture now, please, before you have lunch. That's the price of the lunch. Covers up your picture today. So come up, and then at what time are we meeting back here at? 12:50. Okay. Okay.
All right, everyone. Just like the TV game show, we're going to play Jeopardy, where there are categories displayed on a screen in front of you. And we'll take turns choosing the category and the point value within that category. The higher the point value, the harder the question. Once the question is played, it cannot be selected from the board again. The game continues until all categories with point values have been attempted or we run out of time, whichever goes first. Once the question is read, the team should buzz into with attempts to answer. Of course, the response should be in the form of a question. If your team's out, I will say that if you do not answer in the form of a question, we will still consider your answer, okay? If a team answers correctly, they earn the number of points associated with the question. If they answer incorrectly, they lose the number of points associated with that question. The team that answers the most questions correctly gets to choose the team that answers the question correctly gets to choose the next category. If you are the first to buzz in and you get the question wrong, another team has the opportunity to buzz in and try to answer that question. The team that answers the question correctly will choose the next category and point value. If nobody answers the question correctly, the person who would select the prior category will continue to select the next category. The team with the highest score at the end wins. We'll be keeping scores. We have a backup scorekeeper to keep us honest. I'm going to be making sure that the answers are consistent. So we'll get started. Yes.
If one team a point roll, imagine, should we tap again or if okay, yes. So if you may answer incorrectly, if it's correct, it's wrong, the team should now buzz again. So that we can act every team is heuristic.
So the questions will be answered in column 1 and column 2 by Sebastian Smith, 3 and 4 by Susan Kate and Charlie Porter, and 5 and 6 by two party along with Blaes like that. Okay, before we start, just kind of reset the team at University of Minnesota, we're doing all the logistics to get over the decimal word and scoring and timing and just making this happen. So I go.
Light vector cancer images. What's missing? No favorites. 5 numbers. Complications and remedies. And I guess we'll start the Fed champion. I guess what's better. So we can start with remedies 400.
7-year-old male, heavy pre-treated IgG multiple myeloma. 48 hours after receiving CAR T therapy, has a heart rate of 130 beats per minute and is hypoxic. What is an indicated treatment?
I yes. The doctor, Josh. Yeah. So what's being a threat?
What is just used?
That is correct. You got it. You're crypting kind of. Yeah, I get it. Yeah, there. I said it. Guys, when you look at this, SARS. Yeah. Yeah.
We'll take remedies for 400, please, Alex.
Yeah, so let's just take it here. But no, Josh, you know, send for of Bloomberg. What did
Remedies for 400.
Well, there's something else. That's the problem. And then
What is Luca Oren?
no, here we go. There's something. There's something else. Sorry.
Take remedies for 600, please. Remedies for 600. Running the category.
30-year-old female with metastatic colon adenocarcinoma presents in cardiogenic shock 16 hours after first cycle of FOLFOX chemotherapy. What non-cardiac intervention is available?
You may need 3 years. Old favorites 400. True or false? ADT is associated with QT prolongation. No. Laboratory is true. Oh, what no, was Portland? Maybe I don't. Yeah, yes. Okay, then do it then. Was okay. Do that. So wow, yeah, Suma. Okay. What do you want to do? What's missing? 400.
High risk for cardiovascular complications. Greater than equal to question mark grade mean or dose or question mark milligrams per meter doxorubicin.
25 and 215. That on records.
This depends on which guideline you're going by, but this I believe we're going with the more than 250 milligrams per meter and more than 30 gram in pirates.
But if the mean heart dose is above 5 and 250 of doxorubicin, that's the grams everybody should, but it's 15 grades there. Okay, so no points everybody. They don't all complete points. We all lose. Yeah. Okay. About it. Yeah. Yeah. Okay. So I think you still have to work there. Images 400. 400. 400 images. It's a mix of what is life after cancer 400. 60 years old female post top chemotherapy and 6 degrees radiation therapy presents with severe calcific aortic stenosis. What are the likely findings per yes? What are the action if the action is not in it? That is not what we stepping. If I don't, if I say anything, I don't lose. All right, guys. So fast. Okay. So next week, I think people miss all the questions. It's either the answers wrong or the house questions. Okay. I guess you still have. Okay. By the numbers 400. By the numbers.
Doxorubicin 100 milligrams per meter squared. Radiotherapy 5 grays.
That's it. That's good. No. Moderate risk of cardiotoxicity.
What is low risk of cardiotoxicity?
Oh, yeah.
Okay. I'll go with the old Davids for 400, please, Alex.
For how much? I'll take the 400, Sarah.
Patient with bulky NHL develops atrial fibrillation immediately after cycle 1 of treatment. Lab findings include hyperuricemia,
phosphatemia, alkalemia, and hypocalcemia. What is the most likely cause?
What is tumoritis?
Crap. Right. A bit.
600 seed.
Percentage of colon plasma cells on the bone marrow examination considered a myeloma defining event.
60%.
Right.
Right. But
Whole failure rate.
Remains in the liver for decades after treatment for germ cell cancer.
Cisplatin. And right. He might just
And a short cutter.
What do you see? AL amyloidosis.
It's
And what we were saying, Florida. Now in degree with dynamic. So it's 10 figures and 10 terms.
no. Okay, well, let me go with George, which is negative 400. St. Louis is 200. Brazil is 300. 1200. Brazil is 2200.
Okay.
Remedies 200.
I think we asked this question.
Yeah.
we did not. Oh, we did this.
Ah,
Yeah. Yeah. Okay. Sorry. Pick another.
By the numbers 200.
200. Let's go.
About 25 million.
what is the number of cancer survivors expected by branch?
What's missing?
Word. What's missing for the chomp regimen times 6. What's missing in the doxorubicin space?
What is 50 milligrams per meter squared?
Not sure.
Yeah.
What is 150?
It's cheeky. So you have to read the power, like the space cycles. So don't read the best thing is right once.
But it's just for one cycle. 50
But everything listed is
cycles. You made 300. It's 50 per cycle.
Yeah, but we got that. That's all right. That's the first story.
Yeah. What priority said, odd me up. Correct.
And be like this in there for this cycle.
But the thing is, with the question mark, is 6 cycles on doxorubicin.
Right, but you have with it for the next dollar.
Okay.
It's it was out of court. Sorry. It was fucking up.
So much. Okay.
That was 200.
Can we get to see the answer?
What's missing?
Make sure you fire the other now. Well, you do it, boss. Thank you a lot.
Washington. And it is for 600.
What do you see? What is the carcinoid syndrome of severe tricuspid regurgitation? Correct.
What is Y after kids for 200?
200?
Yes.
Forty-five years old man with Hodgkin lymphoma at age 16 years treated with valvular radiation and splenectomy complicated by Myocarditis. New pancreatic mass with pericardial tamponade after one cycle of docetaxel.
It's a radiation recall. That's permanent.
No, it's good. I respect you. It's like the pericardial tamponade radiation recall. What's the pancreatic mass? But yeah, that's good.
Life after the cancer, and at 600.
And then 50 years old female is diagnosed with Hodgkin lymphoma in her second trimester of pregnancy. She is treated with anthracycline-based chemotherapy. What are the ECG is European Society of Cardiology guidelines for cardiographic monitoring?
Right, but therapy have been every 3 months or every second cycle. What are yets?
Okay, so okay. So when you talk about over-treatment, so many activists would have this is straight from Dogma. Nobody got it. Okay, so but so we don't
Say that. Yeah, one verse.
Yeah, sorry, this is.
Listen, oh, tell me. Perfect. Something you got it. 4 weeks. But all right. Wait, okay. No, what was it? Project. Okay. Yes, we got kind of.
Sorry.
But it went on like the basic stuff. It's like
They said every 2 cycles, 4 weeks, so that was the next 2 months.
But average. Absolutely.
So what do you think? Psychology, 28 years. They said
So George is incorrect, and results also has a. So I didn't got it. It's it's not good. It was not correct.
because that's I think said
okay. All right, so it was still better.
Probably not.
By the number 1,000.
Cycling of 11 Oxford was fine.
For every 100 of doxorubicin, idarubicin should be 9.8.
What?
2.5.
What is missing? 600.
Now,
What is
like
missing?
showed 5 times as funny.
What is missing? It's described. We've seen it many times today.
Well, tell me. I want to answer this question, but I didn't touch it. But I do what?
Sounds like fact.
And what?
Yeah. I don't know. It's the cancer treatment.
EP was submitted.
That's how the live. I was
Okay. Somebody else want to? It's not cancer treatment. Anybody else want to?
treatment related to cancer and toxicity.
Guys, I mean, you're so boring. I did it all like.
I know. Is that what if you give something highlights to another one? Or no? It's
Yeah.
Potentially cardiovascular cancer treatment.
yeah. No. No, but I see.
And I want you to go to reset this question. Okay.
Face all theoretical wild.
Old papers for 1,000. There is we can.
Who is Joe Carver? Cardiologists and oncologists use chest CT scans with contrast for multiple possible diagnostic indications. All indications have different scanning times after isotope injection. Which indication has the shortest injection to scan time?
What is CT coronary angiography?
Yes. Actually, my weapon is something like that. There's chest ED first, then arteries, then
It's nice.
just
The noise of injecting under us, not isotope.
figure it out.
Thank you guys. Very much.
So wait,
What God?
okay,
Remedies for 1,000.
images,
Remedies for 1,000.
Remedies for 1,000.
yes. I got this. This is funny.
49-year-old female with triple negative breast cancer, Keynote 522 trial, has extravasation of doxorubicin, had prior port thrombosis.
Dexrozoxane.
What up?
By the numbers 600.
George Nel are equal to 180 over 110.
When you stop chemotherapy for older men, what blood pressure? What blood pressure for what? About what blood pressure do you hold chemotherapy or recovery as much?
Okay,
We take by the numbers. We'll take 800 the same category.
I don't know. 800.
for the mic.
The minimum duration of anticoagulation in a patient with cancer with a catheter associated.
What is 3 months?
Thank you.
Yeah. 7 more questions.
What are your parameters for 800, please?
55-year-old male is diagnosed with non-cell small cell cancer and presents with headache, facial swelling, distended chest pains, and postural syncope. What is the preferred remedy?
Endovascular intervention and stent if possible.
Right.
We take images for 800.
But the minutes.
800. Yeah, every day. What do you see?
What?
What is immunotherapy related adverse events?
Vitamin toxicity.
Too easy, I would not do that.
When they die,
Yes, we take images for those two.
Can we recognize?
Constructive pericarditis.
Wow.
What is missing? 800.
What is missing? 13.
What is the ECP? Oh, they can't get a huge best supporting criteria.
What is big that in the minutes? Correct. That's right. They do.
What's missing for 1,000?
What's missing?
What is missing? Between fever and hypoxia.
Hypertension.
Right.
Life after cancer for 800, please.
54 years old male with metastatic or maxillary site carcinoma present to ET with mental status changes accompanied by
What is HLH?
Yes.
There's already one over here.
I think we'll go for life after cancer for 1,000. It's life after Oncology.
what is the most likely treatment and what
It's a chronic G age.
No.
What is the rituximab? I want the treatment.
yeah, what is the most likely treatment?
And actually, it's much lower. Yeah, but not good at it. It looks but it's once.
all right. Yeah, I think that's the number.
And
Okay, we're still at 3,000. Georgia was negative 400. Well, St. Louis 2,800. So still one with 2 red guards and it's like little one player. So there you go. I guess we know where that came from. But no, Brazil 3,000, Georgia minus 400, St. Louis 28.
one player. No, the plan menu. Yeah, period. Good afternoon, everyone. We're going to get our next session started. My name is Kareem Seda. I'm a pediatric oncologist at the University of Minnesota. Here with my co-chair, Dr. Catherine Reddy from the Mayo Clinic. We have an exciting session on survivorship, for which I think will lead into nicely and culminate in our new special plenary presentation. We did not plan all those survivorship questions in Jeopardy, but we love that the quarter multiple. So thank you for those questions right there, sir.
In this session, we have the pleasure of hearing 4 speakers, including Dr. Matthew Earhart from St. Jude, Dr. Carrie Thompson from Mayo Clinic, and Dr. Christine Resden-Nasty from the University of Toronto. A little later, we'll hear from Dr. Emily Tonterbezos, the Director of the Office of Survivorship at the National Cancer Institute. Kicking things off first is Dr. Earhart.
Thank you so much. I appreciate the opportunity to be here. It's about one year for the session. I have gathered through the polls earlier. I'm certainly a minority as a pediatric oncologist here. But I want to give you some of the perspective about cardiovascular risk stratification in our pediatric and adolescent cancer survivors. I'm sure this is something all of you are well aware of, but clearly it's a cardio-oncology conference. Our cancer survivors are at risk for late cardiovascular complications. This is one of the key papers of our area of spectacle lineage in the child cancer survivor study, showing really what the spectrum of that cardiotoxicity is. So, in our pediatric patients, really the predominant conditions that we see are heart failure and coronary artery disease. And it's a little difficult to tell from the figure, but the dotted lines right along the x-axis are the Singh burden. And you can see that while there have been improvements over subsequent decades of cancer treatment and reductions in cardiotoxicity, they're somewhat modest and still continue to become a problem for these patients. As a spectrum of cardiovascular disease, In pediatrics specifically, we tend to see cardiomyocyte damage, ischemia, valvular disease, pericardial disease, and arrhythmias. But for the purpose of this talk, about risk stratification, I'm going to focus mostly on anthracyclitis and radiation. What you see on the screen now are 3 of the sort of seminal studies in this area associating anthracyclines to cardiotoxicity in our pediatric population. Across these 3 groups, what you'll notice are a few themes, most notably that when we talk about doxorubicin equivalent anthracycline doses, which I was pleased to see were part of the Jeopardy questions. There's a threshold right at 250 milligrams per meter squared that across these different cohorts, we tend to see an inflection point of cardiomyopathy risk increases quite dramatically. What I don't have time to go into substantial detail about, but for the purposes of putting things in context, again, we think about things in doxorubicin equivalent doses. The data for cardiotoxicity from an isotoxicity standpoint comes from large pooled cohort data led by the Dutch group, but pooled North American and European data to amass about 30,000 cancer survivors. And this is really the best data that we have. Prior estimates were from hepatotoxicity and non-cardiotoxicity. So when you look at specific cardiotoxicity isoequivalencies, we see that most importantly for pediatrics, nalirubicin is about 0.5 to 1 with respect to doxorubicin, and mitoxantrone is 10 to 1. These are the 2 agents that are most commonly used in different therapies of our patients. Now, from 2 of those same studies, we also see the associations with radiation-related toxicity. And the key points from these data are that cardiac exposures less than 15 gray. We're not talking about mean heart doses here. Unfortunately, most of these data are derived from chest-directed radiotherapy, but doses less than 15 gray impart very low risk from cardiomyopathy, stand very similar to the general population risk. So these are the groups that we consider low risk pediatric cohorts. And those that receive 30 to 35 gray or higher, consistent with the adult populations, are those groups that are substantially higher risk from a radiation standpoint. But as the Jeopardy questions alluded to, and I did on the prior slide, that only tells part of the story. And unfortunately, we're not caught up to these data from a guideline standpoint. But as we learn more and more about dosimetry and what that means for cardiac risk, we know that it's not just the chest-directed dose, it's the dose to a particular volume of the heart. So you can have an extensive cardiac damage at low dose, small fields or small volumes, but conversely, high doses, small volumes. Conversely, you can have damage at very low doses of radiation if a larger dot of the heart is within that range. And we know also from a number of studies that the combination of the 2 are worse than either alone. And so when you add anthracycline doses, any anthracycline exposure and radiation 15 gray or higher, you see substantial increases in cardiotoxicity, again, particularly from cardiomyopathy standpoint in pediatrics. So all of these data combined have really led to the development of pediatric guidelines. I've had the pleasure of participating in both of these, or co-chairing both of these cardiac sections, where they're aligned. The International Guideline Harmonization Group is an effort between North America and Europe to create more generalized recommendations. Children's Oncology Group is really focused largely on North American health practices. But what we've been able to do, and unfortunately I can't go into a lot of detail due to time here, but as was mentioned in the prior talks, we've been able to use cost-effectiveness analyses to reduce screening of the last several versions of the guidelines. And so I'm happy to say that due to multiple models showing that patients that receive less than 100 milligrams per meter squared of doxorubicin equivalents and less than 15 gray of chest radiation, we've shown in a number of studies that their risk is similar to the general population for subsequent cardiomyopathy, and it's not cost-effective to continue screening. So this has resulted in an elimination of screening of about 40% of the population who we were previously doing echocardiograms every 5 years. And as was mentioned, this has significant health cost savings as well as time away from work, time away from families, and anxiety for these patients. What about for coronary artery disease? Unfortunately, we just have a huge paucity of data here. We all know that these patients are at risk. Radiation is clearly bad for vessels, despite its many benefits from a cancer standpoint. But we have no data in pediatrics to help guide thresholds for screening or how to screen these patients. And so the International Guideline Harmonization Group recognizes this risk, but has been unable to make any evidence-based recommendations for how to screen this population. Now, there's a growing need for prediction models that account for the younger age of onset and admitting cancer treatment-related exposures unique to our population. So I want to show a couple of very nice models from Eric Chow in Seattle using the childhood cancer survivor study. And what you can see is that when you add increasing levels of discrete data, in this case, the model on the far right takes a standard prediction model and adds cardiac dosimetry to it. You can see that you can pick out individual groups that are particularly high risk or even low risk for cardiotoxicity, whereas we might otherwise lump them together as a moderate or high risk group, but we only consider chest-directed radiation and the combination of anthracyclines. You can see the same with ischemic heart disease, where you can delineate very high and very low risk groups, which could help to direct our screening. But I want to give an example of why this is so important in our population. If you take an example of a 40-year-old male Hodgkin survivor that's exposed to anthracyclines and chest radiation, blood pressure and cholesterol is shown, no smoking, and no current medication use. If you plug him into the ACSC ASCVD risk calculator, his 10-year risk for cardiac event is 0.5%. Conversely, if you put him into this childhood cancer survivor study ischemic heart disease calculator, it's approximately 10%. And of course, the only difference between these models is essentially the treatment exposures, which are unaccounted for in the general population screening. So this is why we think these are so important for our survivors. Where we're missing a key step is we need to incorporate these risk prediction models into cost-effectiveness strategies or cost-effective risk models to guide our screening strategies. But what you can imagine is we start to put more of these discrete variables in, we can get better and better prediction models that will help us to intensify screening for the highest risk patients and de-intensify for the lowest risk, which I think is equally important from a cost standpoint and to burden on these patients. And so this will allow us to screen more in the patients that need it or less, and those that don't, to preserve resources for those that need it. Now, what variables might be included in this? Well, there are several that we could consider, but the role of fitness and exercise has been well shown in this population. We know that inactivity is associated with increased mortality in survivors. We know that higher levels of activity are associated with lower incidence of cardiovascular events, including heart failure and Hodgkin survivors. And so could these activity levels be used to tailor screening recommendations at the individual level? I think yes, but we need good ways of measuring them and ways to incorporate them in real time with prediction models that we have effective surveillance strategies for. Similarly, we could do the same with genetic variants. We know a number of variants that are associated with increased anthracycline-associated toxicity, as well as decreased toxicity, as we learn more and more about these genetic models. And so as these become more available and at a lower cost, these could certainly be used in prediction models to help us guide our screening. And then lastly, what about things that we're already using? Stephanie Dixon led a study at St. Jude looking at NT-proBNP in and of itself. And while it was associated, increasing levels were associated with higher doses of anthracycline use, it was not predictive for subsequent cardiomyopathy. But when we combined abnormal global longitudinal strain with abnormal NT-proBNP in patients who had a baseline echocardiogram with a DL of above 50%, even when you looked at the highest risk international guideline harmonization group patients, they were at a fourfold increased risk to develop an EF less than 50% or beyond cardiac radic patients at return in 5 years from that baseline. So we know there are better ways to identify those highest risk patients that may either benefit from more intensive screening or from tertiary prevention strategies.
So in summary, cardiovascular stratification in childhood cancer survivors is predominantly driven by prior exposure to anthracycline chemotherapy and chest radiation. Risk-based screening recommendations are available from Children's Oncology Group and the International Guideline Harmonization Group at the websites shown. And future studies assess the incorporation of additional risk factors such as genetics or inactivity into screening strategies are necessary to better define those at the highest and at lowest risk of cardiovascular disease. So thank you, and for a children question session after the others.
Thank you, Dr. Ark. You right along. I will go to Dr. Thompson for their presentation.
Thank you very much. Thank you to the organizers for inviting me to be here today. I am a lymphoma clinician at Mayo Clinic, and I'm happy to talk about survivorship in hematological malignancies. I don't have any disclosures. So I thought I would focus on what makes heme patients unique compared to solid tumor patients. And there were a lot of talks already in the conference around these things, so I'm hoping that this kind of pulls all the information together. And I see this really in two big categories. One is disease-related, and then the other are specific treatments that our heme patients tend to get. So let's start with disease-related, and leukostasis is one that's important to recognize. This is something that we see generally in patients with acute leukemias, AML or ALL, when their white blood cell count is extremely high, and not just any white blood cell, it has to be the blast count, because these blast cells are very sticky and they can get caught up pretty much at any organ in the body. And what we'll see is what's called blast crisis or hypoleukostasis, when the blast count is anywhere between at least 50,000 and definitely more than 100,000. And so we could see changes again in any organ. It's not uncommon to have visual changes, neurological changes, respiratory distress, thrombosis, but we can also see myocardial infarctions and arrhythmias. And so this is an autopsy photo of the right coronary artery. This was a gentleman who presented with a relapse of acute myelogenous leukemia. His white blood cell count upon admission was 29,000, and by the date of death, there was up to 102,000, majority blasts. And so you could see within that blood vessel, those are all blasts. And of course, damage was done. How do we manage this? This is something that will get your friendly local hematologist out of bed, no matter what time of day or night, as this is a medical emergency. And we have to get that blast count down as quickly as we can using leukophoresis. We also hydrate them with hydroxyurea as a chemotherapy, oral chemotherapy agent that would work for either ALL or AML as a band-aid to get that white count down, and then allopurinol to prevent tumor lysis syndrome. One other clinical thing to note, if a cardiologist is called to see the patient as they're having a myocardial infarction in the setting of, let's say, blast crisis, plus their hemoglobin is low, let's say it's 6, you want to wait before giving a red cell transfusion until the white cell count is down with leukophoresis. Because if you add red cells, you're actually going to increase the hyperviscosity and potentially make things worse before they get better. Our heme patients can also have direct cardiac infiltration because of their disease. So I'm a lymphoma physician, and the most common tumor that involves the heart malignant tumor is sarcoma. Lymphoma is second. These generally are diffuse large B-cell lymphomas. Primary cardiac lymphoma is actually incredibly rare, and that's where it would be the only site of disease. This generally is seen in large cell lymphomas, or sometimes even Hodgkin lymphoma as secondary spread. Autopsy series report anywhere up to 20% of patients with widespread aggressive lymphomas to have cardiac involvement. I'll say clinically, 20% sounds ridiculously high. I think it's more like the 1%. These are a couple cases in the career. And the right atrium is the most common site for involvement.
And there's a risk of arrhythmias with treatment. And I'll share a case. This is a patient who I treated a couple of years ago, a 32-year-old male who presented with ulcerative colitis on infliximab and then developed an aggressive lymphoma as a result of the biological treatment. And so you can see his imaging findings here. He went to bronchoscopy initially before I saw him, and the bronch was aborting because of atrial fibrillation. And then imaging, you can see direct cardiac infiltration. His disease was fairly complex in terms of treatment. He showed up in my clinic with that PET scan, and the reading, of course, is quite scary to me as a hematologist when this invading the atrium and down into the ventricle, and he's in already a flutter. So co-management between hematology and cardio-oncology is absolutely necessary. And studies have looked at the role of debulking, but that generally is not recommended. Systemic chemotherapy is the modality of choice with cardiac monitoring as an inpatient. So this patient now is in complete remission, but he underwent a couple challenges along the way with arrhythmias as a result of the therapy. As that tumor shrinks down, the arrhythmias can get worse before they get better. Moving on to treatment related, and this is a diagram of what mantle radiation looks like. This was the most common modality to treat Hodgkin lymphoma back when radiation first became available, all the way up until the late 90s and even into the early 2000s. So high doses, generally 40 gray or higher, give it to the neck, the axilla, and the mediastinum. And then, of course, it's been largely phased out. I only see it used every now and again in salvage treatments now, because we know about all of those late effects that you've been hearing about for the last few days, the range from coronary artery disease to cardiomyopathy to the valvular disease, pericardial disease, arrhythmias, not to mention the secondary malignancies and others. Most patients now are treated with systemic therapies. We just heard a lot about anthracyclines, and anthracyclines are still the backbone for our aggressive lymphomas, including diffuse large B-cell lymphoma, which is the most common lymphoma, a Hodgkin lymphoma, and acute leukemia. So certainly we continue to use this drug despite having side effects, as it's very effective. But we have many other systemic agents that we use in the treatment of heme malignancies that can have cardiotoxic effects, including alkylating agents. We use platinum agents as well, BTK inhibitors in CLL and SLL, TKIs in CML, and then immunotherapy in Hodgkin lymphoma. And this is not a comprehensive list. Of course, there are many, many others that can cause cardiotoxicity. Allogeneic stem cell transplant is a unique therapy used almost exclusively in hematological malignancies. And we know that patients who get to allo transplant generally is not a first-line treatment. And so many of these patients come with cardiovascular risk factors, including the receipt of anthracyclines prior to getting there. Some of them may have had mediastinal radiation, and many of them have myeloid malignancies, and so they may have iron overload from the number of transfusions that they've already received. And then, of course, the treatment is quite complex. They get conditioning chemotherapy. Many of them will receive total body irradiation, and then as a result of the transplant itself, they may get GHD, as we saw during the Jeopardy, and then the immunosuppressive drugs can cause cardiotoxicity as well. And in fact, survivorship studies show that the risk of developing cardiovascular disease in a patient who had an allo transplant is 4.5 times higher than the general population. And then CAR T therapy, the new kid on the block, where we know this is an individualized cell-based technique. Patients' T cells are harvested. They're genetically modified to get this chimeric antigen receptor on the surface that then recognizes the tumor cell. And in the treatment, then we get two major side effects: the cytokine release syndrome and neurotoxicity, which are the most widespread. The cytokine release syndrome can be cardiotoxic, and all of these various cardiac issues have been reported in patients with cytokine release syndrome, arrhythmias, course, hypotension, heart failure, cardiomyopathy, myocardial ischemia, shock, and death. And so patients with significant CRS need to go to the ICU for monitoring. And as we heard in the Jeopardy, tocilizumab would be a treatment of choice plus minus dexamethasone. And with better earlier recognition of CRS, these side effects are much less than when CAR T therapy was initially used. That being said, those are the acute effects. It hasn't been around long enough for really us to understand what long-term effects of CAR T therapy there will be on the heart and other organs. All right. So we know overall in heme malignancy survivors, the risk of cardiovascular disease is 2 to 4 times higher than the general population. And in fact, patients who have a history of a heme malignancy have the highest rate of death from heart failure compared to all other cancers. And I'm sure that's related to the anthracyclines and the radiation therapy that's used very commonly or used commonly in the past in treatment of these diseases. Then, of course, we have an aging population of retreated patients with anthracyclines later and later, up until their 80s even. And so patients in their 80s oftentimes have comorbidities, and they come to us with other risk factors that we know are traditional risk factors for heart disease. Hodgkin lymphoma is probably the best cancer type studied in cancer survivorship, as patients are treated generally at younger ages, and the cure rate is excellent. And so we have a large number of people who are going to go on and live for many decades of life. And so we can see in some of the studies that we've already seen presented here today that mediastinal radiation and chemotherapy certainly do a double whammy for these young patients. Guidelines, you've heard a lot about this. I think it's just really important as a clinician for me and my colleagues to remember that baseline cardiac screening prior to treatment is necessary, then modify primary prevention based on the patient in front of us in collaboration with cardio-oncology colleagues. I'm going to go through all the guidelines that have been covered well here, but I'll end just with answering a question that many of my patients have, which is, I'm done with treatment, doc. What can I do now to stay healthy? And I tell them, we can't take away the chemotherapy, can't take away the radiation or the other medications or treatments that you got, and we don't want to because they put you into remission. But what we can do is modify long-term effects. And I think the studies of physical activity in cancer survivors are pretty profound, particularly this study in Hodgkin lymphoma survivors showing that those who are more active, and this was cut off of 9 METs per week, have a lower rate of cardiovascular related effects, including not just coronary artery disease. It was really every type of cardiac disease that they looked at. We also have data that physical activity can decrease the risk of some lymphomas coming back. For example, we know this for many other tumor types. So I encourage all of my patients to make this a big part of their survivorship journey. So my take-home points: heme malignancies are associated with some unique risk factors because of the disease itself, as well as treatment-related. And in fact, that's why heme patients have a higher risk of cardiovascular disease than other cancers. And surveillance is an important part of survivorship, with really emphasizing physical activity. Thank you very much. Thank you, Dr. Thompson, for that fantastic talk. We will do questions at the end of these 3 talks, so we'll move right along to Dr. Preston Masley. Hi, thank you very much. Thank you for the organizers. What a great meeting. It's always, I get PTSD after we did it in Toronto, so I can imagine all the work that's gone forward. I'm a medical oncologist from Toronto. I have the pleasure of working with Dinesh, and I'm talking about pregnancy and cancer. These are my disclosures. So I want to break up my presentation into kind of the cancer survivors, specifically pediatric cancer survivors who then become pregnant. But really the focus also will be on breast cancer patients that I treat that are pregnant, and that we're actually giving chemotherapy to pregnant patients. So we've already seen this. It is truly
an issue with respect to our pediatric cancer survivors. September is the Childhood Cancer Awareness Month. We are in September, so this is a bit of an appropriate presentation. And really when we take a look at the most common, we've seen already leukemia and blood tumors are the most common with respect to treatment. We've also heard about anthracyclines and radiation being significant. And when we look at just the US statistics, about 500,000 childhood cancer survivors. And the women will try to get pregnant. We already kind of taken a look at this. I'm not going to spend much time, but just recognizing if a child received an anthracycline or chest wall radiation, this puts them at risk. Specifically women if they're going to try to get pregnant. And so it's just demonstrating the fact that you certainly have this increased risk of cardiac dysfunction. This was obviously, we already see this in terms of the improvement in the guidelines with respect to how these children and young adults are then followed, and it has been kind of decreased. But specifically when you take a look at pregnancy, that if a child has received an anthracycline or chest wall radiation, regardless of the dose, these women need to have a cardiologist. They need to have a multidisciplinary care to take care of that woman through pregnancy. And so what happens when these childhood cancer survivors do become pregnant? Well, as we know, in pregnancy, there are significant cardiovascular changes. The cardiac output increases and happens all the way through, but predominantly within the third trimester and the time of pregnancy, even postpartum, your blood pressure changes and even more cardiac output that occurs. There's also a higher thrombotic risk. And so these are kind of the milieu of what a woman goes through with respect to her cardiovascular health during pregnancy. And so when we take a look at cardiac outcomes in pregnant women treated with cancer, this is data that was from my hospital, Mount Sinai Hospital, that Dinesh looked at 78 patients. And what was recognized is that if a woman had cardiac toxicity or child had cardiac toxicity, that has certainly increased their risk of developing heart failure, not cardiac toxicity, but heart failure at 31% risk. And so this is kind of the guideline that I think really does work well. But recognizing that if a woman had a childhood cancer, again, probably regardless of anthracycline, but we've heard yesterday by Dr. Lipschultz that 75% of children with the cancer diagnosis will have received Adriamycin, will have received an anthracycline. So that is the majority of cancer survivors. And so I think, that this really is a kind of a call to action that these women should have a cardiac assessment, have a echocardiogram. And if that EF is less than 40%, that woman should be advised not to get pregnant. But unfortunately, these are usually women who are already pregnant that come in. And so this is just a guideline with respect to how these women need to be assessed. And this is just looking at the higher risk population. And so when we take a look at the impact of cancer therapy-related cardiac dysfunction, again, this is Dinesh, they looked at a meta-analysis. Once again, we certainly see that there is this increased risk of developing heart failure. And so we do have guidelines, and we take a look at both the ICOS guidelines for mitral diseases during pregnancy, not necessarily survivors, but we also have, as we've gone through the 2020 ESC guidelines, and once again, is just demonstrating the recommendations for monitoring in cancer survivors during pregnancy. And here you have, as we discussed, our level of evidence. But I think I'm going to also put in a plug here. This is Ann Partridge's work from Yale that looked at early stage breast cancer patients, stage 1 and stage 2. There's over 500 young women under the age of 45 who wanted to interrupt their endocrine therapy to get pregnant. And about 45% of these women did receive an anthracycline. There was no difference in survival, either invasive breast cancer survival or distant recurrence. There was no effect in live births. In fact, over 75% had a healthy live birth. But you have to pull this out of the end of the article that really didn't look at ejection fraction. You don't have data actually on cardiovascular effects. They just talked about hypertension, preeclampsia, which is just over 3% in this population. So just to summarize this part, pediatric cancer survivors and pregnancy, really there is an increased risk of cardiac toxicity because the majority of these women have received an anthracycline and probably some form of chest wall radiation. And this does require a multidisciplinary team. And so all, in my opinion, doesn't know my opinion, but all children who had a childhood diagnosis of cancer and women who decide not to become pregnant should own a multidisciplinary team to certainly treat them. Now, what happens when a pregnant woman has a diagnosis of cancer at the same time? And we do see these at my center because we're a high-risk pregnancy center. So we have a multidisciplinary team that cares for these women. This is considered gestational cancer. Fortunately, this is not common, but we are seeing the trend. Younger women are being diagnosed with breast cancer, and we're certainly now seeing more of a trend with respect to this occurring. And as you can see, breast cancer is usually the most common. In our dedicated center, our obstetrician also is dealing with lymphoma patients, in addition to some cervical patients, but also ovarian cancer patients. And so we take a look at our Canadian data, long-term mortality in patients diagnosed with cancer during pregnancy and 1 year postpartum. And these are 3 provinces in Canada. Ontario is on the bottom. And certainly what you can see here is that, there is an increased risk of mortality of survival when these women are diagnosed with cancer during their pregnancy. And so when we start taking a look at how we can treat these women, at 14 weeks, there's already fetal development. When you look at the fetal development, and this is when we start considering and start treating them with toxic chemotherapy. And anthracycline taxanes are the mainstay of therapy that we provide to our women who are diagnosed with cancer during their pregnancy. So it's already at the 14-week mark, is a very dedicated treatment and is at the second trimester. And so when you kind of take a look at how this has changed over time, I really like this paper because it demonstrates that we didn't give a lot of systemic therapy. And that's the purple bar here. As you can see now in the year 2010 to 2015, this now has increased in addition to improvement in live births. So, gestational pregnancy associated breast cancer is defined as breast cancer diagnosed during pregnancy in the first postpartum year or anytime during lactation. This is the care pathway that we have at our institution at Maros Hospital in Toronto, how we actually care for this patient. As you can see, it's a multidisciplinary team. And then as we give chemotherapy, these organs being monitored very closely, both the fetus, its fetal cardiac monitoring, in addition to being monitored in our chemo suite when she is receiving her chemotherapy. And as you can see, the main effects of chemotherapy during pregnancy on the embryo and fetal development is not that significant. You think of myelosuppression, we support the women with GSS support during their chemotherapy treatment, but there hasn't been any deleterious effects to the fetus. There haven't any stillbirths or any concerns with respect to fetal delay. We do avoid, as mentioned, any antibody therapy, so no trastuzumab, no immune checkpoint inhibitors in this population. And these are the 2022 USC guidelines that we've all seen, and there is a guideline for the pregnancy. It's considered a special population. And, pregnant patients with cancer, as mentioned here, we avoid any antibodies, as mentioned, such as trastuzumab and ICI. There is, of course, the 2023 NCCN guidelines for dealing with women in terms of also the surgical resection and treatment that occurs in the second and third trimester. So we've developed a breast cancer pregnancy for our nurses, for our oncology nurses. We have this course, and it's free to anybody and everyone. The D'Souza Institute is what trains our nurses in Canada. And this is a course that we have created for my institution for educating the oncology nurses how to provide chemotherapy to pregnant women. And it's actually a fantastic resource with multiple different modules. Our question is always whether or not there's a neurocognitive changes that can occur. And we did a small study, we published it last year, looking at fetal exposure to chemotherapy and neurocognitive outcomes. And we partnered with the Hospital for Sick Children in assessing a neurocognitive battery of tests in these patients. And it was noted that there was really no detrimental effect in terms of the development and neurocognitive development in young children after their moms were exposed to chemotherapy. And so really, since this is truly still rare, we do need to build some registries, an opportunity for ICOS even to build a registry for pregnant women who have received chemotherapy or even the childhood survivors. And so this is a U.S. cancer pregnancy registry that is accessible. We also at Sinai, and on Sinai have the PINK program, and this is for women 45 years and younger. And in our program right now, we have 12, 10 actually, 2 unfortunately died when they were diagnosed with that cancer and were pregnant. But we have 10 currently in the last year and a half, and we opened up our PINK program. So this is unfortunately a reality that we deal with. And just try to support our patients. So to end off with, cancer pregnancy, this is truly a multidisciplinary approach. We do not do this alone. We work closely with obstetrics, cardiology, and cardio-oncology, anesthesia for the safe delivery of the child, and also the safe delivery of systemic chemotherapy to our pregnant cancer patients. Really, it is safe to treat chemotherapy in the second and third trimester. As mentioned, we do not treat with any form of antibody therapy, but really are just anthracyclines, cyclophosphamide, and taxanes. And it's a very coordinated approach with respect to delivery. And these are specialized clinics, and these are high-risk special patients. And unfortunately, the incidence is increasing, and we need more data, so registry data will be certainly important. Thank you very much.
Thank you so much, Dr. Preston Masley. We have a few minutes for questions. If folks would like to know first, the microphones there in the audience.
Excellent one question. That had this about throwing women who get pregnant and then have the breast cancer. The second group of Dr. Preston Masley, right? Is there any role for fetal echocardiograms if you're giving anthracycline?
Sorry, I can't.
Any role for fetal echocardiograms if you are giving anthracycline?
So Candace Silversides is the cardiologist that works closely with us, but she focuses more on the mom. And so I'm not aware of specific fetal echo monitoring. But I know that we just basically look at the heart rate with our fusing pre and post.
Thanks.
So on top, I was wondering if you monitor the women in a different way that are either more or less, or in the different way that the usual patients get after cycling.
Definitely more. So we can't do obviously 3D echoes. But they sort of look at an echo before, they'll get an echo right before delivery. And if they're getting an anthracycline taxane, typically we don't get that much in because it's a short window. We'll either get the anthracycline in, and then we'll get the taxane, say the HER2 positive, get the taxane trastuzumab after, but they are certainly monitored and not much more closely. We have a really dedicated regimen, more than our children who are not pregnant.
So that's a follow-up question. Do you see any different signals given the physiological adaptation during pregnancy than the reverse adaptation post-partum?
I haven't looked at that data. We haven't interrogated. We are capturing it. And Christine Elser kind of runs the genetics and pregnant group, and she's been the lead author on all of our guidelines and programs. But I
don't know that yet with respect to, there's no increase in nausea or any other, symptoms. For example, young women are definitely more nauseous. We're able to still give the proper antiemetics, GC-SAF support, and they do have safe deliveries. Like, we haven't had any issues. Only our 2 patients who passed away, they're quite, the fetus died as well, unfortunately. But they were very, very ill. They came in almost in extreme mess. We couldn't mess with them.
Dr. Pops, really anybody on the panel, how do you help for frailty, deconditioning, and general decreased physical activity or physical function related to fatigue, myalgias, arthralgias, or other treatment-related side effects? Like, your recommendations for physical activity in your patients? Can you repeat the last part of that question? Yeah, how do you help for decreased physical function related to fatigue, myalgias, and arthralgias, or other treatment-related side effects, and your recommendation for physical activity? Oh, they find that maintenance.
Yeah. I agree completely that many patients are going to go through intensive treatment, like, for example, post-allogeneic stem cell transplant. Patients get quite deconditioned through that. Even young patients going through Hodgkin lymphoma therapy can become quite deconditioned. And those are the patients that I think benefit the most from physical activity. So what I tell my patients is that the majority of studies of physical activity in cancer patients are walking programs. This is not training for a marathon. This is not rock climbing. This is generally not even strength training. Most of it is walking programs. And so I try to meet patients where they're at. If it is a 78-year-old grandma who's using a walker, okay, let's start there. And if it's a 25-year-old who used to run marathons, all right, they may have different goals. We have a great group that is within our cardiac rehab area, and our trainers work with our cancer patients as well. So there's a lot of goal setting that happens early on. What are your goals? What is your fitness level? And then what equipment do you have available to you, as not everyone has the ability or wishes to go to a gym, for example, especially after just completing cancer treatment. So getting that individualized exercise plan is really helpful. And again, I prefer to call it physical activity as opposed to exercise. I think exercise sometimes has a negative connotation for people. So just getting them moving, starting where they're at. And studies will show that not only is there the benefit, the cardiovascular benefit, but of course, there's the quality of life benefit, as well as symptom relief from all of those post-cancer therapy side effects.
Wonderful, thank you. Are you also using a prospective surveillance model or approach in terms of how early you plug patients into either athletic training or skilled cancer rehabilitation?
I wish we had the staffing to get everybody plugged in, starting from the time of diagnosis. That would be the ideal. We don't have that. And we also have many patients who come from far away for treatment. And so trying to coordinate everything in a convenient package doesn't always work the best. Patients will tell us that if we refer them too late, so let's say we get them through their therapy, we're in the surveillance, and it's 6 months or 9 months after their treatment is done, and we start focusing on the survivorship and the lifestyle factors and such, they generally will say, you know what, this is great, but I wish I had this earlier. So starting as soon as treatment is done, or even during therapy for those who are really motivated, is the ideal.
Thank you.
There was, so last week we had our big European Society of Oncology meeting in Barcelona, and there was a fantastic presentation called Pop Training. And this was during chemotherapy in breast cancer patients, a study in the Netherlands where they looked at control, just saying you should exercise, and that they looked at resistance training, hit cell intensity, interval training, and aerobic exercise hit. And they followed these 300 women up to 5 years, looked at survival. And it was incredible that the resistance training hit group had the best survival. Then the aerobic was a little bit less, and then the control dropped. The delta was better than we achieved with systemic therapy. So I can't underscore the importance of exercise. This was during chemotherapy, that it was 16 weeks of this exercise, and they follow these women. But the fact exercise is so important in our cancer patients.
So sorry, there's one more question. Please find our presenters after us. I'm sure they'll be happy to answer. But that concludes our question and answer period. Thank you so much. It's a great pleasure again to transition now to our plenary presenter, Dr. Emily Tonorizos, who's joining us via Zoom. Dr. Tonorizos is the director of the Office of Cancer Survivorship at the National Cancer Institute. She is an incredible array of diverse research and clinical practice across all populations of cancer survivors in multiple settings, taking care of multiple patient populations. And so we're so happy and pleased to have you here today to present to us. So with no further ado, Dr. Tonorizos, I'll pass it over to you. Thank you.
Thank you so much, and thank you for having me. And I'm very sorry, and I can't be with you in person, but I'm glad that I still have the opportunity to talk about the Office of Cancer Survivorship and what we've been working on. And I specifically have some things to address related to aging and cardiovascular disease, but I'm really here also to learn from all of you and your presentations and the discussion, obviously. So my name is Emily Tonorizos. I am the director of the Office of Cancer Survivorship at the National Cancer Institute. And I inherited this role from some amazing women who came before me and who really led the way in terms of setting the stage for the work that we do today. And one of the things that happened immediately prior to starting was Dan Mayer, who was my predecessor, revamped the definition of cancer survivor. So the definition has always been that a person is considered a cancer survivor from the time of diagnosis through the balance of life. But what Dr. Mayer did was to add the second part, which says that there are many types of survivors, including those who are living with cancer and those who are free of cancer. And as I mentioned, we got this definition from the advocacy community, and it's really important to acknowledge the role that people who were diagnosed with cancer and their families have had in the Office of Cancer Survivorship founding in 1996 and in the work that we have done since then. We have a lot of direct ties to cancer survivors and advocacy groups, but we really listen to them when it comes to deciding what our agenda should be or what kinds of things we should be working on. And one of the things we think a lot about is this word survivor. So this quote comes from a woman who was in a study of people with inherited cancer syndromes. And she said, "I strongly identify as a breast cancer survivor. It's the seminal part of my young adulthood. But I feel differently about survivor in the context of having a glioblastoma, which is an incurable grade 4 brain tumor. So I identify as a breast cancer survivor, but a brain cancer patient." And I put this quote up to acknowledge that the word survivor is not a word that resonates with everyone, but it is a word that we use for the purposes of the research. And when we think about cancer survivors, we came up with this figure. It is on the Office of Cancer Survivors website, and everything on that website is free to the public to use. You can cite the website, but you actually don't even have to, quite honestly, because these we're here as a service to the American public and to people in this country who've been diagnosed with cancer. And so everything is free and open to be used if you want it. Anyway, we came up with this figure to try to describe that even though we always say everyone is a survivor from the time of diagnosis, we also acknowledge that there are different populations of cancer survivors. And sometimes it is useful to talk about people who were diagnosed with early stage cancer, or people who were diagnosed with more advanced to metastatic cancer, or people who are diagnosed with end-stage cancer, where the goal of care is end-of-life care. And we've also started to think about this concept of survivorship, which is different from the person who's been diagnosed with cancer. And it really tries to represent this idea, which we have called a state of being. And it includes the perspectives, needs, the health, and the physical, psychological, social, and economic challenges experienced by people and caregivers after cancer diagnosis. So what that means in this setting is really thinking about the illness and experience, which is to say the cancer experience. And when we say it like that,
The idea is that we can talk about a concept of survivorship that includes things well beyond the individual survivor. But of course, we have a mission in the Office of Cancer Survivorship, which is to support research. And that we are at the NCI, and we are a research supporting organization, and our office is squarely within that role. So our mission is to support research that both examines and addresses the long and short-term physical, psychological, social, and economic effects of cancer and its treatment. What that means in practical terms is that, for example, the Office of Cancer Survivorship does not write guidelines. There are other organizations that write guidelines for cancer survivors, but we support research. And when we think about survivorship research, we like to make figures. The Office of Cancer Survivors are about to say it. We came up with this figure, which we call the Survivorship Research Rainbow. And this is a figure which intends to represent survivorship researchers and the work that we do. And what you see is that survivorship research covers a huge breadth of questions. We talk about things like acute toxicities, long-term side effects of treatment, late effects, healthcare delivery, all of that, health services research that goes on, financial impact of cancer, health promotion and health behaviors. We support infrastructure, especially with regards to cohort studies and methods and measurements, meaning things like patient-reported outcomes. And we try to support research that is happening not just at the survivor, the caregiver, the individual level, but also at the level of the team, the healthcare system, the community, the healthcare care, and the policy landscape around cancer survivorship. So we have a part of our call to duty in the Office of Cancer Survivorship is to conduct survivorship grant portfolio analyses. There was a seminal meeting that occurred in 2019 that was hosted by the Office of Cancer Survivorship before I was director, where they set up they noted some gaps that are in the survivorship research portfolio, and they called for survivorship research portfolio analyses to be done in a more rapid and an ongoing way. So when I came into the office, I really did take that as my call to action. And so we have published our survivorship grant portfolio analysis, which represents the survivorship grants which are funded by the National Institutes of Health over this period of time. But we didn't actually stop in 2021, and this is something we continue to do, and we've published on other aspects of the portfolio since this time. But I just kind of wanted to give you the overall, which was published in 2022 in the Journal of Cancer Survivorship. So we include all research and project grants, which means everything that starts with an R or a U. We also included PO1s, SC1s, and SC3, and I can talk about the PO1s if anyone is interested in that later. We looked at research focused on survivors and informal caregivers and studies addressing, and here's where we come to our definition of survivorship research to decide what should be included, because we want to be very careful that we're not including treatment trials. And so it's actually becoming more and more difficult to make this designation, but we have a very strict definition which we use for our portfolio analysis, which is that, first of all, it has to be a human study, and then it has to address some of these specific survivorship research questions, either secondary or tertiary prevention for cancer and related side effects, assessment or surveillance of side effects, intervention studies to address cancer and its treatment, health services by providers, patients, and caregivers. And when we looked at the portfolios in 2017 to 21, we saw that just like across NCI as a whole, the RO1 is the most common mechanism. We did see a slightly higher proportion of multiple PI studies, meaning that we are a field that tends to use pain science. And so that's represented in our multi-PIs. And we have a lot of early stage investigators, which is just thrilling. It's just thrilling. It's a field of science which is growing. And obviously this is a group that needs support, but is well represented in the portfolio. We saw that about 60% of the portfolio is intervention studies. This is something that historically has been called out, that there is not a lot of intervention research in the survivorship portfolio, but that has changed over time. And we saw that among interventions, the most common outcomes were related to psychosocial or supportive care, lifestyle or health behaviors, and care delivery. And unfortunately, we only had 23 studies which were identified as implementation science. That's something we talk about a lot. And when we looked at outcomes, physiologic in this setting means anything kind of health related. So could be something, anything happening to the body, a second cancer, anything like that. Psychosocial was the next most common outcome, followed by quality of life, healthcare utilization, and health behaviors and health promotion. So I specifically wanted to talk a little bit about our work in primary care and cancer survivorship. And this does intersect with the cardiovascular work that we're doing as well. So we know, first of all, that there has been an exponential growth in the number of cancer survivors in the United States. We have these recent numbers showing 18.1 million cancer survivors currently living in the United States. And we know that over 2/3 of cancer survivors are receiving care in primary care. So as much as we want to support interventions that occur in cancer care delivery settings, a lot of survivors are in primary care. And so when this paper came out about the proportion of survivors that were being seen in primary care, really started to think about what can we do to support survivors and survivorship care where it's being delivered. Not surprisingly, when you look at primary care records, the medical record documentation of cancer history and cardiovascular risk is not great. So this is a study led by Eric Chow, where they looked in the records of participants in the childhood cancer survivor study to see what had been noted, either with regards to cardiovascular risk, a history of childhood cancer, a history of radiation, or cardiotoxic chemotherapy. And what you can see in the light blue is what is represented in the childhood cancer survivor study records. This means, for example, 65% of the participants got radiation therapy. And then you can see what's reflected in the primary care provider's note, which is a much lower proportion across the board. And it's not surprising that we see that, but it is a little disheartening. So, I can talk more about that work if you're interested. So we went and looked to see what are we supporting at NIH on cancer survivors who are being cared for in a primary care setting. And we found only 22 grants that had any involvement of primary care providers in cancer survivorship research. The majority of those grants were focused on survivors engaging with their personal provider. So this is a very common model of survivorship research where you find the survivor, you deliver some usually educational resource, which then you ask that survivor to take with that to their primary care provider. And that was a typical model that we saw for the collective studies that were in the portfolio. Only 8 grants delivered something directly to the primary care providers. And as I said, most were focused on engaging these individual providers. Only 4 grants had interventions which focused on the practice or the system level. And unfortunately, we know that there is not a lot that's going on to support primary care for cancer survivors. There are guidelines that exist, but we see implementation has been uneven. We've seen limited impact of the survivorship care plans and educational initiatives and training programs for interested PCPs, which are in existence, but may not have a lot of uptake. So I'm sorry, I'm just going to jump ahead to my time. It's already rolling. Okay, so we last year put out this RFA. When you see something with the letters RFA in front of it that's coming from MCI, that means that the National Cancer Institute has set aside funds designated to this purpose. And in this case, it was for UO1 studies addressing the needs of cancer survivors in primary care. And in this case, we were trying to stimulate the development and testing of practice and health system interventions that support and promote high quality primary care for cancer survivors during or after the treatment period. And we funded 4 studies through the RFA, and they are just getting going. We're having our first investigator meeting this month. I wanted to spend just a minute talking about aging and older adults.
There has been a lot of work that has gone on at the National Institute of Health and specifically at the NCI related to accelerated aging. And these are just some of the highlights, which I'm going to skip through, the people who are primarily involved in this work. But of course, we know from the most recent estimates that cancer survivors are aging, that older adults with a history of cancer are growing as a proportion of the overall population in the United States. And we know that there's a few things going on with cancer and aging. One is that as you age, your risk of cancer goes up, but also that cancer treatments may cause accelerated aging. And I know this is not new to the attendees, but these are some of the ways that we're thinking about the aging biology and the aging phenotype. There has been a notice of special interest related to understanding the effects of cancer and cancer treatment on aging trajectories and outcomes. The purpose of this NOSI was to solicit grant applications to better understand the effects of cancer diagnosis and subsequent cancer treatment on aging trajectories and outcomes. And there was recently a special section which was published in the Journal of Cancer Survivorship and led by those three people on the prior side, Lisa Colicchio, Jen Nida, and Paige Green. And you can go to the Journal of Cancer Survivorship and read all about the work that they have been supporting. I just wanted to show you two studies that came in and were funded through that NOSI. One is long-term trajectories of accelerated biological aging and functional decline associated with breast cancer and treatment. And the next is an R21, the Pacific Aging and Cancer Studies in Infrastructure, advancing the use of digital biomarkers and related technologies for research on functional aging. This is a phased innovation award, which is an interesting mechanism. I'm happy to explain further if you're interested. And the last one I wanted to tell you about is this R01 on targeting senescence to mitigate chemotherapy-induced functional decline. So some of the studies that came in through that NOSI were really interesting and exciting, the studies that were funded. And there is currently a PAR, which is led by the National Institute of Minority Health and Health Disparities, called Advancing Healthcare for Older Adults from Populations that Experience Health Disparities. This is an R01 PAR, meaning it has the designated due date, but not necessarily set aside funding. And Michelle Doe's, whose email is here, is the NCI contact. If you go to this PAR website, you will see the NCI specific bullets relating to what we're specifically interested in at the NCI. And then lastly, I just wanted to talk about long-term survivorship just briefly. We know that almost 70% of cancer survivors in the United States have lived 5 or more years since diagnosis. And this idea of calling attention to long-term survivors or trying to encourage studies in long-term survivorship has been around for quite a while. It feels like a little bit like we are a broken record on studies of long-term survivors. The first RFA on long-term survivorship came out in 1997. We had a second RFA that came out on long-term survivors, and this is just a graphic depicting the grant. We are in the middle of a survivorship grant portfolio analysis on long-term survivorship. What we're seeing is that the most common long-term survivorship studies are pediatric survivors. It's not surprising. There are obviously a couple of very robust survivorship cohort studies on pediatric survivors. Pediatric survivors do have a longer time in the survivorship period, but they represent most of the portfolio. And we saw only 6% of the long-term survivorship portfolio is represented by older adult survivors. We do a lot of things at the Office of Cancer Survivorship, funding opportunities that I mentioned, meeting with advocates. Sometimes we have to speak to members of Congress. We conduct our own research. We put on informational webinars, and we do all of this with the idea of supporting investigators and supporting this research. And I'd like to go back to some quotes about why we think this work is important and special. And I would just say that for a lot of people who are working in cancer survivorship, they either have a connection directly to cancer survivors or someone in their family has been diagnosed with cancer. And that's a very common story for us. And we do feel as an office
deeply committed to this topic and to cancer survivors and to doing high quality research on their behalf. We have on our website a very popular section called Survivor Stories, which we are always trying to grow. And this is a place where you can go and see some new survivor stories on people who were more recently diagnosed with cancer. We have a whole bunch of funding opportunities. We are in the middle of working on something on hours of care. There was a request for information that just came out. I'm happy to talk more about this, but this is a concept where you really try to go beyond just physical body and external, or even based on lifestyle health, and try to address the spiritual, mental, social, and emotional needs of the person who's been diagnosed with cancer. There is currently an RFA that is out to establish the Whole Person Research and Coordination Center under the NIH Whole Person Initiative. It has a very soon due date, but if it's something you're interested in, please let me know or reach out to Paige Grant here at the NCI. We've had a number of other recent funding opportunities, including one that's still open on sexual and gender minority population, a no-see on disparities affecting healthcare utilization and health outcomes among childhood cancer survivors, an open funding opportunity on pragmatic trials, which is a new G3, H3 mechanism. It's a lot of money, and it's usually 6 years of funding. So if you're interested in that, please check it out. Let me know. We had our RFA 2 dates on survivorship needs of individuals living with advanced cancer, and as I mentioned, the primary care needs of cancer survivors. And then just to close with our events, in the spring, we had Katie Devine talk to our new investigators, and her talk was recorded and it's up on the website and you can watch it. I really strongly recommend listening to some of, not just her talk, but some of the other new investigator talks that are there. These are talks from people who have been successful in survivorship research at different levels in their career and who want to offer insight and support to people who are trying to craft a career in survivorship research. There are some unique reasons it's difficult to do survivorship research, and so this series is one way that we're trying to address some of those challenges. We just had Frank Keynote talk in our OCS Director series on September 17th. His recording will be up very soon. And coming up in October, we have your very own Blaes, along with other speakers from survivorship clinical programs who will be working with Priscilla Beelan from the Office of Cancer Centers to talk about advancing research through cancer survivorship clinical programs. And I just wanted to end with some words from Annie, who is an ovarian cancer survivor, a woman actually living with ovarian cancer for many years. And she said, life is sweet. And I think the point of surviving is to live it, to live your life and help others if you can. Thank you.
Thank you so much for that incredibly informative talk. We are now at the end of time for this session, so we'll be moving on to our final session of the day.
Hello, everyone, and thank you for hanging around for the very last session here, leveraging technological advances to improve care of cardio-oncology patients. We promise you won't be disappointed. We have two excellent speakers today. I know this is the end of the day, so probably I think we are going to have a discussion at the end, but I think we'll do one talk and then we'll have questions after the next talk and then questions to keep things moving along so we're not going over too much on time.
Speaker one is Dr. Tony Sung, is the A. Drew Jennings Professor of Medical Oncology, Professor of Medicine in Division of Hematology, Malignancies and Cellular Therapy, and Director of the Center for Survivorship and Patient-Oriented Research at the University of Kansas Medical Center, California, born and bred. He received his undergraduate degree from Stanford University. He subsequently received his MD from Harvard Medical School, did his internship and residency in internal medicine at Johns Hopkins Hospital, the Ulster Medical House Staff Training Program, and fellowship at Duke University. He spent 10 years on faculty at Duke before coming to Kansas Medical Center just recently in 2024. He is also a special government employee of the United States FDA, an ad hoc member of the FDA Oncologic Drug Advisory Committee, in addition to various other roles. Today, he will present on his innovative work in integrating patient-level data into cancer survivorship care by leveraging more mobile health technologies, AI, and mobile outcome measures. So Dr. Fritzo, thanks for your time. Thank you very much.
Good afternoon. It's a pleasure to be here with all of you today. I just listed my disclosures here. Although I am an employee of FDA, my views are my own and not those of FDA. So there's a lot of changes in cancer these days, on cancer treatments and survivorship, which also brings up a lot of opportunities. There's a rapid growth in the number of cancer survivors, as you've all heard. There's also been a shift in the movement of cancer therapies from hospital-based systems to home. But at the same time, there's opportunities with increased adoption of mobile health and wearables to monitor patients in that setting. There's also been advances in artificial intelligence and machine learning to analyze all the data that's been generating. And there's recognition, as you've just heard from NCI, about the importance of quality of life, patient-reported outcomes, and other social determinants of health. And so what I'm talking about today is attempts to bring all of these together to improve outcomes for our cancer patients. As a physician, I always think about patients first, and so I always think about my patients as I give my talks. The first case is a 67-year-old gentleman who's seen for consideration of transplant, and like all patients, they ask me, what are my chances, and am I going to be okay? And I note that this is probably one of the shortest case presentations I've given. You'll probably notice I didn't even mention the patient's disease, because we know that older adults, unfortunately, tend to do worse after stem cell transplantation. But if you look into them a little bit deeper, it's not just the fact that older adults have increased comorbidities as measured by the HCTCI or comorbidity index, but there's also important differences in older adults in function and their ability to complete instrumental activities of daily living, or IADLs. And as you can see, if you have an older adult who's able to complete all their IADLs, who has low comorbidities, they tend to do well. But as they start to have deficits in one area or another, they start to have worse and worse survival. And as you think about how to evaluate these older adults, it's important to remember that we're not just looking at comorbidities, social support, and pharmacy, polypharmacy, which we have trained medical professionals, social workers, and pharmacists to help us with, but also think about physical function, cognitive function, nutritional status, mental health, and other social determinants of health. And so we created a clinical pre-peri post-transplant optimization program, or CPOP. And the idea is to evaluate patients along these dimensions, and I listed some of these assessments here. And what we want to do is we want to try to find patients who are impaired at one or more of these areas, and if patients are impaired, refer them to the appropriate services. So this is data from about a year ago now. At that time, we had about 318 patients on an additional evaluation with transplant. These are patients who were seen by a physician and deemed to be a transplant candidate. This table right here represents each patient as a row. The different columns are physical function, cognitive function, nutrition, and mental health. Dark blue represents a deficit in that area. Light blue represents normal function. White is about missing data in that area. And so you can see immediately there are many patients with multiple impairments. About 75% have impairments in at least one domain. 43% have impairments in multiple domain, primarily physical function, but also high levels of impairment in cognitive function, nutritional status, and mental health. And again, these are patients who are newly referred for stem cell transplant, not patients who've gone through the transplant. The other thing is, although we started this program with our older adults and geriatric assessment in mind, we realized that many of our younger adults come to us. They may be beat up from prior chemotherapy and have frailties. So we looked at those individuals, and then we saw that not just older adults had impairments, but also our 18 to 39-year-olds and our 40 to 59-year-olds. And at first, when I saw these results, I was like,
why are nearly every single one of our AYA patients impaired in physical function? That can't be right. But then I thought about it a little bit more and I realized, my primary practice is with older adults. Those are the patients who get leukemia or refer for transplant. And so my eye is a little bit biased. And you look at younger adults and now they walk into the room, they walk out, they seem okay. But it's not until we actually provoke them and we test them and we stress them that we're able to find these impairments. And that's why I think it's especially important to look at these individuals and think about ways to improve their function. And by referring them to physical therapy, we were able to see about half of our patients had improved physical function by the time of their sign-off appointment, which is right before they start their transplant. A lot of these patients are receiving chemotherapy, so we did have a few who did develop new impairments who previously were not impaired. And then similarly, we saw improvements in cognitive function, nutrition, and mental health. And so we actually expanded our program to not just look pre-transplant, but also looking at peri and post-transplant, because we realized we really need to be assessing our patients if they're going through treatment. Again, we walk in and you may see them in the hospital, or we're rounding on them every day, but it's not the same thing as actually provoking them, stressing them to really see if they're developing chemobrain or impairments of cognitive function or struggling with depression while they're in the hospital. And so as we going back to that first case, we evaluated him and found impairments in physical function and nutrition. We referred him to physical therapy and a dietitian. He started PT 3 times a week at home. And by the time he was ready for transplant, he had resolution of all his impairments. He did great during his transplant, and he continues to do well 4 or 5 years later. The second case I want to illustrate gets more to some of the mental health aspects. This is a 28-year-old gentleman with Hodgkin's lymphoma who underwent a stem cell transplant. Unfortunately, he developed chronic graft-versus-host disease of his lungs and ultimately needed a bilateral lung transplant. And the reason I often think about his case is because he presented to us with shortness of breath about a year after transplant in August of 2015. But he had to have a personal Fitbit. And when we looked at his Fitbit data and his step counts, if you chart his step counts per month, his step count was actually falling for about 4 months before he presented, but he never really noticed it. He was more than a year out, so we weren't following him as closely. And I always wonder, if we had noticed that drop from April to May and we brought him in sooner and intervened sooner, could we have changed his treatment trajectory and would he have not needed to get a lung transplant afterwards? And again, this brings up the point that I want to make, that oftentimes you're seeing subtle impairments in patients or things that may not be to the level of affecting day-to-day function. But if we can pick up these things earlier, they're a sign that things are not going well and maybe an opportunity to intervene. The other thing is he continued to track his monthly step count over time until his lung transplant, and it actually correlated quite well. As he felt better, his step count went up. As he was developing more complications, H1N1 influenza, sinus infection, it went down. And we also looked at his FEV1 on his pulmonary function test, and it actually did a fairly nice job of mirroring his step count. And so we created our observational pre, peri, and post-treatment optimization program, or OPOP, as a counterpart to CPOP. So CPOP, as I mentioned, is our clinical program. We instituted it as standard of care for all of our transplant patients, so we can monitor that using assessments that are validated, that are evidence-based, with defined cutoffs, as well as plans for action if we've noticed impairments. OPOP is our observational program. The idea is that we don't really know that this is important, right? We have anecdotes where using mobile health and wearables to monitor patients can be useful, but we don't really have large studies. And so we want to gather that data. We want to give our patients wearables to track their activity, their heart rate variability, and so forth. We want to give patient-reported outcome measures and surveys to see how patients are doing, building up on all the work that's being done with electronic patient-reported outcome monitoring and symptom monitoring. And then finally, we want to bring in biospecimen collection to look at mechanistic insights into their disease course and biological correlates that may be other opportunities for intervention to their care. The third case or example I want to bring up is exercise interventions. One of the audience members asked earlier about exercise, and there was a mention of high-intensity interval training by one of the panelists. This is something that we're also interested in studying from a rehabilitation perspective. We developed this program of remotely monitored, mental health supported high-intensity interval training, or REM-FIT. The idea is to improve patients' cardiorespiratory fitness before transplant so we can improve their outcomes after transplant. The idea behind this remotely monitored program, we have a cancer center with a 92,000 square mile catchment area, so we can't really be bringing patients in 3 times a week to our center like standard exercise programs. So instead, what we do is we bring them in one time. We do baseline cardiopulmonary exercise testing to develop our exercise prescription, and then the rest of the sessions are done at home. We have a mobile health platform that provides personalized support and coaching. So we give all of our patients an Apple Watch. We gave them an iPhone. The first exercise session they did at home, they did via FaceTime with our exercise physiologist. And then afterwards, every subsequent exercise session, we would monitor them during their using the Apple Watch to make sure they're adhering to high intensity interval training and adjusting reporting. And this is an example of what the data looks like. So this is the patient who is relatively fit coming into our program. The x-axis represents time during their 30-minute exercise session. The y-axis represents heart rate. You can see those 2 top dotted lines in red represents the high-intensity exercise target for their heart rate. The 2 dotted lines in green represents our targets for the low intensity. So there's a 5-minute warm-up period, then 1 minute of high-intensity exercise to 80-90% of heart rate reserve, then 1 minute of lower intensity to 50-60%. Repeat that for a course of 10 intervals, and then a 5-minute cool-down period. I also want to show you results from a patient who came to us that was not as fit as that first patient. As you can see right off the bat, their heart rate targets are much lower than that patient above. And as common with patients who are not as fit, they will actually overexert themselves when exercising. Their heart rates exceeded the targets that we gave them. And because they overexert themselves, they eventually tire out and they don't complete their exercise session. But because we're able to get this data from them after every exercise session, our exercise physiologists follow with patients the next day. They can say, hey, you know what, we appreciate you trying, but you actually need to slow things down. Look at your Apple Watch when you're exercising, look at your heart rate, tone it down a little bit. And so by the time we get to the 4th week of their program, they're exercising the full 30 minutes. It's not as pretty as those intervals from that first patient, but it's certainly an improvement on what they're doing. And overall, we're able to track them and ensure that they're continuing to comply with the program, whether they're fit or they're not as fit. This was a phase 1 pilot study that unfortunately was conducted during it was started before the pandemic, but the follow-up period occurred during the pandemic. And so there was a period of time when we suspended all research operations at our university, so we could not get a post-transplant cardiopulmonary exercise test on several of our patients. But for the patients that we were able to get post-transplant CPETs on, we saw that every single patient had an improvement in their coronary respiratory fitness. Overall, there was a 23% improvement in their VO2 peak, which if you think about coronary respiratory fitness, the VO2 peak is about a 10% loss with every decade of age. So we saw a huge improvement there. We also saw improvements in 30-second to stand and 6-minute walk distance. And that we submitted an R01 for a randomized phase 2 trial to hopefully evaluate this at long-term transplant outcomes. The 4th example I would like to give in terms of mobile health technologies and remote monitoring is with temperature. So this is a collaboration with BlueSpark Technologies, which makes a patch called TempTrack. This is about 10 centimeters by 5 centimeters. It fits in your axilla. And it stays on for about 3 days, and it reports patients' temperatures every 2 minutes. And so we are interested in using this in monitoring our patients with febrile neutropenia. We noted that in a study by colleagues at the University of Michigan, they were able to detect fevers an average of 5 hours earlier using this temperature patch or the conventional stick your thermometer in your mouth. And if you think about IDSA ASCO guidelines to start antibiotics within 1 hour of febrile neutropenia or fever detection, if you're able to have a 5-hour lead time on top of that, there's the potential to significantly improve your outcomes by starting antibiotics earlier and preventing the development of severe infections and sepsis. But more than that, we're interested in all the rich data that's generated by these devices. Because you're getting temperature every 2 minutes instead of the conventional, stick your thermometer around every 4 to 8 hours, you have about 100 to 200 times as many data points. And so using machine learning, we're able to cluster these data points and these temperature patterns into different shapes. And we're able to identify one pattern in which on the very left, in which every single patient who had this pattern, none of them actually had an infection. It was probably just engraftment or cytokine release or something else. But these are patients who, normally anybody gets a fever in the middle of the night, we tell them to come to the emergency department, get started on IV intravenous antibiotics. these are patients who we may not need to bring in the middle of the night, especially if we've got remote other devices to monitor their heart rate, their blood pressure, and other vitals while they're at home. In contrast, on the far right is a pattern where every single one of those patients developed an infection. And so these are the patients where we don't want to mess around. We want to bring in as soon as possible so we can initiate them on therapy. And then, of course, there are the patients in the middle where we're still refining our algorithms and trying to figure out what to do, but hopefully with the addition of other data that we're collecting, continuous heart rate monitoring, heart rate variability, labs, and so forth, we may be better pinpoint what's going on. And then the fifth example that I would like to highlight is a collaboration with Lawrence David, a colleague of mine in biomedical engineering at Duke, that we were talking about how it's challenging to monitor patients' urine and stool output in the hospital setting, where not all patients will save their hats, but not even that. Simply talking about the home setting when they go home, how are we monitoring that output? And so Lawrence built a device in his bathroom, as you can kind of see right here in that picture, with all the wires sticking out. Where we would automatically track urine and stool output. If you look at the top graph, what you're looking at is the distance from the toilet seat to the water in the toilet bowl. So when there is a stool event, the stool drops in the water will splash up. So there's a distinctive pattern, so you can identify when the patient's stooling. When there's a urination event, when they initially pee, the water level goes up a little bit, but then it starts draining out and dips down. So what you can identify when patients are peeing and when they're pooping, and then looking at using very fine sensors in the toilet seat and a footrest, you can measure the change in mass. So you can know the delta during which they're stooling or during which they're urinating. And so we now have a much cleaner prototype with funding from the North Carolina Biotechnology Center. We're currently testing this in our inpatient transplant unit. But our hope is that we can develop this device and move it for inpatient use as well as outpatient use to make it a lot easier to monitor ISA nodes for our patients. So in summary, I think there's a lot of potential in leveraging existing off-the-shelf technologies, things like activity monitors, things like these temperature settings, temperature sensors, to monitor our patients and hopefully detect complications earlier and intervene earlier and change their trajectories. I think there's a lot of opportunity to work with technology companies like Blue Spark Technologies, as I noted in my disclosures, or others, to collaborate to think about ways that we can use the data that they're generating in innovative manners that maybe can identify things that they were not necessarily looking for, like predicting if someone has a fever from infection or not. And then finally, I think there's opportunities to work with investigators, colleagues in biomedical engineering and other departments to really develop new technologies to better monitor our patients and better care for them and improve their outcomes. And with that, I would like to thank both our patients as well as my many colleagues, both on the research side and the clinical side, and funding for the work that we've been doing. And I have a minute and a half left to take any questions. Thank you.
Thank you, Dr. Sona, for wonderful talking. Yeah, we have more minutes because we have extra time at the end. So, okay. But really love all the sensors and technologies you're incorporating. Very creative work. And please, questions.
Great. Perfect. Take that 1 minute. So my question is going back to your graph regarding the heart rate during the head. And just looking at the scale, I might presume that one participant was young, the other one was older. So I'm wondering if you also have a stratification. And what can you comment at this point about the age effect in your patients? I'm just
Yep, absolutely. So the question is about the age of patients engaged in our high-intensity interval training exercise programs. The youngest patient in our study was 34, the oldest was 74, and actually the majority were above 60 as it reflects our patient population. And, at first when my colleague David Bartlett developed, he's the exercise physiologist who developed the program, said he wanted to do the high interval training in older adults, especially those who often are still receiving chemotherapy to treat their malignancy. I said, David, are you crazy? What are you thinking about with these 70-year-olds and 60-year-olds? But David's point to me was, the HIIT is prescribed individually for the patient. Now, what might be high intensity for me may be different for my patients. For many of the patients, just taking a walk can be enough to get their heart rates up to our target goals. And so that's what we were able to do, is personalize that exercise prescription for each of our patients. Thank you.
So one quick maybe question or comment, and when looking at these new technologies, which I think are really great in terms of collecting information that we need to apply patient care.
how do you see, or do you see any barriers to implementing those in terms of cost? We want to pay for those new technologies so that we can use them, in the real world setting.
Absolutely. So the question was about cost of these technologies and what are the barriers to implementation.
Yeah.
So I think there's a couple things to think about. One is there is a push in remote patient monitoring to be able to bill for these services. So right now it's mostly in the realm of, blood pressure, weight, continuous glucose monitoring, but many insurance companies do have a pathway, and Medicare and Medicaid have a pathway to monitor our patients, or to be reimbursed, I should say, to be reimbursed for monitoring our patients. Now, there's many challenges. Not all insurers will support this. In addition, a lot of the things that I was mentioning, like with temperature monitoring, for example, or looking at step count and activity, are not yet supported or reimbursable, in part because we still need to collect the data. But I think if what we can do as researchers is collect that data, we can then take that data, and if we showed evidence of improved patient outcomes, we can advocate for an insurance to cover it, and then have a pathway for sustainability in the future. I think there's already a roadmap for that.
Thanks.
And we still have some time, so I was going to ask a question to, my research is not cardiac oncology, but I do a lot of vagus nerve implant stimulation work, and we've been tracking, where you track up to 144 patients, and we've seen changes in cardiac and blood pressure effects during sleep. So I wonder, some of these effects that they're looking at during activity and during the day, has there been any thoughts or predictions that maybe changes are happening even at resting state at night, that you could actually look at other biomarkers that could be quite interesting? And I want to get thoughts on that, because we are surprised to see that. To sleep. Yeah.
No, absolutely. I mean, I think that's a great point. And looking at circadian rhythms, for example, and how circadian rhythms may impact cancer outcomes is an area of interest. I believe actually there's some RFAs from NIH and support research in that area. I think we're really at the new frontier here, where we are just getting these devices out into our patients. We're collecting all of this data. And what we need to do is to collect the data first, and then work together to analyze those results and see what kind of patterns we can take out of it. There has been a lot of new collaborations. I don't know if you guys are familiar with MIMIC, but this is an NIH-funded effort at the Bakersfield Deaconess Medical Center, where BIDMC basically took 40,000 ICU patients, de-identified their data, and made it publicly available for anybody to take a look at. And I think that's what we really need to do, is to bring this from the inpatient setting to the outpatient setting. Look at these biometric devices, collect the data to see what we can do, not just as individual researchers, but as a researcher community.
Really exciting. Please, last question.
So Courtney Campbell, Baylor Dallas, fantastic talk. Something that frequently comes into my clinic are patients that have smartwatches and they have a high resting heart rate, and they're scared to exercise, because their heart rate goes too fast. They get alerts on their watches. How are you incorporating that? Because whether it's autonomic dysfunction or something related to their treatment, it's very frequent that their resting heart rate's 95 or upward. How is that incorporated, or how do you get to that counted of your hit study?
So first off, disclaimer. So the question is how to manage high resting heart rates in our patients. First off, I should say a disclaimer. I'm on the oncology side of things, not the cardiology side of things. So many times I will defer to my cardiology colleagues. But in a practical sense, as long as the patient's heart rate is less than 100 and they're in sinus rhythm, I'm not concerned about their exercising. And for our high intensity interval training studies, as part of our baseline CPET test, not only are we personalizing their exercise prescription, but we're also making sure that there's no abnormal changes on EKG, which may warrant further investigation. And I didn't mention, but we actually did have one patient in our study. They had some concerning FTP wave abnormalities during their baseline cardiopulmonary exercise testing. We actually terminated the CPET earlier, sent to cardiology, and our cardiology colleagues self-manage their care. So from that perspective, I think, if they've got a high resting heart rate, I'm certainly willing to at least give them a shot and do the best I can, because I think they could certainly benefit from exercise. And especially, a lot of our patients have reasons for it, right? They are anemic, they might have compensatory tachycardia to help manage their status. And as long as there's no arrhythmias or anything that's concerning, we'll usually go ahead.
Well, thank you very much, Dr. Saad. Appreciate you. Wonderful talk. So as a wonderful moderator, I forgot to introduce myself. So I will say, my name is Hubert Lim. I'm the director of the Early Bakken Medical Devices Center at the University of Minnesota. And so happy to do this session here. And for our second speaker is Dr. Agi Kuma, is assistant professor at Gustav University and leads the cardio-oncology at the Medical College of Georgia. Dr. Guha's ongoing research under patronage of the American Heart Association, Department of Defense, delves deep into the translational sciences concerning biological disparities between white and black men, prostate cancer, undergoing androgen deprivation therapy. He is also trained epidemiologist from Emory University and uses that expertise as a PI at AHA-SFRA grant in disparities in cardio-oncology, where he's the population science principal investigator. Board certified in cardiology, cardio-oncology, echo, and several other cardiac imaging modalities. Today, he will present his active work on leveraging AI and natural language processing algorithms, improving clinical decision-making and care of cancer patients from cardiovasculars. So looking forward to your talk.
Thank you for the invitation. I would say that a lot of this stuff is going to be what we'll hopefully do in the future. So it's not that follow like yourself. I think it was all the origin research that you just presented. So actually, so I'm just not with taking for week's question actually. So for the SFRN, I am the cardiologist who has to supervise CPETs as a part of patients with cancer or tested before and during cancer treatment. And sometimes they are actually sequential CPETs during every 3 months, and they don't have any cancer treatment. So what we do is if somebody's heart rate's high or first times, they generally have to have all labs and everything, all right? So no, all your vitamins are correct, they're demonic. And then we would first time do an orthostatic test, like you would do table kind of thing, but much faster using the shortest protocol because, they're for being in a test. And then if that's fine, we would consider them deconditioned, and that's why the heart rate's high, and they would just, and then we personalize it. All right, so let's begin. All right, so these are the topics I want to cover. These are my disclosures from the last year, so I've been told to keep it for 2 years, so I'm good there. And then, so let's start with the Iakobishvili. Start with the case. So this is actually one of my patients from the age of study. So a 62-year-old black man presented with elevated PSA of 62. His biopsy released 4+4, 8% adenocarcinoma, plasmamegaly, significant for obesity, hypertension, who was an amyloidopathy at 25 years of smoking. After consultation with urology and radiation oncology, he had a PSMA PET scan, and he was started, and PET scan sort of showed that this patient is oligometastatic cancer. So he was started on leuprolide and venetoclax, the triplet being sort of the standard of care now. So he was subsequently seen in my clinic because that's what we would do as a part of our AHA protocol, where they would end up getting your no test. So he had chest pain during his no test. He had one maybe test of depression. And as you know, it's not an imaging test. So while you get the EKG, so it's the regular stress test in this case, treadmill one. And then he had a calcium score part of from his preventive care, which is not congruent with the statin line, but his calcium score showed calcium score 420 in his identity territory. His A1C came back at 6.56, which is standard of care by clinic. His total cholesterol was 96, LDL 126, and HDL was 34. He was started on aspirin, Rosatin, metformin, and he underwent goes to the lymph cap because of the acid depression and symptoms. He then ends up getting an stent to his LAD, and then he goes to cardiac. That's a pretty regular case. We see this all the time. This was a part of our studying. So before I talk about machine learning, let me talk a little bit about what is machine learning. Machine learning is a subset of artificial intelligence. And it's called artificial because it's not human intelligence, basically. That's why it's called artificial intelligence. And it enables the computers to learn from data, which is, again, generated over decades sometimes. And we identify patterns and make decisions with minimal human intervention. So that's in machine learning. How does it work? So unlike traditional programming, where humans define all rules, machine learning algorithms learn these rules by analyzing the data. The more data these algorithms exposed to, the better that they can predictors of decision-making tasks. So from the real life which you actually are using ML with a brain knowing, the autocomplete feature in search engines is a really good example of machine learning. And actually, refers, so if you log into your Google account and then Google something, versus if you don't log into your Google account and Google something, your autocomplete will be different because it use all the data just there available to Google from here to autocomplete your search.
So in healthcare, machine learning helps in diagnosing disease, predicting patient out, personalizing treatment plans. So in cardiology, machine learning uses various different data sources. So the mimic data, which Dr. Sum mentioned, is actually available free to use on Kaggle, which is a place where you can go and participate in various competition learning. It's available on GitHub to just download and use for projects. And it has the AKT data. So you can download the AKT data and play with it. And similarly, there's a lot of echo data, a lot of diagram images. What happens in this is an example of how deep learning works, or the images of deep learning, where the way we think is we imbibe data and it we think through the process, and the thinking is basically neurons connecting to each other. So that's how this there are layers of what is called nodes, which are called the convolutional layers. That sort of was derived by one of our brain nodes, and then once it goes through these layers, the model outputs. So this is quintessentially what a human being does. So, for example, I picked up this very famous study which was performed by colleagues at Cedars-Sinai to predict ejection fraction from any quality echocardiogram by colleagues. So the model works really well. So maybe user is happy. So in this man, which we talked about, 62-year-old, plus 4 medical history, as I said, EDT. So before we already know these risks. Like, he hasn't seen me, and many of the prostate cancer patients, I would imagine, perhaps 80 to sometimes 90% prostate cancer patients would never at this point have cardiologists unless they have a pre-existing cardiovascular condition. And second question, do we know what is absent from the above summary? So this is summary seems pretty complete. So to answer the first question, so we worked with a data set out of Case Western, where we basically did what's called extreme machine learning modeling, where every machine learning study actually has 3 components. That you take data and then you divide the data into 3 parts. The first part is training, where you use that data to train the model we talked about, whether it can be neural network in our case, XGBoost. And then the model is created needs to be tuned. So that is called hyperparameter tuning. You probably go to the details of it because of the time there. And then once you tune the model, then you use a one dot set called the validation set. So in this data set, what we did is we ordered all the possible risk factors, and we had about 45 features which are not connected to each other. So we had to check for that before. So that's called feature selection. So we did the feature selection, and then we did the feature creation. Once the features created, we put it through training, testing, and then might validation. And we come up with the top 10 predictors. And the top 10 predictors have the highest scores called SHAT scores. And then we compared, we made a logistic regression model like the full cohort equation, and that predicted 10-year outcomes. So that's the calculator that uses all these variables, body mass index, systolic blood pressure. I'd like to point out that we have number of household members in this calculator. So we have determinants of health available in our features. And as a part of my research, all this try to include it anyways. So this patient, which we talked about, his numbers in, and his risk is 33.8, obviously much higher than what the full cohort equation could predict. And it would have been a given that, his calcium score was 420 and all that. So this kind of makes sense. He already had an SCD. So we did validate it on the radical PC1 cohort. We all are pretty aware of radical PC1. I wish Daryl was here. But we were able to validate it for 2 years because that's what the follow-up was really good. We couldn't do a whole 10-year follow-up in radical PC1. And we decided to call it calculator after me and the student who made it. So that's why I couldn't even must have the calculator. The tongue-in-cheek thing which we always joke about all the time. So that AUC was actually pretty decent, even in the validation cohort. And external validation cohort, obviously. The internal validation cohort, the AUC is actually always very good. So you always want to validate your data in external validation cohort. Good sensitivity, reasonable specificity. And then subsequently, we actually validated this score against the data. Right? So we validated it with the new PREVENT score, which the AG came up with, and it actually performs equally well. So we're quickly moving on to the next topic of machine learning, which is natural language processing. So natural language processing, it enables machines to process human language. It automates the analysis of unstructured data just there in our charts because we write notes all the time and we have echo reports, PG reports, and such.
So it automates the analysis of this from the electronic health records and converts it to actually insights. The application of it is to basically get medical details from clinical documents and any other source of actually which has English or any other language for that matter. It relies on understanding language rules, usage context, and in the example illustrates potential gains. So this is actually a theme I've worked on with the Inetron, which is it's sort of the largest natural language processing model which exists on this side of the world in University of Florida, which they work with NVIDIA. So it's a huge data farm, as I think about 5.1 billion lines of data, which it was able to go through, and it's actually pretty good and performs better than ChatGPT's LLM model for medical AI for medical natural processing. But this is how the natural language processing looks like, and it comes to how we deal with it. So we have the data source, so which is all the lab works, the medical notes. The ingestion happens at the local site or the lab, and then we store it. The data preparation happens with CVs like Gatortron, and then there are various models people use. Gatortron is sort of has all of those buzzwords as a model, and it's also publicly available on and Kaggle to utilize for people to use. And then the analysis is what we use for research. So this patient ended up having an echocardiogram, he had an EKG, and he had a cardiac MRI, which was a part of his care. Not going to read it to it, but to answer the two questions. So even before we saw him, did we know his risk? And answer is yes. So we used that calculator. It had everything one would need with 4 SOMIAs. ASCVD score was as high as 33, and he had ASCVD. So obviously, it was really less individual for the real patient nonetheless. And do we know what is absent from the above summary here? What was absent is the MRI findings of slight RV ejection fraction reduction, wall motion irregularities were overlooked by standard oncologists because they wouldn't look at that. And then the cardiac and cardiovascular monitoring, because we get so many images that it's data overload, and how NLP will help us is it would flag us by capturing and analyzing his clinical data. So he actually, after consultation with both urologists and oncologists, he had a PSA effect. He pursued treatment, as I said, and then subsequently we saw what happened. But then what was hidden in the data which he had subsequently? And then how can we use that? So this is what he got. So this is PSA PET. The PET part I'm not showing. I'm showing the correction CT scanner. The correction CT scan is a full body CT scanner. So sort of, just sort of playing a CT scan for radiologists in the audience if they're this would be pretty regular life for you. But what we see is we have the skeletal muscle, which we can easily locate because it's like right there in the view. We have classification of the coronaries, which was very obvious in the PSA and CT, the CT part of it. And then you have classifications of abdominal arteries. Why is it important? So this is actually, I should update this slide because this paper just came out in Oncology. This was data which was presented in ESC 2023 and subsequently now published in Jeopardy Oncology, where what we showed is when your skeletal muscle strength goes down after 12 months of androgen deprivation therapy in patients with prostate cancer, which it did. So the reduction was 19.2% in patients with ADT versus no ADT with a reduction of 13%. There's a difference for each quartile of reduction of strength. It's adjusted as the ratio was 1.22% increase in cardiovascular events and mortality. So this is a study where researchers were able to automate CT radiomics to identify skeletal muscle and look for sarcopenia, which is an important topic of discussion, which I think Tara and I actually were talking about how you're studying framing and the R1, which you talked about. I know there's a community report about on phrase is an important thing in geriatrics now. And this CT radiomics protocol can automate finding framing patients by looking at their skeletal muscle. And it's what they showed in this study of much more significant cancers, such as gastric cancer, cancer, is subsequently following patients using radiomic-based skeletal muscle showed significant predictive capability of sarcopenia in patients with cancers underway, but stops chemotherapy or cardiovascular. This is a study which looked at the aortoiliac atherosclerosis block in prostate cancer patients. So we saw that in the case of that CT.
And this study evaluated the link between iliac sclerosis and prostate cancer in treated patients. There was no notable connection with PSA, but the Addison score of abdominal fat showed good correlation with patients' age and tracking of risk score. This is another study. It was published in European Heart Journal, where colleagues from Europe looked at the prognostic of coronary artery calcification in patients with immunodiagnosed prostate cancer. I'm not going to read this out because the evidence will be obvious that if you have high calcium or you have more MACE, which is what they found. So a little bit about deep learning. So deep learning is the next part of artificial intelligence, which we talked about a little bit when we talked about convolutional neural network. But it mimics the human brain, as I said. It teaches computers autonomous decision making. Example of it being, pictures of cats and dogs differentiated by Google Images. The application is to sort of spot diseases, to spot diseases in the soil. I said the not use exactly because FDA has approved that algorithm to be used, but it also cardiac CTs. And then efficiency workflow, because it automates some of these algorithms, it cuts diagnosis time and flags disease again in our audience and enhances patient care. This is actually, again, from the same region as the biggest from. This is a deep learning application course called AI CACs. So the MIT designed this. Again, a complete DIY, you could use it in your institution. It goes from data to outcomes, and then it's very easy to use. They validated it. They created a cohort that validated in propagats and promise and various other studies which use CT scanning. So what data was hidden? So we did not use the data hidden in the PSMA plus CT, as it was used only for attenuation correction. How can we use this data? We can build deep learning algorithms to identify calcium score and abdominal artery calcification to predict ASCVD risk in patients at risk of obstructive CAD. We can track 3D skeletal muscles, and we now have data on why skeletal muscle imaging is important in patients with prostate cancer for rats and all cancers, which is a marker of CVD in prostate cancer. So in summary, AI can improve the care of cancer patients from cardiovascular standpoint. The stratification is possible with RTM testing, looking for calcium score abdominal calcification, directly using NLP and deep learning. So I can show a quick example of implementation. So that man who was referred to for cardiac evaluation with fatigue and dyspnea, his examination reveals NOH class 1 symptoms. These are lab, read it again, it's PTR, see beta MOIC. But all patients with heart failure symptoms get detailed biomarker panels with reflex too. So this is one of the implementation. All heart failure patients basically think about automatically get proteomics. And if there's suspicion of, if they have suspicion of amyloid, this is based on these two papers. Again, not go into details, but they talk very well about how proteomics can be implemented at the site of clinic. Then it has an EKG. The ATTR EKG algorithm, which is now the approach of Mayo Clinic, has one, and police at Yale lab and FDA approved algorithm, where you can look at an EKG and say what is the risk of having ATTR amyloidosis. And then he undergoes an echocardiogram. This is David Point's work, where it can actually look at the echo, and I think there's a company called Echocardiograms, which had a clinical trial at ESC this year, which is able to very well identify amyloidosis, and they don't need to have cherry on top of periods on that. It's pretty good even without that. So this patient's EF was 53% states that his chain pattern was flat. It's all automated. This way implementing it right now. So echo and AI for amyloid can do automated LBEFs as well in the echocardiogram. These are the studies which talk about it. So we can start leaving these studies and actual implementation. You can automate LEFs and identify potential amyloidosis analysis. These are papers which talk about that. His blood was obtained as a part of the proteomics, and now trial result by default because that's what we're implementing. And then he signed a genetic consent because all patients coming into cancer center should get a referral group. His genetic testing by reflex showed the mutation which you're all aware of. And his automated EHR algorithm was triggered by his EKG F1 genetic test to propose a PYK scan, which you just had to sign. You signed it was positive, and then the EHR using natural language processing told the coordinator who oversees the Budisiran trial, which is completed now, that he's a candidate for the trial. So he's randomized within 20 days of first visit. This never happens in real life, but this can happen if you want it to. But all these technologies happen presently by itself. So this will be an implementation of something which all of it's already exists. Just together in the line. So in summary, everything about patient data. Early adopters will be able to use AI to identify risks in our cardiac quality patients.
Rapid clear using DHR merged with latest 501K pathway breakthrough technologies by Valvular and LP. Deep learning will improve quality of care and reduce burnout by timely wellness for patients and conditions. Thank you.
Thank you for that wonderful talk, the very last talk. We have time for 2 minutes for question. But while we're waiting there, I have one question. For the practicality of implementing NLP AI deep learning, what kind of, like, how many patient data had to go in to be able to do those predictions? Just as a scale, yeah.
Like technology approval means they will that.
Yeah.
So the way that technology structure works is it's actually very well together on the Mio worked with a company called Dogma. It is one of the companies implementing the AI PR. So you see how the backend works. By taking itself, start using clinical based on enough data, which led to that paper. It was a Nature edited paper. And then once you start implementing it, you have to have a validation which happens a few years later. So it gives you time, but can let the technology be out for commercial use. But the actually validated a large data set. So the Myocarditis algorithm was the AI thinking algorithm validated over millions of data sets, but the ATTR data set published smaller. But Myo is a center of excellence, great ATTR, right? So they did have a lot of any number of which other bases. Similarly here, similar structure of the only difference was AI uses people EKGs. So they have been learning a lot from there. That Myo did, which they use other data as well. So it was a new EKG format where the EKG can be broken down sort of electric arc. So the feature selection is the leader.
I see. Great. Can we do one question? Oh, sorry, you have a question. All right,
I think it's repeat that. We talked earlier in this session, right? Social determinants of health, and Dr. Tiffany Wiley was here. And my understanding about machine learning is it's only as good as the data that you put into it.
Yes.
So how do you suggest that, or as we work moving forward, I mean, obviously this is happening, but if that's really the case, how do we incorporate some of the other things we're talking about, social determinants of health, disparities into these calculators?
No, an excellent question about how disparities play a role in this. It actually is a very important role. There are sort of two components to it: the ethical use of AI as to how we use data that we get and how we end up using it for patient care, no matter who the patient is, and if the algorithm was developed for them. And then the second part is people who never have data collected, because our patients who live in rural Georgia who use the phones, they're not having any data collected because they will be connected where they will be connected to it. So what do we do with that? So again, I'm going back to the same company. I'm trying to work with that company to see if they would, at no cost or low cost, do their trial or study our side, where the number of patients we see in terms of rates are predominantly Black patients, and both the algorithms in Lyon and Yale are done with predominantly white population. So if they did that, validated it, and got the same results, it would show that it works in populations which are quote unquote underserved or at least over different rates. So I think we can start there in a practical manner. But I think what I liked about sort of work which I was able to do is we were able to actually include social determinants of health as features. So that for deep learning environments, it's a little harder to include those features, but that's where sort of I work with colleagues much smarter than we were able to use multimodality feature creation and merger. So what basically happens is we get features from deep learning data like a CT scan, then we get social determinants of health from another source and then merge it together to create one data set and then make it available only could do.
Okay, so I really enjoyed this. And my question is regarding your false positive, false negatives, of how you deal with those in an automated system like that, where if you see the patient in real life, you make a decision. While if you use an automated system like this, maybe you get the patient that they didn't want to get it, the ignores further. Well, what about the, let's say, checks and balances there?
So sort of going to try to answer this in a different way. So, when we treat patients and a primary care doctor gets a full cohort equation because it's a dot phrasing ethic, if they got a full cohort equation at got a lower risk, a cancer patient who's likely to be a higher risk patient because of vascular aging, which we just heard about. They will likely not get a statin if their number is minus 7.5 at 10 years, right? So the thing is, if you get a higher number, the time to statin gets faster. So that's sort of my thought about it. Now, what is the? It's sort of it's one of those drugs where there's, unless you have severe liver dysfunction, there's almost no harm. Like there's the same drug to give. So I think the way I look at it is, if I am finding somebody with a risk high enough to start a statin in whatever way, then it probably downstream is going to benefit them. And most of our studies, even where we're looking at endpoints such as liver dysfunction, we see either with removal or with itself. So the ability to harm is quite cool. Thank you.
Thank you very much. And with that, we'll close the session. And I'm going to invite Dr. Konety as well as Dr. Singh and Dr. George Nel to come up and tell us about next year's meeting. I don't know about you guys, but my brain is spinning, which is always really fun. Lots of ideas, lots of really good conversation and discussion as we've gone through the meeting. And thank you to all of you for staying around during the whole course of the meeting. It's really been great. I think we all want to continue to thank our sponsors and thank you for interacting with them. And I owe our team here at the Masonic Cancer Center and the Lily Heart Institute a humongous round of applause for all of the work that they've done. Thank you all for being here. And without you all, I don't think this would have been possible. A big shout out to Lisa Martinez and her crew. You are awesome. I need to put up mics. Well, everybody, audience and speakers, moderators, sponsors, to the University of Minnesota, Masonic Cancer Center in particular. But there's a sigh of relief at the end, and we would love to pass the baton on to the next sports team. So,
indeed, thank you very much, Suma, Konety, and Blaes, for a fantastic 3 days. What a fantastic show you put on. We come to a stage now where we, as you say, you've passed the baton. You've passed the Olympic flame. It's now our responsibility to emulate you next year. So I'm Trishun Singh. I'm the president of COSOSA, which is Cardio-Oncology Society of Southern Africa. It is the first such cardio-oncology society in the Southern Hemisphere of Africa. And introduce George Nel, who is our CEO of our COSOSA. So this part is the easy part of conference. It's really to tell you about next year, to try and encourage you to visit our country. It's the first GCOS meeting that will be held on the African continent. So I will deal with just the first part very quickly. I know you're already tired, and then I'll pass the mic on to George Nel, who will tell you a little more. But most important is I will give you the nitty-gritty of how to get there, the costing, and in fact how really cheap it is to come to South Africa. Okay, so GCOS will be held in Cape Town, South Africa next year. It is the same thing. It will be held over 3 days from October 29th, 30th, and the 1st of November. So it'll be a Thursday, the very last week of October, Thursday, Friday, and Saturday. The theme of GCOS Africa next year is based on the Big Five, which is really the Big Five animals that you've heard of from our safari parks in South Africa. And as you see there, it's the buffalo, the rhino, the lion, the leopard, and the elephant. And the reason we chose this theme is because it's based on the big 5 themes of cardio-oncology, which is what I'm going to tell you about. So Cape Town is one of the most beautiful cities on the African continent, in fact, one of the most beautiful cities in the world. It has been consistently rated the #1 convention destination in Africa. And it is, in fact, one of the most attractive destinations in the world. It is based or located at the tip of Africa. So, if you think of the African continent, you have the Atlantic Ocean on the left, and you've got the Indian Ocean on the right. In fact, at the tip, that sea point, in fact, is where the 2 oceans meet. It's also beautiful from the point of view that it has the most beautiful mountains, which you see in the background, and you have the ocean in the front. So, if you go back in history, South Africa was first founded by Jan van Riebeeck in 1650. So that is why we have the Dutch origin of South Africa. So our language, initially Afrikaans, is very much allied to the Dutch language, then occupied by the English. And then, of course, subsequently, we had the Indian population came in 1816. My great forefathers came in as slaves in 1816 because we came to cut the cane, because the English were occupying India at the time, and they realized Indian workers were very good workers, especially cotton cane. So that's how we came. So in a way, I'm thankful to my great forefathers for getting to South Africa. And I'll tell you something, when I go to India, I'm recognized as a foreigner very quickly, because I'm 5th, 6th generation Indian. So the next slide, you will see what it's based on, and you're going to hear the music. It's a song called "A Symbol Kolkata," and it was a song by Johnny Clegg, who we consider a white Zulu. He embraced the African language, he embraced the African culture, and he formed a band called Sabuka. And in 1987, he came about with the song called Asimbi Bongana, which means we have not seen him. And who he refers to is Mandela. He refers to Nelson Mandela in 1987 when he was still in Robben Island. And the song is about we have not seen him. And I would like to just play a bit of the song, not the whole song, because it has great meaning.
This is a song that we wrote for truly one of the greatest South Africans in history, Nelson Mandela, and we'd like to open the show tonight with the tribute to him. I see and I sing one of them. That's one. I'm feeling okay. I'm feeling that's right.
So this song was devised in 1987. The history of the song is that Mandela was still in prison, and we still had the old apartheid regime. This song was banned in 1987. And what you see there is Johnny Clegg singing the song in Frankfurt in 1999. And little did he know that Mandela was in the audience in Frankfurt. And what you see there is Mandela actually coming up very quietly on the stage behind Johnny Clegg. And the crowd went wild. And Johnny Clegg thought that, in fact, a lot of the people knew the song. So that's the basis of that song. So Cape Town, and I really hope all of you are going to be there, has a very rich heritage. All of you know that it was where the first heart transplant took place in 1967 by the famous Chris Barnard, who you see on the left. And the first transplant was a transplant of a heart from a lady called Duval, and transplanted into a dentist called the recipient, Louis Washkansky, who was a dentist. Now, why this first transplant was really fascinating. Remember, 1967 was the height of apartheid. So Duval was a colored woman, and Washkansky was a white man. And this was the beauty of the first heart transplant. You know, the heart of a black woman being transplanted into white man at a time when we had, which was the most horrible time of our history. So it was quite an embarrassment for our government. So when you do come to Cape Town, we hope that you will visit the University of Cape Town, which is world-renowned for many reasons, not just for the heart transplant, but for its level of education and for its level of medicine and its law and all the other faculties. And in fact, many of you here would be working with South Africans wherever you come from, because we ended up exporting our doctors to all parts of the world. And as you know, they all do very well wherever they go. But the level of training has been pretty good. So we have at the University of Cape Town the museum of the first heart transplanted. It is designed such that it has exactly the people. It's with Stephen's of the actual table, the people, and how that theater was designed during the first transplant in 1967. And the picture you see on the top is Mandela in 1994 casting his first vote for the new democracy in 1994. And when you do visit Cape Town, we hope that you would have time to visit Robben Island, which is not far. There are many boats that take you to Robben Island, and you will see where he was incarcerated for 27 years. So this year is now 30 years of our democracy. And then I must say this, that, you know, we've come through a terrible time in the history of world of apartheid. But when you heard Johnny Clegg's song and the way he embraced different cultures, we have come through a period where we had divisions. And I firmly believe that we have learned, because our apartheid was exposed very early. So we've learned to live with each other. And we have tried very hard. It's not easy. We have tried. But I can tell you, when I look at TV now, and I get glued to see what's happening in America, I really get disappointed. Because, you know, what has happened is it was suppressed. And divisions were suppressed, but you've got a long way to embrace each other. We've been there, we've tried it, and I really hope that you do embrace everybody as you want. So, the Western Cape experience is really vast and great. You have, on the one side, you've got the ocean. We are world famous for our wine farms. So we have, behind the mountains, we have the vineyards, some of the greatest wines in the world. So you're going to be at a center where it's not far from visiting the wonderful wine farms, which many of you here have been to South Africa during our last few conferences. We have wonderful oceans. What you see there is the Huguenot Museum in Ferencik. Ferencik is actually a very, very famous a world famous wine district, and it is also the home of the Huguenots. And the Huguenots came in as persecuted people from Holland and Europe early in the 1600s, and they realized, wow, this is a fantastic place to grow grapes. So this is why they established the wine farms in Franschhoek. And Franschhoek also has the Huguenot Museum, which I hope many of you will visit. Other than the Cape Wild Coast, with its whales and many other features, we have the Cape, the Cape route, the Nice, the forests, and so on and so on. So my part of part of my talk is to introduce you to the committee. Many of you will recognize we have both the local committee and the international community. The local committee comprised myself, Ria David, a medical oncologist, Professor Andrew Salkin, a cardiologist from Pretoria University, Professor Geeta Naidu, who is a pediatric oncologist, Professor Sandrine Lacour from the Hatter Institute, and Dr. Ronwin van Eden from who is a medical oncologist. The international faculty, again, you recognize Professor Susan Dent, Alex Lyon, Teresa Lopez, Mike Fradley, and Addison Fellow. On the right-hand side, the Hatter Institute, by the way, is the institute that still exists in London. It's part of the London University, UCL. It is run by two good friends, Derek Yellen and Arjun Ghosh. Where's Arjun? Is he still here? There's Arjun. So he's from the Hatter Institute. The Hatter Institute was started by Derek Yellen, who Arjun works with, ex-South African, not Arjun, but Derek Yellen. And they combined a meeting called the Cardiology at the Limits many, many years ago. It still runs. And it was started by Terry Allen and the late Professor Manuel Opie. And many of you may have read his book on cardiology, drugs in cardiology, which he wrote with Bernie Gersh. The Institute still run, they are doing fantastic work. The Institute in South Africa is not called the Hatter Institute anymore, it's called the Cape Harbour Institute, but it's still the same. And Sandrine Lacour is in charge of the Cape Harbour Institute. The Thursday of the meeting is going to start off the meeting with the basic science, which I think Arjun, you're going to be putting together. If you don't know, I'm telling you now, together with Sandrine Lacour. So the conference will start on Thursday at the Hatter Institute, and the main meeting on Friday and Saturday will be at the conference center, which George will tell you about. So this is the Hatter Institute, which is very close to the University of Cape Town. So if you do come to the meeting on a Thursday, you'll have the chance of visiting the University of Cape Town, the medical school, the place where the first transplant took place, and of course attend the conference. The big five themes, as I said, of the conference comprise the famous big five animals of our country: the lion, the leopard, the elephant, the buffalo, and the rhino. And the themes are based on the baseline assessment or risk of cardio-oncology, surveillance and prevention, optimal treatment, survivorship, and service delivery. So essentially, the theme of our conference is based on our big five. And I can tell you, we got to really put on a huge, big show. And I think you're going to be very proud. We're going to be very proud of us. And hopefully you will all come in your big numbers. And as you would say, make Africa great again. Thank you very much, Dr. Singh. Appreciate it. I think he's done an excellent job, so it probably would be a good time to actually conclude our presentation. But I've got the benefit today of doing a bit on the Cape Town side of things. So why Cape Town conferencing and obviously why Cape Town? So if you look at the slide here on the left side, top left, you'll see the convention center will be housed. So it's really close to the center of town. Total Mountain literally is going to be on the side there, international airport, so the access is quite close, and the VNA waterfront. So within kilometers from where we are, you basically have the opportunity to consider the mountain, of course, standard martial arts, one route that's available, and you could do some wild watching and even great shot diving, which Stephen apparently said he's going to do with his tail. And you could do big size safari as well within a few hundred kilometers from where we are there. So there's definitely the multi of waste influence and Cape Town and South Africa. To reach South Africa or Cape Town specifically from most major cities these days, you can fly directly to Cape Town. It's normally overnight flights, so you depart in the evening and you arrive the next morning. And it depends on the class you're flying, but you can reach Cape Town for a less than $250. So it can be quite a cost-effective trip to get down to Cape Town. We'll be hosting the conference at the Century City Convention Center and hotel, so which is very centrally located within what we call the mother city of South Africa. So once again, just to reflect, it is a pricing development for conferencing, so it's got all the amenities needed. There's accommodation in different price ranges, and once again, the convention center, which is quite a modern hotel, and it's available at about $150 per day. So that's quite affordable. And then the center itself is well developed to accommodate delegates, and obviously with very good audiovisual equipment, and there'll be a exhibition center where now industry partners can obviously network and where we can engage with each other. Safety and security is a high priority, of course, as in any global city these days. So 24/7 surveillance, video monitoring is available in the precinct, and even within the greater Cape Town area. But obviously, as with any traveling, when you are traveling, you need to be vigilant ultimately and be careful where you go. So just a little bit of a summary once again on the convention center. It's really well situated. There's a lot of different types of hotels and accommodation needed. Even for Airbnb type scenarios is available. And then within walking distance, there's Joe's. There's a huge mall if you need to buy Airbnb. So it's really well situated if you know what to travel into Tower, for instance. So for the rest, I'm just going to play a short video, just giving you a bit of a flavor for Cape Town. The city bowl from Lyon's head, running with the rising sun, kissed the contours of Table Mountain, the beautiful Robben Island, the dwelling in us pride, our open feels a lamp of emotion and innocence. Flashing off waves that meet us and these shores of vibrant cafe life that your coffee is poured. Fiji tells a story. Paint worships concrete. The old despicable and the congregation of bustling feet. The rainbow of work card indulges where the lady County Spice follows and verses with the aid of local advice. Remember the start when you felt younger heart, the joy of the good old days and the way of the magic scheme. Yet tongue to us as wine into anticipation through every destination. Something down why whatever it was is legendary as you stream down our center. The lush green of cursed marsh gardens where Mother Nature is in all ways near. Loveliness is a point where connection is found, then disappear. Fingertips through fashion, creative genius marries passion, the wool on those ladies. Almost of long boards in the open wars. Find meaning as marvelous ones.
Streets breathe pine peas and third lines. Stadium dreams, but orange shoes that ignite spontaneous smiles. A tight smile, essential in a child. Jake dance feels like, oh, don't invite you to stay a while.
Baby. So that doesn't convince you to go to KBL. I don't know what will. Congratulations, guys, with an amazing presentation. So thank you for those of you who were able to stay till the very end. You see their smiling faces. Congratulations on an amazing keynote. I think I would say you realize now how much phenomenal effort this goes into hosting this meeting. And I have to remind you, this is all done on a volunteer basis, right? So it'll be a incredible amount of work. So congratulations. Let's over to my left, where you come on stage, because without you, this meeting doesn't happen. So you've been incredible, all the meetings that we've had over the last year or more, arranging all of the hotel rooms, all the meetings. ICOS to speak about the gathering. Thank And I just really hope you do make it to King Tower next year in South Africa. So thank you, everyone. And thank you for coming to this great meeting. Hope to see you next year.